on the second day of the academic extravaganza. After the power-packed direct section of the study delivered by Dr. Matthew Varghese sir, Dr. Vikas Gupta and our own faculties, we are simply daring to unroll the events of the today. Today's events would be subdivided into 5 sessions. Leaflets are reviewed, and I heartily, respectively, I welcome to Dr. V.K. Jain sir, Professor, and Dr. Professor Atul sir for chairing this session. Please, sir.
Good morning. I welcome you all to this interesting CME. And the first topic is very common fracture we all face among pediatric age group is supracondylar humerus fracture. To begin the proceedings, I would call Dr. Abhishek Saha to come up and has his words on supracondylar humerus fractures in children, how to avoid missing the diagnosis.
Good morning, everybody, respected seniors. It's an honor to be in AIIMS Bhopal on your invitation for presentation of this topic. And before I start the presentation, I would like to stress on what exactly we are trying to achieve over here. Main thing that we need to do is we have tried to keep the talk as crisp as possible because the talks are mainly targeted towards our postgraduate students and senior residents and people who are into the general practice of orthopedics. So I'll start with the initial introduction. We all know that supracondylar fractures roughly account for 60 to 70% of elbow fractures in children. There's a high risk of neurovascular injury and compartment syndrome, and that is why it is imperative not to miss the diagnosis in these cases. There is a varied clinical grades, and the differential diagnosis of this fracture, if I go into the details, the differential diagnosis is lateral condyle fracture, elbow dislocation, and transfacial separation. I've mainly pointed out all these 3 fractures mainly because these are the commonest fractures which are missed with supracondylar fracture. Now, just to put in the fracture, you all must have seen supracondylar fractures in your practice. The lateral condyle fracture, make it a point that it is mainly the tenderness on the lateral side, which is diagnostic of a lateral condyle fracture, as well as the swelling in a supracondylar fracture is far more than what we see in a lateral condyle fracture. Elbow dislocation is very rare. So when you get a supracondylar fracture or you are suspecting an elbow, or technically when you get an elbow injury in a child, don't think about elbow dislocation first of all. You should think about a supracondylar fracture. Coming to transfacial separation, this is again common in the younger age group. That is roughly 1 to 3 years of age, or in the neonate, or in the neonatal age group, less than 1 year of age. So these are the 3 things. We have started with the differential diagnosis, just to put in your mind that imagine that the patient has come to you. These are the 3 things which should be in your mind. But since I've already mentioned the supracondylar fracture is the most common fracture. So when a child comes to you with a elbow injury, the first diagnosis in your mind should be supracondylar fracture, not only because it is the commonest fracture, but also because the complications of a supracondylar fracture or the damage which a supracondylar fracture can do is far more serious than all the other fractures mentioned here, except for elbow dislocation. You all have gone through this image in our textbook. When the patient is presenting to you, these are the commonest images that we have. This is the X-ray. This is the skin condition, though it is present in severely displaced fracture like the X-ray. I have kept the X-ray by side over here just to impress on you that such kind of skin puckering or such kind of skin damage or the AIIMS that we see is normally seen in this type of highly displaced fractures. And we all know about the S deformity or the deformity in which it becomes very apparent. So these are the three images which should be in your mind when a patient with an elbow injury comes to you and when we are suspecting a supracondylar fracture. Now, age-wise diagnostic point, the spectrum is quite varied. It is pretty obvious to near impossible. There are the grade 1 supracondylar fracture according to Gartland classification. We have got we have got patients who have been missed initially, and then the fracture went on to displace, and the complications happened at a later date, which is technically a big problem for us. Lesser the age, more difficulties are encountered. And once the child is of 3 to 4 years of age, we should make a persistent effort to diagnose it clinically by examining the patient. So the fat pad signs I'll be elaborating in some time, and the 2-point sensory and dilated motor inspection should also be included in the diagnosis, because these fractures are associated with nerve injuries and vascular injuries. Now, 1 to 3 years, the uncooperative child roughly increase the diagnosis, but we should rely on our clinical skills, tenderness around the elbow, as well as the various, we should try to take the history from the parents. Transfacial separation should be in our mind, as I mentioned in my first slide, that transfacial separation, which mimics supracondylar fracture, which is commonly misdiagnosed as a supracondylar fracture, should be in mind. The treatment of a transfacial separation is a little bit different from that of the supracondylar fracture. Child abuse, yes, we should also take note of that in this age group, because most of the time this type of injuries happen because of fall, either because of neglect from the parent or because of the child falling from the lap of the parent. Infections, yes, this is another important differential diagnosis. We have to keep this in mind as well, because septic arthritis of the elbow is also a differential diagnosis in this age group. And we normally encounter the septic arthritis of the elbow in this age group more commonly than beyond the 3 years of age. Coming to the fat pad sign. So we are going step by step. First of all, we try to create a mental impression that what to look for without going into the X-ray and the other details. Now the diagnosis, or how not to miss the diagnosis, will be totally focused on the radiological signs, because that is the main investigation which you have in your hand when the patient presents to you in the emergency. So there's the fat pad signs. Now, the main thing in the fat pad sign is the anterior fat pad might be present, or the anterior fat pad sign might be present in even a normal patient. That is one thing which you should keep in mind. The anterior fat pad sign is not a diagnostic feature of a elbow injury or a supracondylar fracture, provided it is not well pronounced like what you can see over here. The main is the posterior fat pad sign. In case of elbow injuries, you will always get a very prominent posterior fat pad sign. This is the thing which you should look in a supracondylar fracture. So here you can see that the anterior fat pad sign is also visible, as well as you can see the posterior fat pad sign also to be present. So this is pathognomonic of a elbow injury, most likely to be a type 1 supracondylar fracture, if there is no fracture line visible. This is one of my cases. As you can see over here, the AP X-ray does not look much sinister. But in the lateral view, you can make out that the fat pad sign, both the sides is prominently, and you also have a small chip over here. Had the chip not been there, it would have been a little bit more difficult to diagnose this fracture as a type 1. I'll not go into the treatment and other part of it. I've kept it for Dr. Faisal will be presenting that when he starts the CRPP, so I've kept it for him. But these things are normally treated with bracing. Coming to the, according to me, the most important diagnostic point or the most important diagnostic criteria in supracondylar fracture, which is the anterior humeral line. Now, as you can see, the anterior humeral line over here should transverse the middle 1/3 of the capitulum. Less than 4 years, it can be a little bit more anterior, a little bit more posterior. But after the age of 4, roughly, it becomes very diagnostic feature, which is technically it should pass through the middle 1/3 of the capitulum in this age group. So this is the first case. Now, in this case, we can see that if we have a look over here in the lateral X-ray, we can see that the anterior humeral line is not passing through the capitulum at all. So this is an extension type of injury. The anterior humeral line not only helps us in diagnosing the commonest variety of supracondylar fracture, which is the extension type. Here you can make out that we have the flexion type of supracondylar injury. It's a little bit older child. We can see the majority part of the capitulum going a little bit more anterior. So it helps us in diagnosing that fracture as well. I've intentionally omitted the operative pictures. We did put some, after reducing it, we did put some data. This was the final image that we got. The other angle also helps in diagnosis, which is the Bowman's angle and the ulnohumeral angle. Now, the Bowman's angle has got a far more important role in the treatment. Once we have fixed the fracture, then the Bowman's angle is far more important because we always try to restore the Bowman's angle post-fixation, but it also helps us in the diagnosis. So this is now coming to some of the cases. We have the low supracondylar fractures. This is again a young age group, roughly around 2.5 to 3 years. We have the displacement, which we could see over here. So kindly appreciate that here the Bowman's angle is totally disrupted. It's a little older case. Again, we can see over here that there's overwriting of the fragments and the Bowman's angle is totally disrupted. So this is actually a way to diagnose the fracture, because in a way, if you have a proper understanding of the Bowman's angle, then you can definitely assess the
Sir, would you please sum up fast in 1 minute?
Sure. So this is again, Bowman's angle was restored, so we continued with the conservative management. And the grossly displaced fracture, which we see in in the cases, again the Bowman's angle is disrupted. Treatment also becomes easier with these parameters in mind. Other imaging modalities that we have, roughly the oblique views, I would discourage that because you will displace the fracture even more if you try to take an oblique view. A lot of the people, they suggest that you should take an oblique view just to assess in the absence of an MRI or a CT scan. MRI, yes, sometimes in type of fractures like the flexion type of deformity that I showed, it is essential to have a fracture to get an MRI just to assess, and also in case of when we are suspecting a neurovascular injury, then to assess the vascularity, it might be essential to get an MRI. CT scan is absolutely not indicated, and angiography and Doppler for assessing the vascularity is indicated case by case basis. Open fractures are also there, and I think these things are very obvious rather than talking about it, because we can easily see the amount of displacement and these are open fracture again in case. So I'll hand over the mic to Dr. present now.
Thank
Thank
you,
you so
Dr.
much.
Shah. You have nicely stressed on pet signs and diagnosing supracondylar fracture humerus, occult fractures. Now I would invite Dr. Faisal for close reduction and percutaneous spinning in such fractures. How does he do? Dr. Faisal to kindly stick to time.
Honorable Director, sir, respected Head of Department, my seniors and my dear colleagues, a very good morning to all of you. Today I'll be speaking on the close reduction and percutaneous spinning for fracture supracondylar humerus. How do I do it? So before moving to the main topic, I'd like to give a brief introduction about fracture supracondylar humerus, which is the most common elbow fractures in children, and most commonly it occurs in 5 to 7 years of age. Extension type, the mechanism of injury is fall on outstretched hand, and flexion type, direct blow to the elbow occurs and it leads to flexion type of injuries. So moving on to the pediatric supracondylar humerus fractures, which is the most common surgical pediatric fracture, which frequently requires surgical treatment to avoid complications. And displaced fractures are unstable and they require reduction and stabilization to heal in appropriate ligament alignment. So broadly, it has been divided into two major types. First being the extension, which is the most common, and it is around 95 to 98%. And the flexion type is uncommon, which occurs in 2 to 4%. It has been divided into Gartland classification, type 1 being undisplaced, which is treated by just simple immobilization, and a long arm cast is given for 3 to 4 weeks. Type 2, there is sagittal angulation, but the posterior hinge is intact, and it can be diagnosed by the anterior humeral line, which has been mentioned by my colleague. Type 3 is complete posterior displacement. There is loss of posterior hinge, and in type 4, there is instability in extension and flexion, and there is disruption of the periosteal sleeve. So this is a tubular representation of the basic treatment, which is done according to the type. In type 1, the type 1 only long arm cast is required for 3 to 4 weeks. In type 2, coronal, if there is coronal or rotational angulation, then it is type 2B and CRPP is required. And in type 2A, if the anterior humeral line intersects the capitulum, a long arm cast is applied for 3 to 4 weeks and the patient is kept on close follow-up. And if the anterior humeral line does not intersect the capitulum, the patient is kept on a close follow-up. And later on, if the displacement occurs, again close reduction and percutaneous spinning will be required. And in type 3 and flexion type, close reduction or open reduction is required. So the timing of operative treatment basically depends upon the fracture pattern and the displacement, the distal neurovascular status, neurologic function distal to the fracture, the soft tissue swelling, and any associated fractures. Type 2s can be safely treated as outpatients in a delayed manner, and type 3 should be admitted for monitoring if the surgery is delayed. So now moving on to the main topic, which is the close reduction and percutaneous spinning technique. First of all, the OR setup should be suffice. There should be a proper C-arm or an arm board, and inversion of the C-arm should be avoided as it increases the radiation doses, and the patient has to be placed over a lead apron. So starting with the close reduction, the first step is longitudinal traction is given to re-establish the length with or without the milking maneuver, and then sequentially rotation and coronal plane correction and the sagittal plane correction is done, which I'll be discussing in the later slides in detail. So this is this sign is called as the brachialis sign, which occurs due to the impingement of brachialis muscle over the proximal fragment of the supracondylar humerus fracture, and post reduction it disappears. So there is a rule of thumb in which the thumb points in the direction of initial displacement of the distal segment. So some papers say that if the displacement is posteromedial, the forearm should be kept in pronation In pronation, it tightens the medial soft tissue sleeve, and the vice versa is for the posterolateral fragment. In difficult type of closed reductions, the elbow should be kept stable and the C-arm should be rotated in the direction where the image is required, and joystick pins are used in the distal fragment to help the control and to manipulate the fragments. So, as my colleague spoke about the acceptable alignment, there are basically 4 parameters. First being the anterior humeral line, which should intersect through the capitulum. The second is the Bowman's angle, which after reduction should be more than 10 degrees. And third and fourth being the medial and the lateral pillar. Both the medial and lateral pillar should be intact. So ideally, what the authors have advised is that minimum K-wire should be of 1.6 millimeters to 2 millimeters. Both the columns should be engaged, that is the lateral and medial columns, and the pins should be applied in a divergent fashion. The greater the pin spread, the greater the stability. So the pin construct should be spread wide at the fracture site, and both columns should be controlled. The lateral column is controlled with the pin along the metaphyseal flare, and the medial column control is with the lateral base pin. And after putting 2 pins, the construct is checked in the AP and lateral views. If the construct is found to be stable, then the third pin is not required. So after the stable reduction and pinning, we do the AP and lateral views, and if required, we go for stress views. Otherwise, in all the cases, stress views are not required. If the reduction is found to be stable, unattempted repeated stress views are not required. So the post-op care is in the type 2, the patient can be treated as outpatient. In type 3, monitoring is required for 12 to 24 hours. Frequent neurovascular examinations should be done, and compartment should be checked. So now I'm going to demonstrate a case of a 7-year-old male patient who presented to us with fracture supracondylar humerus. So this is the general setup of OT, in which the patient is placed supine with a board, and a proper functioning C-arm is a main essential for performing closed reduction and percutaneous pinning. So the first step is the longitudinal traction is given, in which the counter traction is given against the axilla, and first the alignment is done in the AP view. So after applying the longitudinal traction for few minutes, check the AP view, in which to see that the fragment is reduced in the coronal plane. So also check for the posteromedial and the posterolateral cortex, whether they are intact or not, and if the chunk is on the posteromedial aspect or the posterolateral aspect, the opposite pressure is applied to the elbow while the limb is placed in extension. So after satisfactory alignment in the AP view, now we move on to the lateral view and check the Jones view and see the displacement in the sagittal plane. So the first picture, which from the left side, we can see that the fragment is still unreduced. So what we do is that in the elbow inflection only, we try to align the views by medial or lateral displacement. So after correction of the medial and lateral displacement, we again see the views in the Jones view and the lateral view. The reduction looks fine. So now we move on to the next step, that is the pinning technique, pinning methods of medial or lateral entry pins. So to maintain reduction, we can either do a taping around the elbow, or we can place a towel beneath the elbow. So the acceptable parameters, as I mentioned, is the Bowman's angle, the anterior humeral line, and the intact medial and lateral columns. Now moving on to the pinning technique. First and foremost, multiple entry pins should be avoided. The lateral pin insertion should be done. The preferred technique for CRPP is to put 2 lateral K-wires. So the first K-wire should be held against the lateral condyle, and the trajectory should be checked in the AP and the lateral views. Once 2 pins has been applied, check the coronal alignment by extending the elbow, and if the reduction is found to be unstable, then pass another pin. So engage sufficient bone in both the proximal and the distal fragment. The proper method is that the first pin should cross the fracture medial to the olecranon. The second pin should cross the fracture lateral to the olecranon fossa, and if required for additional stability, third pin can be crossed through the fossa, which provides four cortex purchase. Then reduced capitulum normally lies anterior to the plane of the fracture, and the pins should always be slightly anterior, and it should be angulated 10 to 15 degrees posteriorly. So now moving on to the medial pin. Medial pin is only used when there is inadequate stability or if there is a medial oblique fracture. Normally how I perform is that I give a small stab hole and pass a fine artery forceps up to the bone. The elbow is extended and then K-wire is placed. And it is advised to be slightly anterior if possible while advancing the medial K-wire. Then check the AP and lateral views again. Now, what are the things that needs to be avoided while pinning? So, inadequate number of pins should not be there. The pins should not be thin. Bicortical purchase should be achieved. The pin spread should not be poor. The avoid pin convergence and pin crossing. So, a tip to make the pins in a divergent fashion is that you try to cross the K-wires outside itself. Once the K-wire has been crossed outside, then automatically the pins will diverge inside. Then after putting the K-wires, assess the stability, check the stress, check the reduction in stress views, check the vascularity, and apply a cast in 60 to 70 degrees of elbow flexion. At follow-up, normally pin removal requires 3 to 4 weeks. Frequency of the follow-up is variable according to the surgeon or the fracture type, and post-pin removal radiographs may not provide clinical utility in the absence of any other clinical finding. Thank you.
We will have question answers after the next session, after the next speaker is done with. We all have come across many cases in which we have blanching present in the nail bed, but the pulse is not palpable. That is a pink pulseless hand. Now I invite a debate on this, whether to wait or operate immediately for vascular injuries. Dr. Karthik would be in favor of waiting in such cases, whereas Dr. Ritesh Pandey would be speaking on immediate surgery.
So good morning. I want to thank Honorable Director Sir, Professor Rehan and Dr. Pratik for giving this opportunity. So it is a very interesting topic. So it is a pink pulseless hand, but I want to use the word it is a perfused pulseless hand. I want to talk in favor of watchful wait. So nothing to disclose. So when you look at this X-ray, it is a Gotland type 3 presenting with absent distal pulses. So how will we proceed? So you have to look at clinically. So you have to look out initial assessment. You have to look at clinically whether there's a skin puckering or ecchymosis is present, because the proximal fragment spike pierces the brachialis muscle and causes hemorrhage. That may be cause for impending compartment syndrome. So you should suspect compartment syndrome when you see ecchymosis also. So you look at this diagram. Here the median nerve and brachial artery are tethered by the proximal spike, proximal fragment spike. When you look at the diagram on the right side, this is a posterolateral displace. It's a posterolateral type of supraparenchymal structure where the proximal spike is moving anteromedially and it causes injuring the median nerve and the brachial artery that are run very close to each other. So you have to look at the neurological status also. So complete motor and sensory examination. So Mangat et al. Told if you are having coexisting anterior intraosseous nerve or median nerve injury, it is a more predictive of nerve or vessel entrapment. So angiography, it is not routinely recommended. It is only time wasting. So the site of vascular injury is obvious. It is at the fracture site. So there is no need for routine angiography. So what do you have to do in the emergency room? First, you have to apply the slab in slight traction in 30 to 40 degree of flexion. Apply only loose bandages. Don't immobilize more than 90 degree because it may cause compartment syndrome and further compromise the vascularity. So this is a case of supraparenchymal type 3 with vascular injuries. You take into OR and you fix with lateral K-wires. So then you check for the pulse. So you wait for 10 to 15 minutes. Whether if the pulse comes, it is well and good. In around 50 to 60% of the case, usually the pulse returns. But if the pulse didn't return, you have to look for the hand perfusion. So how you look for hand perfusion? You got to look at the color by means of pink or it's pale, whether it is the temperature is warm or not. Capillary refill time is less than 3 seconds or more than 3 seconds. You can use the SpO2 oximetry. You have to look at the pulse form and the amplitude of the waveform. If you are having handheld Doppler, you can use the Doppler signals also. So if the pulse comes, it's very good. If the pulse doesn't come, you have to look at whether it is a pale hand or pink hand, perfused hand. If it is a pale hand, you have to explore. If it is a perfused hand, there's no clear consensus. You have to decide whether you want to explore or not explore. So I want to talk in favor of watchful expectancy. You have to wait, observe the patient. So you would look at the angiogram. Although we are not doing angiogram routinely, but if you look at the angiogram, how beautifully the distal reformation is because of the rich collaterals around the elbow, because of anastomosis between the profunda brachii, radial recurrent and ulnar recurrent arteries. So there are multiple papers published. This is the paper current concept review by David Skaggs and Donald B. Crew from USA. Another is a systematic review that is published in Annals of Vascular Surgery. Another is another paper published in Indian Journal of Orthopaedics by Sandeep Agrawal. So they are talking about the treatment algorithm for how will you manage a pink supracolonic humerus fracture with a vascular injury. So vascular injuries, the vascular compromise is comprised of 3 to 19% of the all supracolonic humerus fractures. It is the characteristics of vascular injury may be a simple spasm or kinking, or sometimes it can be complete transection or thrombosis because of the intimal tear. Sometimes it may be entrapped within the fracture sites. So well-perfused pink hand is a controversy, whether you want to wait or you want to explore immediately. So are the collaterals sufficient to explore or not? So we have to talk. There are two schools of thought, to explore or not. So watchful wait and see, because of the rich collaterals around the elbow, there is no need to explore in all the cases. So you have to look for the perfusion by means of capillary refill time, used to SpO2 probe and the temperature of the hand. So sometimes in 50 to 60% of the cases, the pulse returns within 10 to 15 minutes. So there are papers suggesting there may be a chance of re-occlusion even after vascular injury repair. Like if you do grafting or you do end-to-end repair, there's a chance of 50 to 60% cases there will be a re-occlusion or there is a formation of aneurysm following repair also. There's a limited clinical evidence of long-term sequelae. So Sabharwal et al. Tell in 6 out of 13 patients they had brachial stenosis or re-occlusion in their long-term follow-up. Another is Constantinic et al. They're telling in the 14-year follow-up they had 7 cases out of 10 had aneurysm following the vascular intervention. So why you want to explore? But the people that are standing in the opposite side, they want to explore. They are telling the points favor of exploration is you are missing the opportunity to re-establish it, and there's a long-term sequelae. Although it is not proven, the long-term sequelae are not proven. So this is a level 1 systematic review done by Devmurari. In the annal, this is published in the Annal of Vascular Surgery. They told that in a well-perfused pink hand, the traditional dogma of watchful wait should not be revisited as long as no signs of deterioration of the vascular status appears. There is no need to intervene if the hand is well perfused. This is another paper that is published in 2021 in the BMC Musculoskeletal Center. That also tells if the hand is well perfused, surgical exposure is not necessary as long as the hand is warm and well perfused. You have to observe for next 40 to 72 hours. So what is watchful wait? What do you mean by watchful wait? So you have to do continuous serial examinations in your ward. So you have to monitor. It is not like that you are operating and you're going out, you are not observing at all. You have to do monitor regularly. You have to look for the temperature, you have to look for the capillary refill time, you have to look for the SpO2 waveform. And if you are having handheld Doppler, you can use that also. There is a signal suppression Doppler. So in children, in adults, you will have 5 P's for looking for the compartment syndrome, but in the children, it is 3 A's. It is an increased anxiety, agitation, and increased requirement of analgesics. So you have to feel for the tense of the compartment and you have to look for these signs. So be aware in kids with medial palsy. Why in medial palsy? Because in medial palsy, there is a sensory component is also involved. So if the patient is having sensory component involved, the child may not manifest the pain. So you have to, at that time, you have to feel the compartment and you have to use the SpO2 probe, something like that. So in anti-intracranial nerve palsy, it is a pure motor branch, sensory will be preserved. But in medial nerve injury, the sensory component along with the motor component will go. So the pain perception will be less. So you should be very aware in cases of coexisting medial nerve injury with the vascular injury. So this is an algorithm. So if your patient comes to with the pulseless hand, you have to apply in a slight traction, apply 30 to 45 area. Remember, don't attempt any reduction. Just apply in a slight traction in 30 to 45 area of flexion. So if the pulse returns, it's well and good. If the pulse is not returned, if it is a pale hand, you have to immediately explore, you get the vascular consolidation. But most of the time, it will be a perfused hand. So you have to observe and watchful wait for another 48 hours. So how do you observe? You observe, I already told you have to look at the compartment, you have to look at the capillary refill time, you have to use the SpO2 probe, and you have to use the handheld Doppler. So during the observation time, if the child develops some signs of impending compartment syndrome like 3 years or there is a deterioration in perfusion, you have to get immediate vascular consultation, and if required, you have to go for vascular exploration if the deterioration occurs. So what about long-term concerns? Some people will talk about long-term concerns like growth retardation, or there is an exercise or cold intolerance or autonomic dysfunctions. So what the literature says? This is an E4 review. What it told is Pulmonary reviewed 14 adults with a 14-year follow-up. They are telling with no difference in grip strength, capillary refill, wrist brachial index, and length of the arm and circumference, and the radial pulse was present in all these patients. So in the literature also it varied from 80 to 90% after 1 year follow-up, the radial pulse comes back. So we are also doing a study in our institute. So we are comparing the patients, retrospective study, comparing the patients, those who underwent vascular intervention and those who didn't underwent vascular interventions. We also found no difference because in all the patients, the radial pulse returns after 1.5 years follow. So this is a case example of 3-year-old child having pink pulseless hand. We taken it to OR immediately and we fixed with cross caviar because it was unstable only with the lateral caviar. And it was managed conservatively with the watchful expectancy. We didn't intervene vascularly. So after 3 years of follow-up, now the child is 6-year-old. After 3 years of follow-up, we took the color Doppler and you can see there's a triphasic flow. Although the PSV is less on the left side is the injured side, but it is triphasic. And you have to look at the temperature difference. If you talk about autonomic dysfunction, your temperature difference, here it is similar. You're using the infrared camera, you can see the temperature difference on the opposite side is more or less same. And there is no cold intolerance or exercise-induced intolerance. So the pulses is palpable, although the volume is less, the patency is present, and it is a triphasic waveform in this child. So we look at the exercise-induced intolerance by measuring the wrist brachial index. We ask the child to have a smiley ball and ask to squeeze for 10 minutes. We measure the brachial index before exercise and after exercise. The value more than 0.8 is normal. So here the child comes, it is more than 1 in both the sides. So there is no exercise-induced intolerance after a long-term follow-up also. So you want to look at the grip strength by means of dynamometer. Up to 14 kg, this child is able to perform bilaterally. And there is no growth disturbances in means of length and circumference. So the child is asymptomatic and there is no proven long-term sequelae. So my conclusion is distal perfusion is the main deciding factor rather than the severity of vascular injury, whether it is a transection, whether it is a spasm, whatever may be. So you have to look at the distal perfusion, that is the main deciding factor. When the cases with associated medial injury, yes, you can manage conservatively, but you should be more vigilant. Every case of pink pulseless hand doesn't require vascular intervention. It should be individualized approach based upon the treatment algorithm. So watchful eye, observe for signs of compartment syndrome and vascular deterioration for the next 48 to 72 hours before discharging the patient. Thank you.
Thank you, Dr. Karthik. Now I invite Dr. Ritesh Pandey.
A very good morning to all. At the outset, I thank Ajai sir, Rehan sir, Dr. Prateek, and the whole organizing team for having me here. I will be speaking in the favor of early vascular exploration for a case of pink pulseless hand. And Karthik is a very good friend of mine, and he is very academic, and I knew that he will present a lot of papers in his support. But life is beyond expectations, and what Karthik is suggesting is that to do nothing and to expect that everything will be fine. And this may lead to disappointments both for the patients as well as the physicians. And hence I object against observing these cases. And I will prove my arguments by discussing the disadvantages of observation and monitoring, and then the advantages of exploration. So let's come to the first point. Most of the studies which support conservative treatment, they are retrospective in nature and they lack proper validation. And the definition of pink is also not very clear regarding how much pink should be considered as a normal thing. The studies mainly comment on the return of palpable pulse and capillary refill, but they lack comment on the long-term functional outcomes, and they lack comment on long-term objective assessment of the vascularity. Also, these are some questions which are not answered yet in literature, like what is critical ischemia? How do you define it? And how do you determine it? then the term deterioration is also not very clear, like how much deterioration will suggest you to go for exploration on a timely basis, and when to discontinue the monitoring and declare that it is safe now. This study has tried to make the things a bit simpler by suggesting some of the indications for vascular exploration when the child is undergoing observation for a pink pulseless hand. And if you can see, all these indications are subjective and not very clear. Also, in a dark pink child, it may be difficult to differentiate a pink hand from an essential vascular injury. Pink hand doesn't guarantee us about the long-term outcomes. The return of pulse is mainly dependent on presence of rich collaterals, but these collaterals may itself be variable and unreliable. So what I want to say that a pink pulseless hand is a compromised state somewhere between complete ischemia and complete recovery, and it has its own implications. For example, in this study, 2 children out of 20 who were undergoing observation, they needed subsequent vascular exploration. But what is more concerning is, this patient who was discharged and later on presented in the OPD with circumferential skin necrosis and a VIC. This is another long-term outcome study which followed these patients for around 15 years, and 22 patients who had undergone observation, they all had signs of a VIC and later needed surgery for the correction of the deformity. Another issue is that as a treating physician, we are mostly unaware of the real scenarios and its gravity. So this is a study which compared the actual figures from the literature and compared it with the response given by the POSNA members. And you can see there is big disparity between the figures. And I'm sure if a similar study is carried out in India, similar figures will come out. The concomitant nerve involvement is also very common and it needs exploration. Otherwise, it is going to cause long-term neurological issues. It is also known that a compromised vascularity can lead to poor limb development and shortening in a growing child. And cases of late pseudaneurysm from the brachial arteries has been reported in literature. So how will we explain all these things? Who will be answerable to all these long-term complications in today's world of litigations, and which could have been avoided by a timely surgical intervention? These are the types of vascular injuries which have been reported in literature. And in most of the cases, it is a simple entrapment of vessel between the fracture ends. And exploration can restore the vascularity immediately. So why to depend on the collaterals and remain in uncertainty? So I support exploration of the neurovascular structures, and appropriate intervention can be done depending on the type of the vascular injuries you are facing. And it is fairly supported by the literature. Like in this study, the 5 children who underwent vascular exploration all had normal neurological and vascular status at the end of 1 year. This is another study. The children were followed for around 14 years and all 12 had a patent vascular reconstruction and equal limb length. And there are many more similar studies which support early vascular intervention for a pink pulseless hand. So to conclude, I support early vascular intervention as it restores the vascularity immediately and takes out of the uncertain situations. It avoids long-term complications and it is more justified for the medical legal issues. Thank you very much.
Thank you, Dr. Ritesh. We have 2 senior orthopedic surgeons in the hall. They are currently directors of their own institutes right now. And they are, I think, have much more experience in dealing with pediatric orthopedics. I would like to have their experience in managing supracondylar fracture humerus. Since they are more experienced, we would be enlightened by their experience. Just half a minute. May I request Dr. Ajai Singh sir and Dr. Jiten Shukla sir later on.
Thank you very much, sir. Uh, I think all the four speakers were excellent and they have presented their views. And nothing more I want to add. Uh, but I want to, this debate is very interesting. But as per my opinion, this is not the debate where there are definitive indications when the exploration should be done. Nobody is saying that exploration should not be done. Nobody is saying that totally we have to wait. There are certain indication and parameters. We have to define those parameters. And as per the parameters, we have to wait and wait, the watchful wait for 48 hours. If there is no deterioration, there is no development of compartment syndrome in that 48 hours means after the manipulation, if the limb was initially was pulseless and it was not well perfused, but after the manipulation it has become perfused, but well perfused. And well perfused does not mean the pink in color. It is the pulse oximetry, which is now is one of the very solid parameter, and it is the triphasic wave that is more important rather than the oxygen concentration. So the triphasic phase is there, and if there is no sign of the compartment syndrome, so I strongly feel that we should wait, and only after, if deterioration is there, just for the sake of obtaining the vessel, does not justify our intervention. That is my opinion, and I follow that. Thank you.
Dr. Shukla, sir. Thank you, Dr. Washington, for involving us in the discussion part of it. And I will start by commenting on the CRPP by Dr. Faisal. Dr. Faisal was talking about reduction of the supracondylar fracture. So one point which I would like to suggest, when you are giving the traction for reduction of supracondylar fracture, it has to be given in line of the deformity rather than do not overextend the elbow at the time of reduction. One. Second is when you have once achieved the length, the distal to medial manipulation that you advise should not be done in flexion, it should be done in extension. Because in flexion, you are locking that fragment. Then this displacement the correction will not be possible. That is what I think. Maybe you can support your views, but that is what I think. Second, I would like to ask you a question. When you go for 3-pin fixation from the lateral side, and when you go from median and lateral 1-pin fixation.
If the construct first and foremost, I try to achieve the correction by 2 lateral pins. And if the construct, I find the construct to be stable, then I leave it. And if the construct is unstable, or if there is a medial wall comminution, then I go for a medial pin.
But medial wall comminution is obvious to you even on X-rays prior to taking in for the reduction. And so in all cases, you have 3 pins.
May I ask all the speakers to please come forward? So, sir, you may continue.
If sir, you allow me, I want to intervene that now the evidences are very strong in favor of 2 lateral pins in an uncomplicated supracondylar. And when we are talking about 2 pins, means 1 pin should be central, involving the 4 cortex, and only then, and other thing he has already mentioned that it should be fanning out in the both direction should be, and the second pin should be involving the at least 2 cortex. Only then the fixation is good. Biomechanical studies are enough there which suggest that if these parameters are met, then no need of 3 lateral pins are required. The 2 are good enough. As far as the medial pinning is concerned, as Dr. Faisal has, I think I agree with that idea that if there is a comminution, and you are very right, the communication comminution you can see on your plain X-ray. So if you are able to see the comminution, then you have to go for medial pinning. But otherwise, biomechanically, there are no indication for unless until it's a higher supracondylar. If it's a higher supracondylar, then you may fix the lateral column, medial column, and the central involving the 4 pins. Otherwise, 2 pins are good enough in a classical supracondylar humerus.
As far as now coming to the debate, I think I would also like to opt for wait and watch until and unless you have some, as Dr. Pandey has said, some other signs, and then you can always go for an exploration of the vessel. Nerve injury, median nerve injury associated with a pulseless hand, more chances of exploration. That is what I think. And thirdly, I would like to ask Dr. Karthik, is there any range when you are monitoring the SpO2? Is there any range which you will say it is acceptable? Is acceptable?
That is more, it is subjective only, the amplitude of the just look at the amplitude of the waveform. There is no written criteria exactly, but you should look at the amplitude of the waveform. That is, if the amplitude is good, then it's okay. If the amplitude is poor, the graph amplitude, then it is a concern.
As such, there is no range like 93%, 95, above 95 or below 95.
You are talking about the saturation value, sir?
Saturation value.
SpO2, sir, it is more than 90, it's okay. But I am more concerned about the amplitude rather than the saturation.
Okay, thank you.
It is not only Karthik, it is not only the height of the wave. It is the triphasic pattern. If it is not biphasic pattern, then it is
Yes, sir. That is in Doppler.
That is in Doppler.
Yes,
So
sir.
that is more important. Even in pulse oximeter, you have the wave pattern. It has to be the wave pattern. And
Exactly.
if-
The amplitude.
Yeah. So that wave pattern is more important to observe rather than going for, because there are many factors which will influence your oxygen concentration, such as the temperature and other factors. The apprehension, even the apprehension will decrease. Will do the peripheral vasoconstriction. So that is not the criteria of doing it. It is the pattern of the wave which is more important.
So I suggest to have a handheld Doppler. You can purchase some handheld Doppler. It will be really handy to use.
And secondly, I would like to ask whether I wanted to ask Dr. Ritesh that.
In the meantime, can I ask?
That the pulse which returns after some time in a pink pulseless hand, after reduction even, or after your repair even, is it due to the collaterals or is it really the bounding pulse? So again, you have to take color Doppler and find the triphasic pattern of it and whatever.
So most of the time it is an arterial spasm. So because of the main vessel, the pulse returns not because of collaterals, but because of the flow through the main vessel itself. Most of the time it will get arterial spasm. So if the spasm goes out after once the fracture is reduced, maybe after 15, you wait for 15 to 20 minutes. In 50 to 60% comes. So to answer your question, it is the flow through the main vessel rather than the collaterals, because immediate pulse return is due to the main vessel flow, not because of the collaterals.
The vessel which is commonly injured, the pattern is the intimal damage. That is the most, that causes the spasm. So even if when the spasm is over, the damage is always there. So what he presented that in a long-term pattern, there will be the pulse will be feeble. It will not be, it may
Volume
be,
is less.
Yeah, volume will be less. But so that is not the criteria. That is not the criteria. It is the extent of the capillary circulation which is more important.
So to add on to the point, if after intimal tear, there will be late onset thrombus. The thrombus may develop after 20-48 hours also. So you should be very careful.
That's why 48 hours are very, very critical to find out any 3A is there or not.
what do you say? After that, the collaterals will develop during that 48 hours and the flow will be there.
No, the collaterals are already there, sir. The collaterals are already there, anastomosis is there. So I am telling most of the time, the collateral, the hand, I am not using the word ping, I am already using the word perfused hand. So the hand perfusion is the criteria. If the pulse comes, the arterial spasm is relieved, so the patency of the vessel had improved. So, but it takes time. It case to case basis, it varies.
Later, the pulse can go away with the thrombus if there is formation of thrombus in the vessel.
It can. If you are telling the pulse comes immediately because of the intimal tear, late onset thrombus, then it
can go away.
Theoretically, it is likely, sir, but the hand will be again be perfused because of the collaterals. So we are concerned about the perfusion of the hand rather than this.
In presence of good collateral, the thrombus will be bypassed. So sometimes even the proximal collateral will bypass the thrombus. So it is not necessary. If thrombus is there, then you will not get good quality.
Because the anastomosis is higher above the profunda brachii with the radial and ulnar recurrent artery. So it is way high above.
It will maintain and bypass the thrombus.
Second question I want to ask is, while you are pinning, suppose you have pinned the fracture, lateral view, which you see, internal rotation one or external rotation, or both?
So if it is a stable, I will do external rotation. Otherwise, I will move. If it is unstable pattern, I will move the CM and see that is the best.
This being very
Because
common.
the problem is, if you rotate, most of the people rotate the forearm. You don't rotate the humerus. That is what the mistake usually.
What initially you see?
I will rotate the humerus along with this, not just rotating this, because it will cause strain over the fixation. So that is the most common mistake that people do, just rotating the distal lever.
This being
That
a
is what
common
I-
topic, I'm sure there will be many questions which we can discuss during tea and other time during lunch or tea. I would now invite Dr. Amol Dubepuria for his case. We can have further discussions over the case also.
So before
And
that,
then-
I would like to make it clear that don't get confused with the debate. I totally agree with the opinion of the House and Dr. Karthik that surgical exploration is not needed in every case, and the first step should be observation if everything looks okay, and based on the defined indications, we should go ahead and do the exploration if needed. Thank you very much.
One more from the suggestion to the organizer that we must encourage our PGs and other delegates for the discussion, because this discussion should not be from our side, but from the delegates.
Good morning, everyone. First of all, I would like to thank Honorable Director Sir, Rehan Sir, and Pratik Sir for giving this opportunity. So, starting with the case, a child was born by complex vaginal delivery, which required traction for extraction of the baby at a hospital in periphery of MP. On day 2, the obstetrician noticed swelling over the right elbow and decreased movement of the right upper extremity. So they sought opinion by an orthopedic surgeon. So on the second day of birth, after examination by the orthopedic surgeon, the standard X-ray were done, AP in lateral views. So in this X-ray, we can see some abnormality over the elbow. So anyone from the delegates would like to make a diagnosis? Anyone? Okay, we can see that the normal anatomy of the elbow is distorted, and there is a history of trauma, birth trauma. So if no one is ready.
Yeah, people should get involved. It was already mentioned in my lecture.
Please suggest a diagnosis. Any of you.
Okay, very good. Anyone would like to give another diagnosis? Let it be wrong, but make a yes.
Way, why it is not elbow dislocation?
Try anyone.
Partly because the observation centers have not developed at birth. So we can also make a differential diagnosis of elbow dislocation as well as a transfacial fracture dislocation.
The faces are weaker compared to limbs. So,
Observation has.
That is not visible, but why it happens?
Okay, then we'll have discussion later on. So the treating surgeon was also not experienced in the pediatric cases. He misdiagnosed it as a case of elbow dislocation. And as per the child's parents, after close reduction of the elbow, the surgeon applied an upper elbow slab. However, he made a mistake here that he didn't get a check X-ray done after slab application. He advised the patient to continue slab and to follow after 2 weeks. So after 2 weeks of birth, the slab was removed and fresh X-ray was done. So now we can see that still the normal anatomy of the elbow is not retained. We can see that the proximal end of both radius and ulna are shifted medially and have migrated proximally. Also, we can see some periosteal reaction around the elbow. So now he realized his mistake that it is not a case of elbow dislocation, rather it was a case of transfacial separation of distal humerus. So he then referred the patient to higher center. So for my young friends, just a glimpse of transfacial separation. This is a diagrammatic illustration of the transfacial injury. The facial portion of the distal humerus is the weakest part, and birth trauma can lead to this facial separation. And the key to diagnosis is the alignment of radius with the capitulum. The physis at this time is cartilaginous, so we cannot see in the plain X-ray. So for confirmation of diagnosis, we'll have to use additional imaging modalities like USG, MRI, and arthrography. So we all know that USG is a simple, non-invasive, and easily available tool. And for diagnosis, a skilled radiologist should be involved in this. And it can be done without sedation, but usually it is uncomfortable for the patient to manipulate the limb. So here we can see that this, starting with the normal side, the capitulum and the humerus is aligned. But in this case, the humerus and capitulum is not aligned, and radius and capitulum are aligned. Second imaging modality is the MRI. It is the most accurate examination. It provides detailed visualization of the cartilage, bone, and soft tissue in various planes, and it requires the baby to be under sedation, and it is an expensive modality. The third one, which is usually done by an orthopedic surgeon, is an arthrography. It is a useful tool that is quick and minimally invasive. It allows adequate visualization of the joint anatomy during surgery, and it helps in intraoperative decision making. So coming back to the case, so this patient came to us with this X-ray at 16 days after birth. So considering the periosteal reaction, we thought that the healing process is on the way. So we decided to manage this patient conservatively. So anyone would like to change with the plan? Any another method of management? So we went by the literature. The actual management of transfacial separation depends on age and time of presentation of the patient. Neonates and infants up to 6 months of age can be managed with close reduction and elbow casting. However, if close reduction fails, then we need to move on the operative intervention. Children more than 6 months of age, usually close reduction and pinning is advised. And it is not recommended to treat a late presentation with open reduction because it can more damage the physis. And we usually see cubitus varus deformity in these neglected cases, which can be dealt later on. So this was the follow-up X-ray, which was done at our hospital after 4 months of birth. At this point of time, we can see that the distal part is now looking like distal humerus. However, there is some malalignment. So we decided to manage this patient conservatively only, and the malunion to progress. So take-home message remains the correct diagnosis. For my young friends, to differentiate elbow dislocation with transfacial separation, age at presentation is important. In this case, as it was a neonate and infants, we usually see transfacial separation. In age more than 2 to 3 years, we should make a diagnosis of elbow dislocation. Mode of trauma, and the important finding is the radiological feature. As in this case, we saw that there was a medial displacement of radius and ulna, but in case of elbow dislocation, usually the radius and ulna are displaced laterally. And we should not hesitate to use additional imaging modalities like already discussed USG MRI arthrography. And management depends on age and time of presentation. And cubitus varus is the common complication. Thank you very much.
Thank you. We have discussion at the end of the second case. Dr. Shekhar Mishra.
Good morning, everyone. I'll be presenting a case following this. Child presented, the history of the case is the child presented, an 8-year-old boy presented with trauma with a history of fall on outstretched hand while playing in the park. On examination, there was swelling around the left elbow. There was no open wound. There was tenderness and there was no distal neurovascular deficit. So sadly, I don't have the X-rays for this child. These are the intraop CM images. You can see in the X-rays with the intraop CM images in the AP and the lateral views. In the lateral view, you can see there is no meaningful cortical continuity. So we diagnosed this case as a supracondylar humerus Gartland type 3 fracture. And the patient was planned for closed reduction and percutaneous spinning with K wires. So these are the intraop CM images. And this is the AP view. And this is the lateral view. So you can see in lateral view, the fragments are completely separate. So again, after flexion and reduction maneuvers, we could not attain reduction. So we tried some reduction maneuvers have been taught in closed reduction techniques. One of them is this intrafocal pinning, similar to a Kapanji technique, which we use for distal and radius. This is first described, it's a Japanese person, it was done, which is published in the Journal of Shoulder and Elbow Surgery in 2003. In this, we pass a pin from the posterior side and we go through the fracture fragment and then we try to lever the proximal fragment to attain vertical continuity. But despite this method also, we failed to achieve reduction. This was the lateral view after trying to achieve, we could not achieve reduction. So the next method left to us was only open to go for an open approach. So the fracture was then opened through an anterior approach. The fracture can be approached to various approaches, but multiple literatures suggest that the anterior approach is better compared to the posterior or the lateral and medial approaches. So these are the intraop pictures. You can clearly see a rent in the anterior brachialis and the brachialis muscle. So the fracture was then reduced after removing the interposing brachialis muscle, and fixation of the fracture was then done using K-wires used under fluoroscopic guidance. So this is the fixation that we did. We had to put 3 lateral pins. First we did to see the stability, but even that proved to be unstable, then you had to go for a needle pin also. So these are the pictures after reduction and the after fixation with KYs. This is a 1 month follow-up X-ray of the same child, after which the KYs were removed. So one of the things to ponder in this is initially when you see a patient with a supracondylar fracture, you should always look for this sign, which is a pucker sign, which we say, in which the proximal fragment has penetrated through the brachialis muscle and has taken the dermis with it. It has incarcerated the dermis. So this is, you should be aware of this sign. So how do you reduce this? So before giving traction initially, normally what we heard initially was when you go to a theater, you try to give reduction, you give a longitudinal traction. But when you have this sign, instead of first giving traction, you first try to milk this. If you give traction, it will incarcerate further structures which are there. So first you try to reduce this, and then you go ahead with your reduction techniques. So the take-home message is supracondylar fractures, grade 3 and above can be sometimes difficult to reduce with closed techniques. A pucker sign, which I showed previously, may be present if the proximal fragment has penetrated the brachialis and the anterior fascia of the elbow. Milking maneuver may be tried for freeing the brachialis. However, if it still fails, opening the fracture from an anterior approach may be required. Thank you.
Dr. Shekhar, please stay there. Dr. Amol, please come forward. Now, may we have questions from delegates?
Why a medial pin was inserted in your case? Just curious.
So after the pins insertion from the lateral side, the 3 pins, the stability was checked. Introp was still, we found that the stability was not.
So still applying 3 KYs from the lateral
Yes,
side,
sir.
still it was unstable.
Yes, sir, because one of the KYs which I see is the displacement at the fracture site is still not appreciable. At the fracture is not as divergent as you would have liked in the.
And do all the cases of open reduction, you go for through the anterior approach? I mean, you told in your talk
Yes,
that we prefer anterior approach rather than lateral and posterior. How common is it to perform anterior approach in cases of open reduction in the supracondylar fracture humerus?
Personally, sir, what I have been in, we have mostly gone through the anterior approach only, but I've not been in many, so as
I would like the senior members to comment on this.
Shekhar, anterior approach is only meant if you are going to explore the vessel. If you are not aiming to exploring the vessel, then much easier is going for posterior lateral approach. That will take you to the safer area. There would be less chances of maybe surgical complications. So anterior approach is good. Because directly you are reaching the vessel. But if vessel is not being targeted, then for me that is not a preferred approach. Okay.
So what I read was going through a posterior approach in grade 3, mostly the periosteal hinge is still intact. So when you go through a posterior,
then that is not type 3. If that is 2B, if the hinge is intact, then that is.
yes, the bone is not in continuity, but the periosteum is intact, which we don't see on the X-rays. But if the periosteum is completely torn, then it goes into grade 4, which is the flexion extension both is possible.
Anterior should be only for the exploration. There are posterior lateral is most safe approach without going into the danger area.
And sir is saying about posterolateral approaches, not the typical posterior approaches, which some of the surgeons use.
Yes.
So, I was having a discussion with Dr. Karthik over here about using the Dorgan spin.
Yes, that is
so,
very important.
Like with so much experience among our seniors over here.
Yes.
How commonly, sir, have you encountered a radial nerve injury?
I think that was he showed the pin. He used the pin for as a joystick and keeping that pin into the fracture site and manipulating the fragment. Then if you are having 2 pins, one in the proximal proximal fragment, other in the distal fragment, and then you manipulate with these pins the 2 fragment, and as soon as you get the reduction, you same pin may be passed into from distal to proximal or proximal to
Proximal to distal, sir.
yeah, that is the proximal to distal what you are talking about. So that is one of the way of next time you try that method. Don't keep only one pin into the fracture site, but make a joystick of having two pins and then manipulate, and same pin can be used to propagate into through the fracture. That would be what he's saying is because now the most three pins from the distal to proximal, other way is from the proximal to distal. That gives even the better fixation as far as biomechanical evidence is there.
The question I wanted to ask everybody over here, that has anyone encountered a radial nerve injury with organs? Because I use it in a little bit like more common way than it should be used according to textbooks. But I have been warned by it about the radial nerve palsy by my seniors. Dr. Karthik also was saying the same thing.
There is evidences or papers are there in which they say that by passing the three or passing the lateral pins, you may injure the radial. Why? Because radial is piercing the septum. When it is piercing the septum, and then there are high chance. I mean, there are chances. So one of the X-ray was showing too much pin was going out of the cortex. That should be avoided in the next time. It should not be so much of going into the soft tissue. That should be avoided. Even if you have gone into the soft tissue, withdraw it slightly. Only then you will be avoiding the radial nerve injury through the lateral pinning.
I use this pin construct when I am having a difficult reduction and I have to go with lateral approach for open reduction. Then I have gone in front of me and then I use that wire, and it will be a cross fixation.
Yes.
But I'm not going from medial side, I'm going from upside, and I'll restrict myself from just above the medial contact. In that case, we are safe from the radial nerve as well as ulnar nerve. Otherwise, obviously, percutaneously, it will be difficult to be safeguarding the.
So we are running a shorter time, and I thank you all the speakers for some nice.
Only one point I want to add about Amol.
Yes.
One of, if it is a birth injury, you presented the lower humeral epiphysis separation as one of the birth injury. Yes, it may be a birth injury in a difficult delivery. Otherwise, this is for every student who is present here. We must rule out the infection. Septic arthritis induced separation is very common in high risk neonates. So we must do ultrasound in such patient in each and every to rule out whether there is a collection of fluid or not. If it is there, then the whole treatment will change. So it is, they should not go with the mind with the impression that it is only the injury which is causing. Maybe infection without injury may be the cause. Okay, thank you.
Just one point I'd like to add in such cases where we are suspecting septic arthritis, I would recommend that normally what ultrasound we do, we should go for a high resolution ultrasound. So,
Thank you for an interesting session. I thank all the speakers. Thank you.
Thank you, speakers and chairperson, sir. Sir, there is time to appreciate the speakers. Sir, please, chairperson, please come to the dais and give the name to speakers. I will call one by one. Dr. Abhishek Saha. Dr. Abhishek, please come. Dr. Fazal, please.
Abhishek.
Dr. Karthik, SR, please. Come on the dais. Dr. Ritesh Pandey, please. Thank you, Dr. Ritesh. Dr. Amol. Professor Dr. D.K. Jain, sir. Thank you, sir. Professor Atul, sir. Thank you, sir. Now I will call Dr. Rehananda, HOD, Department of Orthopaedics. Please come on the dais. Either will.
A very good morning to all of you. I think looking at how we are running, we have actually taken 30 minutes more in the first session. I think we are already gearing up for a very, very interesting day ahead. And a success of any workshop CME is delegates taking participation in the discussions. And I think that is just beginning to happen. So I'm hoping that we'll have a very successful CME. Any event that happens stands on the shoulders of people who have built up an organization. And I would like to tell you that the MP chapter of the Indian Orthopaedic Association is one of the most vibrant chapters. Unfortunately, we lost one of our very senior members, Professor Pradeep Bhargav. He was the ex-HOD of the Department of Orthopaedics at Indore Medical College. And he was one of the pioneers who actually established orthopedics in the state. So I would request all of you to stand up for 1 minute. It is his funeral today, and we will just, for 1 minute, we'll keep silence to give calm and distance to the family. Please. Thank you. I think as the head of the Department of Orthopaedics, it is my humble duty to welcome all the people who have come all the way from Bhopal and from the far-flung corners of the country. I first and foremost would want to welcome our Executive Director, Sir, Professor Dr. Ajai Singh, sir. Sir is himself a pediatric orthopedic surgeon that you would, all who are sitting behind would have now realized, because I think the final key take-home messages in all the talks are actually coming from him. I would request Dr. John to welcome sir with a floral welcome. So Bhopal is actually a wonderful city, and we are actually at the forefront of orthopedic education as of today. I think we have two very senior people, Dr. Sanjeev Kaur, who is the president of the Central Zone, and Dr. Sumit Tandon, who is the president of the MP chapter of IOA. Unfortunately, because of their busy schedules, they have not been able to join us today, but their blessings are with us. And I think probably in the afternoon, once they join, the discussions will become more vibrant. I would take this opportunity to welcome Dr. Sanjay Gupta, sir. Sir is a very busy practitioner in the city of Bhopal. He is also the president of the Bhopal Orthopaedic Surgeons Society, and I think without his help and cooperation, it would not have been possible for us to organize the CME. Pratik. I would also like to welcome the young and dynamic secretary of the Bhopal Orthopaedic Surgeons Society, Dr. Rahul Verma. He is an associate professor at Gandhi Medical College, a very close friend, and we are always looking for a lot of advice from him. I would request Pratik again to give a floral welcome to Dr. Rahul Verma. We have some very senior people of the boss who have graced this occasion. I would request Dr. Pankaj to give a floral welcome to Jiten Shukla sir. The reason why we had two chairpersons in the form of Dr. B.K. Jain and Dr. Atul Vashni is well known. हम लोग जो बॉस में जो भी इवेंट करवाना होता है, अगर उसको 9 बजे शुरू करना है, then Dr. B.K. Jain and Dr. Atul Vashni have to be the chairpersons because they are the one who will come at 8:58 and will ask you, यार तुम लोग खुद ही नहीं आए, हम लोगों को बुला लिया. So I would like to welcome both of them. Again, Dr. John, can you kindly give a floral welcome to Dr. B.K. Jain and Dr. Manish to kindly give a floral welcome to Atul. Yesterday we had a faculty dinner, right? And it has been only 3 years since I have moved from Delhi to Bhopal. And I was, like some of you, Ravi will know, I was very active in the Delhi Orthopaedic Association. And I used to feel that I'm a middle age group. But yesterday when I was in the faculty dinner, I suddenly realized that the faculty's age is almost 10 years younger than me, right? And it was this thing that generational change is actually coming. हम अपने आप को माना करते थे कि हम juniors हैं and there were a lot of seniors, but yesterday I think there was a huge generational gap. So I would like, and I think that is why a wonderful discussion is happening. They are talking from the textbooks, they are talking about evidence, unlike what we used to have in the past, where we used to have eminence-based discussions. This is ये मेरा तरीका है and मैं ऐसे करता हूँ. That is what is not happening in this workshop, and I think it is all because of the faculty. So a big round of applause for all the faculty who have traveled from different parts of the country. Last but not the least, I would like to thank all the delegates, because without you, any conference is of no use. A lot of effort goes on the part of the organizing team to make this thing. And I would have been happier if the more people would have come, but yes, there is a crowd. The good thing is now with technology, a lot of things can be overcome. So all what is happening over here is actually available on the Ortho TV. Thanks to Ravi, it is also available on YouTube. So I think those who are missing out on the academics in the lecture theatre may be looking at it on the YouTube and the Ortho TV. So thank you, Ravi, for that. And I think with these, because we're already running short of time, I would close this session, and I would like Pankaj to come forward and take the proceedings for the inaugural session forward. Thank you.
Thank you, sir. Sir, अपूर्वा कोपि कोशोड्यम विद्यते तो भारती वेद विद्यमायाति क्षयमायाति संजया. हे सरस्वती, तेरा खजाना सचमुच अवर्णनीय, खर्च करने से बढ़ता है और संभालने से कम है. With this श्लोक, I will request to our director, sir, please come on the dais and do the lighting, the lamps. Thank you, sir. Sir, I will request to Dr. Sanjay Gupta, sir, both president, kindly come on the dais and give us some.
Good morning, everyone. As already we are late, I'll restrict my talk to only 2 minutes, I think. Respected Dr. Ajai Singh, Director AIIMS, Bhopal, Dr. Rehan, HOD, AIIMS, Bhopal, and I think Dr. Seniors, Dr. Jiten Shukla, Dr. VK Jain, Dr. Atul Vashne, and respected all seniors and my dear colleagues and friends, and special mention for the young faculty who have come from all parts of the India to deliver our lectures on pediatric orthopedics. First, I should thank Dr. Ajay Singh, who has been driving force for this conference. I should also thank Dr. Rehan for arranging this pediatric orthopedic CME, and then Dr. Pratik. He is also very efficient, and he has taken a lot of pains in making arrangements. In last 30 years of my stay in Bhopal, I think this is the only first orthopedic CME we are organizing in Bhopal. And that all credit goes to, I think, Dr. Ajay Singh, who is here as Director AIIMS. Though during MS, we learn pediatric orthopedics and we all treat all type of fractures in children. With the time, pediatric ortho is becoming a super specialty in orthopedics. In metro towns, there are so many pediatric orthopedic surgeons. It is true that when you treat only children, you will do better job and then better job for them and obviously give better results. That is true, very true. Fresh simple trauma in children can be treated by all ortho surgeons equally well. Role of pediatric ortho surgeons comes in treating complicated trauma, neglected trauma, and congenital anomalies. I think in Bhopal at present we don't have pediatric orthopedic surgeon, but with so many medical colleges coming up, gradually we'll be having a pediatric orthopedic surgeon very soon in Bhopal. I think one pediatric orthopedic surgeon from Indore is visiting once a month to Bhopal to provide his services in Bhopal. With so many medical colleges in Bhopal, sooner or later Bhopal city will have specialized pediatric orthopedic surgeon. This pediatric orthopedic conference will be useful for all the ortho surgeons of Bhopal, as they have got a good opportunity to learn from the experts in the field, especially complicated trauma, how to manage this complicated trauma and neglected trauma. If the child is not treated well, and especially with some deformity which is not correctable, he had to suffer longest because he is having long lifespan. We should be very careful in treating children. He should not land up with any deformity because you can understand he's having longest lifespan. Adult is having smaller lifespan, but children is having longer lifespan. He has to suffer whole life. So we should be very careful. I think this pediatric ortho CME in Bhopal will be benefit all ortho surgeons and also population of Bhopal, all pediatric population of Bhopal. Thank you very much.
As this is an IOA event, we had requested the IOA office bearers to be with us. Unfortunately, there are two different conferences also going on and they have preoccupations. So they have sent their wishes and regards to us. And I would like to take this opportunity to play their recorded inauguration. First of all, I will be running the video of the IOA Academy Chair, Dr. Vivek.
gives me, and Dr. Vivek, Academic Cell in charge of Indian Orthopaedic Association. It gives me great pleasure and honor to welcome you all to this excellent pediatric orthopedics CME, which is being conducted on 13th and 14th of May in Bhopal under the guidance of Professor Ajai Singh, Executive Director and CEO of AIIMS Bhopal. He is also the Pediatric Subcommittee of Indian Orthopaedic Association in charge and has been guiding us in the matters of pediatric orthopedics for the IOA in a great way. This CME is concentrated purely for the pediatric orthopedics issues, especially the trauma on 14th of May, where the entire gamut of all the fractures and all the topics regarding to the fractures of pediatric orthopedics are going to be taken up by luminaries and great experts of pediatric orthopedics from all over the country. I was going through the brochure and I could see that Professor Ajai Singh and his great team of Professor Rehan and other people in the organization, along with Bhopal Orthopedic Surgeon Society, has been able to gather a lot of good, great speakers, great experts in pediatric orthopedics, and are going to cover a lot of area in the pediatric orthopedics trauma by lectures, by case discussions, and other activities. On 13th of May, they have organized a club foot management CME along with Q Foundation, and it is also an important part of pediatric orthopedics. I feel that this CME is going to be a landmark CME and is going to be of great value to the orthopedic surgeons who have come there, especially in the middle part of our country, and is going to be emulated by all the people in various parts of the country to follow such events and to have such events, especially for the pediatric orthopedics scenario. I would like to wish Professor Ajai Singh sir or Professor Rehan, the organizing team, all the delegates and the faculty, a grand success for this academic year. And I hope that this academic spirit of IOA is going to continue in the very future as well. I thank you all for your patient hearing and giving me this opportunity to be a part of Go Online, being a part right now in a conference in Delhi right now. So I think, thank you very much for inviting me.
Dear all delegates and dignitaries of the dais and of the dais. On behalf of IO Secretariat Office, we invite you here for the fantastic course organized by Bhopal Paeds under the aegis of IO Academic Committee, Pediatric Orthopedic Committee, and under the aegis of Central Zone of IOA and the MP chapter of IOA, where all stalwarts are here. Chairman of IOA Pediatric Orthopedic Committee, Dr. Ajai Singh. He has put a lot of effort with this team of Dr. Rehan and Dr. Patwardhan from such a critical program. Teams Bhopal with all facility and very good ambience. The workshop. I must thank organizers for inviting me in this event. But as we committed for South Zone Conference of Portugal and the North Zone Conference of Delhi, I'm not available with you physically, but virtually I am with you. The whole team has crafted a well-balanced program as a workshop. And the faculty are very good faculty. We are lucky to have a very senior, dedicated Matthew Verghese sir and other faculties. We have prepared structured modules for all delegates. I have a small appeal to young delegates to become IO member, to have advantage of UA mentorship. You can create a possibility of training to get mentored by Dr. Matthew Verghese, Dr. Ajai Singh, Dr. Sandeep Patwardhan in pediatric orthopedics. mentor you too. We have 100 UA mentorships. Last year we have given 100 UA mentorship fellowships to young orthopedic surgeons. And we have earmarked 60 lakh rupees fund as an academic fund for young orthopedic surgeons for fellowships. And now the IO membership, first time in the history of IOA, has been made totally online, total paperless, including payment online, no need to make drafts, no hassle. You can join IOA paperless. Visit the IOA website and click the join IOA button. And you will be able to see the complete detail and instructions where you can join IOA effortless. So please join the IOA. So we are now moving more and more towards the digitalization of the IOA. Now you can see the IOA, all the papers, all the issues from 1967 that digitalized by our IOA team. It is put up on the IOA. You need a login to enter into it. You need a login to read all the articles. They're free for all IOA members. I'm again thankful to you all for the great support in my tenure and helping to bring the change in the IOA. So many changes we could make together. And still we will make new changes. As few young members say, new IOA. So we'll be sharing, contributing and learning together and evolve all together. Thanks to all for allowing me here. Welcome you, and you will get the best knowledge by all the faculties. And I wish great success to the event. Very welcome. Thank you all.
Good morning, friends. I'm happy that our Pediatric Orthopedic Committee of the Indian Orthopaedic Association is organizing a CME on pediatric trauma today at Bhopal. This is also being accompanied by a workshop on Ponseti techniques. I'm thankful to the Department of Orthopedic for taking this effort in organizing this. We have the best available as faculty. Dr. Taral, Nagda, Dr. Sandeep, Patwardhan as the advisors. Dr. Ajai Singh as the chairman. Dr. Kamlesh, Devmurari, Dr. Agrawal, Dr. Venkat as members. I would have so much wanted to be there in person, but I am in Japan attending the Japanese Orthopaedic Association conference. I wish you all the best from here at Yokohama. Enjoy good learning. Journey.
So now I would like to invite our director, sir, Professor Ajai Singh, sir, to have share his experience in a few words. Thank you.
Thank you very much. Thank you, IOA. Thank you, BOA, BOSS, MP chapter, Central Zone, Department of Orthopaedics, AIIMS Bhopal, all the organizers, senior persons sitting of the dais, and everyone, all the faculty members coming from far places from the country, and all the members or the delegates. On the behalf of AIIMS Bhopal, please accept my greetings, and I am very happy to be here. And especially Pratik has done a lot of under the supervision of Dr. Rehan, has done a wonderful job of organizing this this workshop. Yes, we are missing few of. I mean, there are number of persons are delegates are less, but no matter, because we are live on YouTube, and we are having Ortho TV facility also. So I'm so happy that this workshop will improve the awareness as far as the pediatric orthopedics is concerned. जब मैंने काम शुरू किया था तो उस समय लोगों को लगता था कि pediatric orthopedics क्या है, इसकी जरूरत भी क्यों है, तो सभी जैसे होता है कि हम तो ऑलरेडी बच्चों को इलाज कर ही रहे हैं, इसमें अलग से करने की क्या आवश्यकता है। लेकिन नाउ आई एम वेरी हैप्पी कि इतने सब यंग मेरे कोलीग्स यहाँ पे हैं और वो सब इस मैंडेट के साथ यहाँ हैं कि हम लोगों को बच्चों के लिए जो स्पेशलाइज ट्रीटमेंट की आवश्यकता है वो हम लोग उनको दे पा रहे हैं। और हमारी यूजी और पीजी की ट्रेनिंग में कहीं ना कहीं इसको इनकॉर्पोरेट करने की आवश्यकता थी, अभी भी स्कोप है और हमें लगता है कि हमें बहुत ज़्यादा इस पे भी काम करने की जरूरत है। तो मैं IOA का बहुत ही धन्यवाद देता हूँ कि उन्होंने हम लोगों को ये अपॉर्चुनिटी दी, और बॉस और MP चैप्टर का भी धन्यवाद देता हूँ कि आप लोगों ने हम लोगों को ये मौका दिया कि हम ये जो है वो एम्स भोपाल में कर सकें कॉन्फ्रेंस। मेरा डॉक्टर संजय, आपने कहा कि देयर इज नो पीडियाट्रिक ऑर्थोपेडिक सर्जन इन भोपाल। आई थिंक डॉक्टर प्रतीक इज वेरी वेल डूइंग a good job in pediatric orthopedics, or यदि Bhopal is not recognizing Pratik, then that is your mistake. You should be more vocal as far as the pediatric orthopedic, and now it is my duty to make you prominent from in Bhopal. So we are very much. I know he's working. I know his surgeries. I am following his patients in OPD. So I know he's doing wonderful job. So I'm very hopeful, and I'm sure. प्रतीक को मैं 2 काम दे रहा हूँ आज। एक तो you have to start a anti-chapter pediatric orthopedic association. That is very much required. Whatever, I mean, it is not necessary that any orthopedic surgeon who is having some degree or fellowship in the pediatric orthopedic, any person who is having an interest in the pediatric orthopedic and wants to learn more, you must attract those. And in 2023, you must establish a MP chapter of pediatric orthopedics. That is one job I am giving you, and without fail, you have to do it. The other thing that is for Rehan, that this year, MCS pediatric orthopedics has to be started in AIIMS Bhopal without fail. I don't know how you will manage, but you have to manage it, and that is my personal request, but also the command that you have to follow it. So एक चीज में सभी सीनियर्स बैठे हुए हैं और बहुत सारी फैकल्टी इधर हमारे अदर मेडिकल कॉलेज से आए। मेरा एक छोटा सा निवेदन है कि हम लोग फेलोशिप शुरू कर सकते हैं, जो स्टूडेंट्स हैं आपके PGs या इवन यंग ऑर्थोपेडिक सर्जन हु वांट्स टू सी गुड सर्जरीज। DDH जैसे प्रतीक करता है, बहुत अच्छा DDH का केसेस करता है, और भी मैंने देखा है इसको स्पाइन हमारे यहाँ बहुत अच्छा हो रहा है। तो यदि हम लोग उन चीजों को यदि शेयर कर सकें तो वो एक शेयरिंग ऑफ नॉलेज बहुत जरूरी है। तो मैं जो भी सीनियर MP चैप्टर के लोग हैं, जो बॉस के जो सीनियर लोग हैं, मैं उनसे रिक्वेस्ट करूंगा कि इस तरीके की एक्सचेंज फेलोशिप हम लोगों क्या होनी चाहिए, और लोगों को रेजिडेंट्स को और सीनियर रेजिडेंट को और यंग ऑर्थोपेडिक सर्जन्स को एम्स में हम लोगों को वेलकम करना चाहिए कि आप यहाँ पे आए, क्योंकि ऑलरेडी हम बहुत ज़्यादा लेट हो रहे हैं। तो मैं इसमें ज़्यादा नहीं बोलूँगा। ये 2 काम मैंने दिए हैं, एक डॉक्टर रेहान को और एक डॉक्टर प्रतीक को। ये दोनों काम हम लोग करेंगे, और नेक्स्ट टाइम जब भी हम लोग मिलेंगे तो we will come up with a much awaited news as far as the creation of these 2 things are concerned. I wish everyone all the best and happy learning from AIIMS Bhopal. Thank you.
Thank you, sir, for your kind words. Sir, please come and join our chief executive. और जो डेलीगेट्स हैं उन्होंने जो उनको अपना पोस्टर जाकर के वहां लगा दें, ताकि हम लोग उसको टाइमली जो है बाद में जज कर सकें। डेलीगेट्स, जिन लोगों का पोस्टर अभी नहीं लगा है प्लीज आप लोग जाके लगा दीजिए वहां पे। Now we are moving to the second session. For the second session, I invite Dr. Ajai sir and Dr. Sanjay Gupta sir. Please. Okay. Please chair the sessions.
Thank you very much. Now we are going to start the session 2. First topic is management of lateral condyle humeral fracture. How do I do it? Dr. Anurag Tiwari.
Questions will be after this lecture only. So keep your questions ready after the lecture.
Respected chairperson, my seniors, other faculty members, and my dear friends. आप सभी को मेरा नमस्कार। मैं डॉक्टर अनुराग तिवारी आज प्रेजेंट कर रहा हूँ अपनी टॉक लेटरल कंडाइल ह्यूमरस फ्रैक्चर। I would like to thank the organizer for giving me this opportunity. So let's start this. Lateral condyle humerus, why so important? In the pediatric age group, we see the injuries around the elbow. There are two injuries, the supracondylar and the lateral condyle. I personally feel that the lateral condyle is more important because the lateral condyle is rare injury. You may see only 1 to 2 cases per month in your emergencies during post-graduation. Whereas the supracondylar, you may see a lot of cases every day. So this is important, this is rare. And the second important reason is the diagnosis is challenging. Many times you see the x-rays, the patient comes to you after injury and the x-ray looks normal. And you see that the x-ray is normal and you send back the patient home. Whereas in such cases, if you feel that there is something suspicious about the injury, about the lateral condyle, you always get a comparison view. From the other limb, you can compare that what is wrong, what is normal and what is abnormal. You can clearly now identify that there is something abnormal in the lateral side. There is fracture lateral condyle. The next is there is a pull of the extensor muscles which is causing the displacement and rotation, and it is the intra-articular fracture epiphyseal. So these two parameters cause more prone for the fracture to go into non-union. And these non-union, if left untreated, the patient may end up with cubitus valgus, this deformity, and the tardy ulnar nerve palsy later on. So to avoid this disaster, to avoid this complication, we need to address this lateral condyle to be diagnosed early and appropriate management can be started. So that's why it is called as fracture of necessity. Whenever you see the displaced lateral condyle, it is the treatment of choice is open reduction, internal fixation. To avoid this complication, you have to fix it with a K-wire. Lateral condyle humerus, what does this include? In your exam, if you have get the case of cubitus valgus, definitely the examiner will ask you that what do you mean by lateral condyle? So just have this animation. On the X-ray, the lateral condyle includes actually the capitulum, the lateral epicondyle portion, the lateral condylar physis, the portion of trochlea. Again, important, many of us may not be knowing that the portion of trochlea is also included in the lateral condyle, this portion, and the metaphyseal region. So any injury in this region will be called as the lateral condyle. It is the intra-articular fracture epiphyseal injury. And in the later adult life, this portion is made by this lateral condyle. The classification, we have many classification. Not going into too much of detail, Mills, you already know if the fracture is going through the propliocapitular ridge or if it is going around the physis of the condyle. This will be classified as 1 and the 2. Milch 1 is Salter-Harris type 4 and Milch 2 is Salter-Harris type 2. So there is a mnemonic. I have made the 1 into 4 is 4, 2 into 2 is 4. So easy to remember that Milch type is Milch, the Salter-Harris type 4 and Milch type 2 is Salter-Harris type 2. But not so helpful in treatment decision making. It does not tell कि इसमें क्या करना है, इसमें क्या करना है. So management wise, this classification is not is outdated. So we have the Jacob classification based upon the displacement. if it is undisplaced fracture, if it is a complete fracture, or if it is a displaced and rotated. The same way, to a little of this difference, we can make it more objective that if the displacement is less than 2 mm, type 1. If it is more than 2 mm, but articular hinge is intact, somewhat different from the Jacobs type 2. And if the displacement is more than 2 mm. So this will be the V's classification, more or less the same, only difference is between the type 2. The type 2 intra-articular disruption, it will be the Jacob 2, and if it is articular intact, it will be V's classification. So to combine these two classifications, they combine into one single, that is the sound classification. They are made into the 5 types based upon the displacement and the fracture pattern. So clearly it differentiates that if it is an undisplaced type, it will be treated as a non-operative management, whereas if it is a displaced and rotated, definitely it needs open reduction and internal fixation. So this looks more treatment decision making would be easier. The mechanism, we have the two theories, that is push off and pull off. If the patient or the child fall on outstretched hand, there will be valgus and it will cause fracture lateral condyle. Or the second is the theory, if it is because of the pull of the extensor muscles, there will be avulsion type of the fracture lateral condyle. So if there is a valgus force given, because of the radial head, this causes the fracture of the lateral condyle and it displays superiorly. And the second possibility is because of the pull of the common extensor origin on the lateral condyle, there will be the avulsion type of the injury. So if it is a push-off theory, the type 1 milch will be more commonly seen. In this type of injury mechanism, the type 2 milch will be commonly seen. So based upon the mechanism, you can have the idea about the fracture pattern. Clinical presentation, you all know there will be pain, there will be swelling, there will be the tenderness, all sort of this. But just want to make a point here that you have to differentiate between the supracondylar and the lateral condyle. If you see this child like this in your emergency, it is something abnormal in the elbow. The patient will not allow you to touch. There will be swelling. In supracondylar, there will be the circumferential swelling, whereas in lateral condyle, it will be more localized towards the lateral side. The second point is the tenderness. If you go and tenderness, if you check the tenderness in supracondylar, it will be medial as well as lateral supracondylar ridges will be tender, whereas in lateral condyle, it will only be more prominent on the lateral side. So these are the two differentiating features clinically you can differentiate. Now next comes the X-ray. So this is the X-ray AP view. Can anyone tell me that what it is? Is it normal or abnormal? More or less, it looks normal. AP view is normal. Any other view? We have the lateral view. Again, normal. I don't know. This is also normal. This is also normal. We can send back the patient home. No, for lateral condyle, if you are suspecting that there is swelling, there is tenderness over the lateral condylar region, always get a oblique view. So it is mandatory to get an oblique view if you feel that there is suspected fracture, but the diagnosis is not clear. So this is the oblique view, this is the external oblique view, and this is the internal oblique view. Because the lateral condyle is placed not exactly lateral, it is posterolateral. So the fracture is posterolateral. When you rotate the hand internally, the fracture will be more visible. Like we do in the fracture neck of femur, we rotate it by 15 degrees. So that is the same principle here. So now you can appreciate the fracture here. There is a fracture of the lateral condyle on the internal oblique view. And now retrospectively, you can say that there is some haziness or there is some problem in the AP view too. So this is the importance of internal oblique view. Always get an internal oblique if you are in a doubt of diagnosing the lateral condyle. Now next talk about the management part. So we have the two varieties. It could be non-displaced, it could be displaced. So displaced and non-displaced are divided by the basis of 2 mm displacement. So if it is a less than 2 mm displacement in all the views, including the internal oblique, such type of injuries, the treatment is controversial. Two school of thought. Some surgeons say that go for non-operative management, wait and watch, just apply the immobilization. And the second school of thought is always operate. So I personally feel that you should go with our elbow slab or cast. I treat them non-operatively and check the X-rays every week. If it is going to displace in a later on follow-up X-rays, then go for surgery. If it is not, then continue the same for 4 to 6 weeks and the patient will be fine. The fracture will definitely unite. Displace, there is no confusion, no controversy. Always and always surgery, because this is fracture of necessity. If you don't treat, they will go into non-union, they will go into cubitus valgus. So it is the open reduction internal fixation is the treatment of choice in such fractures. Now surgery, how do I do it? Certain questions which need to be answered. That what should be the reduction, close or open, approach, choice of implant, how will I do the fixation, the pattern of fixation, pins to be left outside or inside the skin, immobilization for how long, and rehab protocol. So these are the questions to your mind, to my mind when I was the postgraduate. कि कैसे करना है, क्यों करना है, किस तरह से. So let's see one by one. So how do I do it? Reduction, always and always open. I always prefer open reduction if it is a displaced fracture. There is no role for close reduction. However, there is a school of thought that you can do the close reduction and percutaneous pinning, but I feel there are so many literature that always do the open reduction. Now the approach, the standard approach is the Thakkar's approach, the lateral approach to the elbow for the radial head, for the capitulum, for the lateral condyle. So this is the approach. You do the incision, you give the incision along the lateral supracondylar ridge and continue it along the joint and just curve it towards the radial neck. You dissect and the interval is between the ECU and the anconeus muscle. Many times when you open the fracture, if it is a displaced type of fracture, you will directly lead onto you will see the hematoma and there will be the breach in the fascia and you will directly see the fracture inside. Not too much of dissection is required in the displaced fracture. So when you give the incision, you see this picture, you will see the fragment. So this is the arm side, this is the forearm, here the tourniquet will be applied. And in these cases, always remember that, always beware that you cannot injure, you should not injure the articular surface. Because this is articular surface just beneath the fascia. If you are doing it blindly, just cutting with a knife, you can injure the articular surface. So beware about this. The second is, don't put any retractor in the anterior side. The anterior side, if you put the retractor, Oman retractor, I have put this Langenbeck retractor. So don't put your retractor because it can injure the ulnar nerve onto the medial side. Or if you are using it, Oman retractor, then be close to the bone. Remain close to the bone so that to avoid any injury to the ulnar nerve. And lastly, always dissect anterior to the fragment. Now don't dissect posterior to this. So I have not done any dissection posterior to this side. This side should be left alone. The soft tissue should not be touched because they can cause the osteonecrosis of the fragment because vascularity is coming from the posterior side. So always do the dissection from this line anteriorly, this side. And this is the joint you have to visualize. So always focus on the articular reduction. That is more important. Metaphyseal can be step because of the plastic deformation. So don't focus on the metaphyseal part, always on the intra-articular. Just 3-4 slides, sir. So don't dissect posteriorly. Just want to emphasize this. After approach, we have the choice of implants. So there can be the K-wire if the metaphyseal fragment is small. You can use the K-wire. If it is a large chunk, you can use the screw. However, I personally prefer only the K-wire, the smooth K-wires. They don't injure the physis. Pattern of K-wire, you can use the multiple pattern, the parallel, 2-wire, divergent, 3-wire, or screws. So I use usually the 2 parallel or divergent wire, as the previous session also emphasized that the need for the divergent wire. So always use a divergent type of configuration that is more stable. The pins outside or inside is skin. So there is a paper here and they have said that there is no significant difference between the infection rate between the 2 groups, but there is a high risk of skin erosion in the buried group and there is high risk of pin migration in the buried group. So I personally leave all the pins outside the skin. Immobilization for 6 weeks and rehab protocol after 6 weeks. You start the active or active assisted exercise. Don't go for passive because it will cause myositis ossificans. Complication, already I have told about this. So this is a case, 9 to 10-year-old child with fractured lateral condyle. I have done this open reduction internal fixation with K-wire and it healed in the 6 weeks. This is the 6 weeks X-ray and after 3 months, full range of motion, the supination, pronation and the flexion extension is achieved. Thank you.
Next is open for discussion. Already it's 2 minutes. So you always open discussion.
In displaced type of fractures. If it is displaced,
with some
4 and 5 mainly.
Then it is not always, right? Sometimes you will do post-reduction, you will after post-reduction also.
No. If it is undisplaced type, then I will do the non-operative management. If it is getting displaced during the treatment part.
So undisplaced is song 1. Completely displaced and rotated is song 5. What about 2, 3, 4?
2 and 3 also non-operative. I will go for
3 also
non-operative.
non-operative.
Yes.
So that is debatable.
Yes. That is controversial.
Okay. And another thing, you will immobilize for 6 weeks.
Yes.
So
Usually
yes, we keep KOS for 6 weeks, but we start elbow ROM after 3 weeks. Otherwise, it will become stiff.
Again, depends upon the fracture fixation. If it is stable, then after 4 weeks can be mobilized.
You should do good job. You should do stable fixation. But we can start earlier. Thank you.
Just to keep a caution. Yes.
And you use threaded wires or plain wires?
Smooth wires.
Is there any advantage of threaded wires?
They will theoretically there is an advantage that they will have a more purchase, but I don't think the threaded wire.
No, never to go. Never
Threaded
go
wire will injure the
because
physis.
that will physis will be destroyed.
Dr. Anurag, it was a nice presentation. So I also agree with Karthik that there is role of percutaneous KOR fixation also for undisplaced and minimally displaced fractures rather than opening or managing conservatively. So there is a middle way of percutaneous KOR fixation. When you are in doubt that it may get displaced and it's not very much displaced to do an open reduction.
And it is controversial, and there are 2 schools of thought.
Yeah,
That is very important. I think you must tell the students about the arthrogram because that will decide whether you will want open reduction or full reduction. So there is a scope. There is if the cartilage is intact, then there is a scope of doing even slightly displaced fractures. If cartilage is intact, then you may go for the close. Otherwise, if cartilage is not there and even if it's at less than 2 mm, so what you show is the conservative in the first X-ray. If cartilage is not not intact, then always go for percutaneous pinning at the first step. Dr. Rihan.
I think a wonderful lecture. I just wanted to know, in our own clinical practice, we get a lot of patients who are coming a bit late. Let's say they're not coming at, say, 6 weeks, but they're coming at 2 weeks or 3 weeks. And there is a diagnostic dilemma regarding whether you should get this fragment back or fix it or leave it and do it. So what is the opinion of the house? I would just want to have an idea about it. First from you and then maybe from the other people who are here.
Usually if the patient is coming late, maybe 3 to 4 weeks. And if it is a displace, then definitely I will go for open reduction internal fixation day 1.
If you cut off after so many weeks, I'm not going to.
Maybe 6 weeks. Beyond 6 weeks, there is no point because the fracture will be.
Sir, the cutoff for neglected fractures is 3 months. When a patient comes after 3 months post-injury lateral condyle, then we term the patient as neglected lateral condyle. And if the patient presents to you before 3 months, then we treat it as Dr. Anurag mentioned. And if the patient comes with any associated deformities, suppose elbow instability or cubitus valgus deformity or a tardial nerve palsy, then subsequently we stabilize the fracture fragment and whatever is required we do in the same.
Thank you very much. Thank you, Dr. Anurag. Now, next lecture is rash injury, something all must be aware of by Dr. Suresh.
Good morning, all, and I'm thankful to Professor Ajai Singh, sir, Rehan sir, and Prateek for inviting me here. And it's always wonderful to interact with all the friends and colleagues and juniors. I'll be presenting on elbow trash lesion, something all must be aware of. So it's a topic which signifies the old saying that eyes don't see what mind doesn't know. So elbow trash lesions are a kind of injury which we should know, and then only we'll be able to detect them. So I have no financial disclosures. I'll be thankful to Dr. Mannar and Dr. Sandeep for sharing their cases for this presentation, because all varieties of trash lesions even I have not attended. A few kind of them I have attended. So this was classical paper by Peter Waters. in 2010, they have mentioned trash lesions. So this full form for that lesions they have put forth is the radiographic appearance seemed harmless. So what they encase a variety of lesions where the first X-ray might be very normal looking, and we might miss that elbow injury as soft tissue injury, and in a later date we'll have a more complicated thing which will be difficult to salvage, and child will always be having a problem. So they have almost 7 to 8 variants or maybe types of trash lesions they have mentioned, and it is listed over here. And in subsequent slides, I'll try to cover all the things with the case examples as well. So this is another article in IJO which has described all the types of trash lesions one by one, and I'll try to go through each case. So the errors in management would be, first thing, we don't suspect it and we don't know that trash lesions are there and such entity exists, and we overlook the subtle things and we subsequently fall back with the elbow persistent pain or functional limitation, and then we in retrospect we diagnose that it was something fishy going on in the X-ray in the initial presentation as well. So this is the first case who presented with a fall on outstretched hand, initially reported as normal, but when the child had persistent elbow pain, somebody reported it as radial head fracture. So if we see in this X-ray closely, we see that there is something not well around the radiocapitular area, and in the lateral view also the radiocapitular line is not very well, which should go at the 1/3 level of capitulum. So if we do a higher imaging like CT or MRI, we can see that there is radial head compression fracture, and more than that, there is progressive subluxation of radiocapitular joint. So radial head fracture itself might be a harmless entity in a child, but the radiocapitular subluxation will definitely have worse outcomes in the long term, and missing such injury will have very bad results in the functional way for the child. So this was diagnosed at radial head compression fracture, which is one of the variants of trash lesions, and there is progressive radiocapitular subluxation. So this was fixed with open reduction and headless screws. Absorbable screws are preferred, but if not available, then we can use the classical Herbert screws as well. So the second case is 6-year-old girl who had elbow injury while doing somersault, and there was valgus thrust injury, and somebody diagnosed it as the medial epicondyle fracture, and which appeared to be very harmless, and they managed it conservatively. So after 3 months, patient presented with persistent pain and not regaining it, the functions, and on X-ray the fragment was visibly large this time, and it was actually a unossified medial condylar fracture, which was wrongly labeled as medial epicondyle avulsion kind of fracture, and that was managed conservatively. Now this required open reduction, and thankfully, because it was only 3 months, it could be fixed and the function was well. So again, this was missed as medial epicondyle avulsion fracture. Third case here is, we have been going through such cases earlier in presentations also. Typical history is a newborn child from NICU or PICU. We got a call that there was a difficult birth and there is elbow pain and swelling or refusal to use the limb. So somebody will diagnose it wrongly as elbow dislocation because the physis is weaker than the capsule and ligament. So elbow dislocation will be very rare entity in children, and the physis will give way before the forces go to joint and it dislocates it. So this is supracondylar, the transphysial separation, and the treatment is similar to supracondylar. If you have facility and child allows, you can put under GA and put K-wire fixation. If not, the situation doesn't allow and the child is very small, you can use gentle reduction and counsel the parents for the future cubitus varus deformity, but obviously it should not be treated as elbow dislocation. So opposite side X-rays are always helpful in treating the children elbows, and we should have comparative views whenever in the doubt. In these X-rays, we can certainly make that there is no doubt about the radiographic abnormalities in the elbow. So this was fixed, and we can always use arthrography to see the distal fragment and it will guide us in passing the KOS. So prognosis is just like supracondylar fractures, and the only problem is cubitus varus if there is any. The fourth case I'm describing here is 6-year-old child who presented to emergency as elbow injury, and somebody diagnosed it as the elbow dislocation, and simply close reduction was done and a slab was applied. However, this was the presentation X-rays, and if we see closely, there is something not usual in the medial side of the joint. And on higher imaging, there was incarcerated medial epicondyle, which was wrongly labeled as elbow dislocation and was reduced. And patient presented with persistent elbow pain and ulnar nerve palsy, and it had to be done open reduction. And while reducing it, the ulnar nerve got relaxed and it was fixed with screw, and the outcome was very good. So, fifth case is 15-year-old child who had injury while he was working in his fields, and the bull suddenly ran away from his hand, and there was some injury in the elbow, and somebody reported it as normal. Patient presented around 4 to 6 weeks later with the persistent elbow pain and restricted range of motion. And on first X-ray, it looked like some myositis is there in the anterior aspect of the humerus. However, on closed analysis, there is something abnormal in the lateral aspect of the X-ray. And on higher imaging, we can see that there is a shear fracture of the capitulum, and which has to be fixed. Obviously, approach and all will be a dilemma, and a simple anterolateral open reduction, just like in a lateral condyle, probably will be a sufficient thing in such cases. These are some of the intro steps, and it was fixed with Herbert screws. Obviously, in children, we cannot remove it, so if available, use bio screws. So this is a known entity of having a shear fracture in the capitulum. The last case I will demonstrate here is a 4-year-old child with injury on the elbow, fall on outstretched hand, and we can see that there is the radiocapitular alignment is probably not right, and the patient has persistent elbow pain. On higher imaging, we can see that in the capitulum area there is osteochondral injury, and in the retrospect we can see that the elbow alignment is also not very good. So these are the ossification centers around the elbow. We should always be aware of the things. And the anossified cartilage rupture or avulsion is a known entity, and it has to be fixed. So take-home message is trash lesions are set of injuries which appear harmless on X-rays, and a high index of suspicion is required. And these are the enumerated again, and we should always have these injuries in our mind. When the child has elbow pain, and we can always treat them as with the splinters, and we can always have a look back after 4 to 5 days, and the pain and the swelling is not subsiding. We can always go for higher imaging and rule out the trash lesions. This is again the summary of that article. Thank you.
Thank you, Dr. Suresh. Now, this lecture is open for the discussion. Maximum 2 questions will be taken. Yeah, Ravi.
Nice talk, Dr. Suresh. Well, for the sake of senior residents and postgraduates, I want to ask you just a few tips.
Yeah.
Because diagnosis is a big problem in these trash lesions.
Yeah.
So, with your experience or with your literature support, what are those tips that you give to the postgraduates and senior residents? That these are the few things that you can notice in these elbows, and you should have a high suspicion of diagnosing of the trash lesions.
Yeah. So if a pediatric patient comes in this age group and he has a typical history of fall on outstretched hand most of the time, and there is swelling and pain which suggests that there is something fracture kind of thing, and you get an X-ray where there is nothing there. So probably you will suspect something and you analyze the X-ray again, and it's okay to miss these findings, but I'll apply a slab and counsel the parents to come back after 3 to 5 days. By that time, the soft tissue injury should have subsided, and I'll take examination again and I'll analyze the X-rays again. At that moment, if there is persistent pain and swelling, I'll try to go for higher imaging, because without the help of higher imaging, it will be difficult to diagnose. And it's always to err on the side of over investigating in such cases rather than missing it and later repenting that we cannot do anything.
Why should we go for a higher image at that time of presentation?
So because if you go for MRI or something, because it will need sedation and everything, cost issues are there. And in our country, we need to look at the practical issue of having MRI in small city. So it's safer to have a slab and look at 3 to 5 days, because within 5 days there is nothing we are going to lose, and we can always have a look. But yes, on a day one, you suspect something is fishy, yeah, you can go for directly for. I'm not saying deliberately you delay, but if there is the dilemma and there is no complete evidence of trash lesion or something like that, you can always have a relook. But don't say कि soft tissue injury अभी 2 हफ्ते बाद आना and then you have nothing to do.
Moreover, I think, sir, an early MRI will have a lot of hematoma, and the definition of the lesion will also not clearly demarcated by the radiologist also. That's also one of the points to
Whether we should go for CT or MRI?
So MRI is better because all the problem is here is non-ossified cartilage. So the MRI will be always be better, but depending on the practicality, the CT will be better than having nothing. And
It's
if
not visible on X-ray, it's not visible on CT. Dr. Suresh, I think again arthrography is a good option.
Yes,
for
yes,
this
yes.
disease. Anyways, MRI will need sedation.
Yeah.
So, and you need some kind of intervention, some close reduction. So it's better to take the child with get an arthrogram done.
Yeah.
We get better results.
Suresh, one thing I want to add that now in this era of high resolution ultrasound, it is always better you go for high resolution ultrasound even in a slightly elder patient, because the high resolution ultrasound will tell you about the discontinuity of the cortex. If you are getting the discontinuity without any collection, then of course you can go for CT, go for MRI. Otherwise, I mean, not always going for MRI, because MRI would be, not technically viable. Number one, orthography. I feel if you are not having any disintegration, then penetrating into the joint is not a good idea always. So high resolution ultrasound should also be tried.
Yeah, I agree, sir. I think the message should be that trash lesion should be kept a differential, and the higher imaging, whatever is practically available, should always be.
Thank you very much, Dr. Shah, for the radial neck fractures.
I'd like to thank the Department of Orthopaedics in Bhopal for inviting me again over here. Now, this is a topic which commonly is matter of considerable debate, as well as I have tried to simplify it in my talk by not going into the technical details of the various papers and what the different authors mentioned, but to make it simple for the SRs and our junior colleagues to make a decision based on the X-ray. So it's a relatively common traumatic injury, and usually affects the radial neck in children above 7 years of age, though in younger age also you might get these fractures. Now, plain radiographs of elbow and AP and lateral are most of the time sufficient to diagnose these fractures. Treatment is non-operative, operative. We'll come to the details of that. That is the crux of the talk. And it depends mainly on degree of angulation, translation, and displacement. So remember this 3 terms. You have to see for angulation, translation, and displacement. I've kept this slide immediately in the beginning. This is a classification by O'Brien done long back. This classification itself forms the crux of our decision to whether operate or not operate. Remember this classification. Now, when you have an angulation of less than 30 degrees, you are looking more at a conservative approach. Whereas when the angulation goes beyond 45 degrees, you are looking at an operative approach, depending on your post manipulation reduction. And more than 60 degrees is most of the time definitive indication for fixation. So I'd like you to go through this image because the discussion will be mainly case-based, and we will be going through rapidly through all the X-rays because the fixation techniques will also be discussed in very brief in the coming slides. There's another classification that is there, though this is just being put over here to make you understand the amount of displacements which you can encounter in these fractures. Now, indications of fixation, I have just bottled them up and tried to keep it as simple as possible, but there are other factors also, which is beyond the scope of our junior colleagues. We can discuss that later on. Now, greater than 30 degree following a closed reduction. So as mentioned over there, once you reduce these fractures, then if you are seeing that the angulation is still, is normally, if you see that the displacement is more than 30 degrees, you go for a closed reduction. And in case of more than 10 years, you can accept less than 15 degrees. Can anyone tell me why we accept less than 15 degrees when the age is beyond 10 years? It's a very simple question, actually, just to get our juniors involved. What is the reason? Someone can stand and just tell. I think people have been very quiet, actually. Exactly. It's a reduced remodel. Now, greater than 3 to 4 mm translation, I think in all the fractures which have been discussed so far, it is an indication for fixation. And when you get a restricted pronation and supination, that is also an indication for fixation. Now, open reduction, when after a close, when you have given an attempt for a closed reduction, if a fracture that cannot be adequately reduced to less than 45 degrees, angulation with closed or percutaneous methods, you have to do an open reduction. But you should also know the pitfalls. There is always a loss of motion. You should counsel the patient accordingly that there will be a loss of motion if you're going for an open reduction. Increased rate of osteonecrosis of the radial head and risk of synostosis. This is an acute injury. Can anyone make out anything from the X-ray? This is the first X-ray which I had when the patient presented to me. How many see some displacement? Though the talk is on radial neck fracture, how many see a displacement? You can be honest. You can raise your hands. How many are seeing any displacement or think that there is an injury over here? This is the follow-up at 2 weeks. So you can note a small bowing over there on the lateral aspect, which was suggestive that this was a radial neck fracture. So this was the X-ray. Luckily, I had done a proper clinical examination and I had put this patient on an arm sling. So when he came, we continued with that because again, if you'd have gone for a cast or a fixation, it might have led to significant stiffness. So always be ready for this. The treatment here is definitely conservative because the angle, there is no angulation as such. That's what you need to understand. Now here is a 10-year-old female. What is the angulation roughly? (30 to 60) around roughly. So this is the plus minus. But as I had already mentioned that this is around 10 years and a female. So in these cases, we have to be a little bit more aggressive. And this is the technique that I used for reduction. Luckily with closed, I got the reduction and then it was fixed. It united at 5 weeks and recovered full pronation and supination. And I'm an advocate of a little bit early mobilization providing this. You can make out from the X-ray that we have accepted a little less angulation, or a little bit of angulation, which will be the why we have accepted that. I'll be mentioning at a later talk. Now coming to a technique that we use, which is known as a Menzies technique. This is my case. This one had a radial neck with ulnar shaft. We used a Menzies technique in this. And so in this technique, what we do basically is we try to engage the radial neck fracture and then we rotate it 180 degrees to get the reduction. But I think this has been well demonstrated in our various presentations, but it is easier said than done. it is not very easy to do. So if you get a proper close reduction and you are able to reduce it by joysticking, I would request you to stick to that technique initially. Medzio is a technique which I think maybe our seniors will be in a better position to tell that whether they are doing it, because we still find it difficult to reduce. Now, this is a 14-year-old female, neglected case, almost skeletally mature. This came to me at almost 6 weeks. Now, since I had plans to conserve the radial head over here, we opened it up. This was almost rotated by 180 degrees and fixed it with KYs. Now, why I have put this X-ray over here, though it is not an ideal fixation technique in nowadays, because this was the technique, or you might have to use a K-wire in certain cases. And the fixation might be a crossed one, which I have said, which I have put over here, or you can put 2 K-wires, because holding it in reduction is what is required over here. Now, these are the certain special mentions for our junior colleagues, and that it is almost never a head fracture except for the thrash lesion, lesion just mentioned. Extension and valgus stress is the commonest cause. If you have a 180 degree of flip, you have to open and reduce. And remember, when you are opening, you should be telling the patients that there will be some restriction of the movement. That is the counsel, which is the part of the counseling should include that. If you get a full movement, that's definitely the grace of God, but invariably, you should be ready for that. Loss of motion in 30 to 50% of all patients. So again, what I just mentioned, you need a proper pre-op counseling and cast for 2 to 3 weeks and start ROM exercises, because these fractures are very prone to stiffness. Salter-Harris type 3 and 4 are rare variants. They require audit. Again, coming back to the same point that it will have poor results. Now, there are a lot of studies which suggest that attempting close reduction after 5 days and everything is not indicated, but technically we wait for almost 10 days and that, then still you can go for an attempt for reduction. And in case of severe neglected cases, radial head excision has been advised, and they have reported good results, but again, this is a controversial topic. So thank you. I would like to especially thank Dr. Ajai Singh, sir, for inviting me over here. He has been like a mentor to me for the last few years. Dr. Rehan, sir, for inviting us and being such a grand host to us, and Dr. Pratik for organizing such a good. This is my institute in Kolkata. This is the oldest pediatric hospital in the country. It was established in 1952. I'm working over there, and this is my guru over there, my boss, Professor N.K. Das, sir, who was one of the founding member of POSI. So if anyone wants to develop operative skills, sir has a huge volume of cases. He has an experience of almost 15,000 CTEVs alone in his 35 years of practice. So anyone wants to have a good orthopedic, pediatric orthopedic exposure, we can definitely arrange that in the institute. Thank you so much.
There is open for discussion.
When you remove the tents, can the tents be left outside?
We normally, what we do is we keep the tents, the usual technique for tents is to keep it buried to that level in which it will not be difficult to extract. It's the same as the forearm fracture and that.
Because I think that reduction is tough. I did this technique once. So it was difficult, as you said.
Difficult with the Medzio technique.
Yes, sir.
Yeah.
So when I put the tents, it was outside. So I thought I was not.
Outside means what? Like
the skin. So
oh, okay.
So okay. I didn't want to manipulate much. Yeah,
that is like the cutting the tents. That is a technique which develops over time. That's all I can say to you. That it's better to keep it buried inside. Never, because what approach are you using? Are you going through the styloid or through the posterior this thing? Styloid only. You can think about going a little bit posterior through this thing, because superficial radial nerve injuries have been documented. We have also gradually shifted from the radial styloid approach to the posterior approach now. Roughly, we normally at 5 to 6 months. Roughly.
One more question.
you showed the technique of KY fixation of that. Is there any risk of injuring the posterior introitious nerve with the KY?
Yes, there is a risk of injury of posterior introitious nerve, and that is what, like in this, the joysticking technique which we use to reduce that. I'm intentionally not shown that because I'm not a big fan of that. It actually damages the physis more. There is a physis over there, and basically the posterior introitious nerve is a little bit more anterior in the children. So it is preferable. As you can see, the KYs were all from the posterior side and that. So that is the technique which I used because I wanted to save that head anyhow. But preferably you can use a titanium elastic nail with your reduction maneuver.
After open reduction, how do you fix it?
So it depends. We can use this thing, titanium elastic nail, and that if we can get a reduction, or we can put to this thing, KYs as well.
After open reduction?
After open reduction, so we can use a titanium elastic nail also because we're getting titanium in that reduction.
Thank you. Thank you, Dr. Abhishek.
Thank you.
Now, I invite Dr. Pratik Bahera from Montegia Legions, always a card challenge.
Good afternoon, respected seniors and colleagues. After going into the lesions around the elbow and then proximal part of the radius, let us discuss something about Montegia lesions. But these Montegia lesions are actually injuries of the ulna. Along with that, there is a radial head dislocation from the proximal radioulnar joint. And it has a more than 200-year-old history. The first being described in the year 1814 by Montegia. Then in 1844, Cooper came up with some sort of a classification which underwent many modifications. But we should be thankful for Jose Bardo from Uruguay, who actually described his results. And after that, his classification is what we are using even today. Basically, why should we discuss it? Well, this is not very uncommon to find children coming to you with lesions like this, with deformities like this. And the moment you get the X-rays, you find out that there was an injury which was probably either missed or not identified or not managed properly. How does a child present? Well, there is a history of fall on outstretched hand or fall from substantial height, at times in polytrauma patients also. And examination must include the note of any deformity at that time, the 3 A's, as Dr. Karthik has already emphasized, and neurologic and vascular status. Once we have done this, we have to understand this basic relationship of radius and ulna with each other and radius and ulna with the distal part of humerus. So the radius and ulna practically are two bones, but they act as a single joint type of thing with a proximal radioulnar joint, an interosseous membrane, and a distal radioulnar joint. The capitulum of the humerus articulates with the radius in all the positions when the elbow is moving. So there are times when patients will come to you with history, you get the X-rays. Do you think these X-rays are enough? Are they sufficient? If you are happy with just looking at the fracture over ulna and with forgetting the basic principle of getting X-rays of one joint above and one joint below, then yes, you are okay. But the moment you get X-rays one joint above and one joint below, you will find that you have actually missed out a lesion in the distal part of the humerus, in the proximal part of forearm. And when you get the X-rays, what are the things you are going to look at? You have to look at for obvious relationship between the radius and ulna, relationship if there is any obvious fracture or not, and the relationship of radius with the capitulum. And this relationship is what is classically being identified with the help of what is called as a radiocapitular line. And this line is, it has been classically described to be drawn along the long axis of the radius. But recently there are papers who have reported that this might not always be true. And that this radiocapitular line might not be a good idea if it is drawn along the long axis of the radius. Why? Because there are about 16% of radiographs in which even in a normal elbow, if you draw a line, so this is an unrelated case, not having any sort of Montegia region, but if you draw the radiocapitular line along the shaft of the radius, it is going to miss the capitulum. So the new line has been described. What line? Yes, the radiocapitular line, but drawn along the neck of the radius. So this line has been now proven to be better for identifying your radiocapitular alignment. And this is because there is a definite angulation between the proximal part of the radius in the neck and the shaft. This angulation is about 16 degree and you get and miss the diagnosis in 16% of cases. So once you have done this homework and you have identified that there is something wrong, there is a fracture in the radius, there is a fracture in the ulna, there is a dislocation of the proximal part of the radius from the capitulum, then you focus on management. How do you manage? Basic idea, basic concept, first classify. How do you classify? Presently accepted Bedo classification. There are two aspects which you have to look. One is the angulation of the ulnar fracture and direction of displacement of the radial head. So based on this, apex anterior, ulnar fracture, direction of radial head dislocation anterior, type 1. Similarly, posterior is type 2, lateral or radial is type 3, and rarely when both radius and ulna are fractured and the radial head goes in any direction, that becomes type 4. Along with this, there is a group of lesions which we label as Monteggia equivalents. So these are the lesions where you cannot you cannot fit them into any of these criteria, but they have a radial head dislocation, there is a fracture. After you have classified, you must know what are you aiming at. So our aim is to reduce the ulnar fracture to regain the length. We have to reduce the radial head dislocation and maintain this alignment till the fracture heals. How do you do? Well, at present, the accepted guidelines and in the recent international course lectures, Ring and Waters have used the description by Ramsky, and what they have described is an ulnar-based approach. So how do you decide? You decide by looking at the fracture of the ulna. Is the fracture of ulna incomplete? Is it a green stick or plastic deformation? No worries. If this is the scenario, simply do a close reduction, but keep the patient under follow-up. If the ulnar fracture is a complete fracture, but it is length stable, that means either a transverse or a short oblique, an intramedullary nail into the ulna, and then addressing your radial head dislocation is the way to go. If your fracture is complete, but it is length unstable, either comminuted or long oblique, then you go for plate fixation. So this is a description by K. Wilkins. He was the primary proponent of non-operative management, but what he has described is beautifully is the way you have to reduce. So the 3-point fixation technique, you reduce the fracture in type 1. After that, because it is type 1, you have to decrease the pull of the biceps, you flex the elbow. Ulna, you reduce it by countering the direction, but to maintain the reduction, you extend the elbow. For type 3, you have to reduce the radial displacement, you have to give a valgus push. Once you have done this thing, the management for non-operative management is a long arm cast. These are the different positions. For type 1, it is a flexion, type 2, it is an extension, type 3, extension with a valgus movement. But in all of these, what is important is this one. Close follow-up, weekly x-rays, check if there is any displacement happening or not. Let us go through a few case examples. So this is a case of a child in whom there is a complete fracture, but it is a transverse fracture. So we were able to obtain this reduction, fix with an elastic nail, and obtain a union in proper time. This is a child who has a relatively long oblique fracture. When we tried to attempt the reduction, because in order to maintain stability, we went ahead with the plate fixation. So can a child present late? Yes, it is very common in our country. When can the child present late? If the consultation was not sought in time. Very common in our villages and backward areas. Parents, they sought treatment, but unfortunately, the clinician failed to identify the lesion. There is a plastic deformation of ulna, which the clinician was not able to pick up that and diagnose it as an isolated radial head dislocation. So late presenting children, they will present with a deformity, invariably either varus or valgus. There can be presentation in the form of movement restriction, chronic pain, and at times ulnar neuropathic symptoms. In this scenario, the principles of treatment will be first classify. You can use the same Bedo classification to classify, assess the alignment of the radiocapitular joint, assess the overlap, then you have to define for your surgery. What surgery? You have to go through Boyd's or Cocker's approach, ulnar osteotomy, and regaining of ulnar length is the primary aspect. This can be done either immediately and fixed with a plate or gradually. After that, if required, you have to do a reduction of radial head by open technique. Then you have to stabilize the ulnar osteotomy with either a plate or fixator. Finally, if required, you have to stabilize the radial head by sling procedure if it is required. Not always. So let us go through this example. So this is a child, the injury has been missed. When the child came, it was already 3 years down the line. But when we assess, what we find is that there is a missed Monteggia lesion. When you do the Mubarak's line, you clearly find that there is a bowing of the ulna. And then you assess the amount of deformity. Here I measured the deformity was 10 degrees. So what did we do? We went through the Paeds approach. We can see the radial head in the depth of the wound, capital M lying over here. Next, what we did? We use a DCP. We bent the DCP. The amount of angulation provided is twice the amount of angulation which we measured. It is not described anywhere, but this is what I learned from my seniors and colleagues. So after that, we put the first screw as near to the coronoid process as possible. You open up the displacement, so you open up the osteotomy, assess whether the radial head is reducing or not. If the radial is not reducing, you may have to increase the amount of angulation, even put in some amount of distraction. After that, the radial head is reduced now. We were able to restore the radial alignment, and this is what the osteotomy looks like after healing. So it is not always that how do you decide where do you do the osteotomy and where do you put the plate, how do you put angulation in the plate. So it depends on where the apex is. If the apex is lateral, the angulation in the plate has to be just opposite, it has to be medial. This is one of the examples where we performed an osteotomy, same osteotomy, but the angulation was according to the angulation in the deformity. So finally, these are the few papers which suggest that reconstruction of annular ligament is not always a necessity. You have to assess whether the reduction is stable. If radial head is well reduced, then you can go away without doing any reconstruction of the annular ligament. In summary, timely identification of the ulnar fracture is the first step to identify whether the lesion is Monteggia or not. You have to look at the radiocapital line to clarify your doubts. Retention and reduction of both ulnar and radial fracture is important. And in late presenting cases, you can go for surgical management, and that primarily requires an ulnar osteotomy and radial head reduction, which can be done either acutely or gradually, as and when it is required. Thank you very much.
Thank you, Dr. Patil, for a wonderful lecture. First question I'll ask you, in blade presentation, when you have done osteotomy and everything and reduce the head, will you reconstruct annular ligament with the fascia or not?
So the answer, I tried to answer that here also, but probably the lecture was quite very fast. I ran through slides. So the answer is, it is not always essential. You have to first reduce the radial head and you assess the reduction, whether that is stable or not. You take the elbow through entire range of motion, flexion, extension, pronation, supination. If you are finding it is unstable, then you have to reconstruct. Otherwise, you can leave it as such. And there are many papers. Even Dr. Atul Bhaskar has presented a very large series from India only, in which he did not actually need any reconstruction. And all the elbows, they went on to do well. So it is not essential. The decision has to be done on table after you have done your osteotomy and reduction of the radial.
Even when you are reconstructing the annular ligament, then you have to fix the head to the capitulum or something like that?
No, sir.
There is no need.
If you are already reconstructing, that means that you have gone to that level where your radial head is reduced. Now you are bothered about the stability of the radial head while you are taking the elbow through the range of motion. The radial head reconstruction, annular ligament reconstruction is to ensure that your pronation, supination movements are fine. So it is not necessary to fix again.
Just for residents, so most of the time it is missed in our country. So you should have a clinical suspicion and you should take a proper true lateral view. If you don't take the proper true lateral view, most of the time it will be missed. It's because of the poor quality X-ray or not taking some oblique view, you may miss this process. And another point is for how much angulation you will give, sir, because how will you calculate how much angle, if you want to bend the plate, how much you calculate?
So actually there is no clear-cut guidelines how much you should bend. So what I have in about 8-9 cases which I have done, what I realized was that when you measure the angulation, which you can do by measuring line, drawing the line along the two parts at the level of angulation on the ulna, you find out how much it is angled. You double it. So in the first go, I simply double that angulation. And if it is stable enough, that is fine. If not, then you have to further increase.
So another trick is some people use intraoperative radiocapillary wire, and how much the angulation intraoperative ulna create, they will bend and they will remove the wire later.
Okay.
So that is one fix. And we use just, we don't use always over. We use just 70%.
So but just is one of the ways in which you can do a gradual one.
Yeah,
but if
you can do lengthening also.
Exactly. But if it is something which can be achieved acutely,
yes,
then it is probably more comfortable for the patient.
Plate of bends totally.
Thank you, Dr. Pati. I think we are running already short of time. Now I invite Dr. Suresh Chand and Dr. Ravi Chauhan for BB FA fracture in adolescents. Conserve or operate. Debate for 14 minutes. I think you're taking 7 minutes each.
Yeah, I will try to explain. So I'll be talking regarding the forearm fracture in adolescents, and I'll try to justify the conservative approach and its place in current era. So I don't have any financial disclosures. I have shared took some cases from our seniors to show here the results of close reduction in adolescents. So this is a 14-year-old child who presents with closed fracture, both bone forearm, shaft of the ulna and radius, and there is no distal neurovascular deficit. And as I mentioned, there is no compounding or any wound. So how many of will think about doing a casting and close reduction, and how many will directly go for TENS? Cast. I think there are few friends of mine here who are choosing casting, but most of the, I mean, in current phase, most of the teenagers and adolescents are directly undergoing TENS fixation to have more predictable results. But I'll try to convince that there is a role of conservative approach also. So pediatric forearm fractures are quite common in teenagers, and it has been described that the incidence is higher, almost double in the school-going age when we compare it to toddlers. So obviously, clinical examination is a must, and rule out all the compounding injuries or neurovascular deficit and the compartment syndrome. The neurovascular examination may be tricky in children, and a close observation and repeated examination may always be required to rule out the neurovascular injury. The representative X-rays are very necessary, and as described in previous talks, that the proximal joint and distal joint should always be included, and there should be a true AP and true lateral view, so that we don't miss just the angulation, and the acceptability criteria is based on the angulation, and reduction is based on the true AP and true lateral views. Here is an example which shows that a true AP and true lateral can have a different picture when we have an oblique or not so perfect picture. So concern regarding the forearm fracture in adolescents is malunion. So this is classical picture from the Rockwood, that the motion of radius is in a conical fashion over the ulna. So there is a certain arc where the radius moves in the pronation and supination. So if a malunion happens, obviously this arc will reduce, more so when the remodeling capacity is less. So this is our first concern. The other concerns are stiffness, probably not so much in children. Osmosis issues, because forearm is not much covered with soft tissue, and the ulna is subcutaneous bone, so the osmosis might be an issue, just like in this case where the radius is too much bore and the patient is worried about the osmosis, and the limited remodeling potential in the adolescent. So this is a tabulation from Matthew et al., which shows that how much of range of motion is lost when there is a deformity. For example, if there is 10 degree of deformity left in the radius or ulna, there will be insignificant loss of supination or pronation, roughly less than 3 degrees. However, it goes up to 40 degrees of restriction in both planes if there is 20 degrees of deformity in both radius and ulna. So it gives an idea about the approximate acceptability criteria, as well as the decision making in adolescent where there is limited remodeling capacity. Also, the ulna is subcutaneous bone, so it is more susceptible to cosmetic issues, and the radius is because it is moving over the ulna for the motion as shown in the previous slide. So it is more sensitive to rotational problems than the aesthetic issues. So the final decision will be obviously depend on the site of fracture, because the distal probably will remodel more. The type of fracture, I mean the transverse will have more stability rather than a comminuted or long spiral fracture. Any soft tissue interposition which is hampering our acceptable reduction and growth remaining. So remodeling happens at the distal area, and for the radius it has been classically described as 10 degree per year. So after 12 years, probably there will be very limited remodeling capacity. That is what we are concerned here. Some remodeling also occurs from the lengthening, because the length of bone itself gets increased, so the deformity is percentage wise less. So again, this is also limited in the adolescent. And intramembranous apposition on the concave side and resorption on the convex side is also one way of remodeling. Again, that is may be limited, although it is not related to physical growth. So here is a tabulation of pros and cons of cast and surgical treatment. Cast has benefits of having long-term track record without any complication of wound infection, and it is without probably having too much of surgical intervention. And it has cons of its own, having no control over the reduction failure, and the frequent follow-ups are always required in adolescents. So if I go regarding the AO philosophy regarding the forearm fractures, they treat adult suprachondral, adult forearm fractures and intra-articular fractures, and they recommend articular fixation, anatomical fixation, and they recommend plate fixation in most of the cases. So the trend is going towards surgical fixation in adolescent forearm fractures as per the AO recommendation for adults. So is there any role of conservative? So few situations I feel where the conservative is still have a choice, and I will try to enumerate them. Undisplaced or minimally displaced fractures, middle or distal half of distal 1/4 of shaft or the distal forearm fractures, stable pattern like the transverse fractures, obviously having a 2 year of growth left, like a 13-year-old or 12-year-old boy will have definitely better chance of conservative rather than a 12-year-old girl. And a thin built child having a narrow canal where we cannot put a TENS. And again, a fitness issues for a surgical fixation. So what are the points to remember while doing a forearm fracture by conservative approach? We should look at the bow of radius. We should look at the rotations. We should look at the overlap of the bones at the fracture site. We should look at the angulation and the displacement. So radial bow is maximum at the 60% of the radial length, and the rotation is described by Rang et al. That the radial styloid is always opposite of the bicipital groove, and there is a crossover sign that in the supination it is crossover at the proximal 1/3, and in the mid prone position it is at the distal 1/4, and in the supination there is no crossover. If there is any discrepancy, there will chance of malunion or malreduction, which should be seen. This is an example where the crossover sign was missed and we have a malunited forearm, which is probably not acceptable in adolescent. The overlap is again a small amount of overlap is acceptable, and angulation, which is roughly estimated that 10 degree in upper, 15 in mid, and 20 degree in lower is acceptable, considering 2 years of growth remaining is there. So if I summarize the acceptability criteria for adolescent, which is the topic here, so 10 degrees of probably angulation and 30 degrees of malrotation if we can assess, and almost 100% of displacement is acceptable. So tricks to improve the outcomes of casting are well selected case. So I'm putting very limited indications for close reduction. A good casting technique and molding is no replacement for any other thing. Wedging options should always be kept in mind, and compliance and follow-up should always be there. Otherwise, we cannot determine the outcome. So the principles of good forearm casting are intraosseous molding, supracondylar molding, and the radius. So 3-point fixation should always be there. There should be thin padding, a stockinette followed by a ready-made soft roll, cotton roll should be applied. The cast material should be evenly distributed. The ulnar border should be straight, and the cast index as described by Chess et al. Should be less than 0.7. So the debate will always be between above and below elbow. So for shaft fracture, there should always be above elbow. The elbow should be flexed. Supination or pronation. The volar apex should be kept in the pronation, and the dorsal apex should be kept in supination. Although the classical teaching was that the proximal forearm should be kept in supination and distal should be in the pronation. So these are our common adverse outcomes when we treat the children with close reduction. We should keep this in mind. A few articles are there which justify the close reduction, and they have described a favorable outcome without much of issues in the long run. So this is the example which I discussed. I will finish my talk with this. So this was treated with close reduction based on the narrow canal, and the TENS was not able to, there was less chance of passing TENS. So we just did the close reduction. And in the follow-up, we had very good outcome, and the child is functioning very well. These are the functional things. Thank you.
Dr. Ravi. Continue, sir.
Good morning, everyone. Thank you, Ajai sir, for the invitation. And I remember in 2019 May, I have conducted a postgraduate teaching program for pediatric orthopedics and served as the course director for that program. And since then, I'm with sir. So really thankful, sir. And I'm really thankful to Rehan sir and Prateek and the whole organizing team for the kind invitation. So coming to my topic, that I think my friend Suresh has spoken a lot in favor of me, operative, as compared to these non-operative treatments. So my topic will be both bone forearm fractures in adolescents, and I will be speaking on operative treatment, why I consider it more factual, more reasonable in this adolescent age group. So to begin with a disclaimer that I'm not a die-hard fan of nailing or a plating in pediatric orthopedics. And I do respect biology as much as other pediatric orthopedics do. But with a saying that what is right is not always popular, and what is popular is always not right. It was rightly said by Albert Einstein. So it's not necessary that whatever is the common, traditional and vegetarian view is always right. As compared to the other view, which is more factual, which is more logical. So if we speak about both bone forearm fractures in adolescent age group, then these are the fractures mainly of the radius and ulnar diaphysis. And these are the third most common fractures in pediatric population. That's why we are speaking about it. And the peak age, unfortunately, the peak age of incidence of these fractures is 9 and 14 years in boys and girls more than 9 years. This is the age group which comes into the adolescent part. So definitely that's an coming to its anatomy. There are various muscle attachments, proximal and distal ligament attachments, and the interosseous membrane and the radial bow. These things are very vital for the restoration during our non-operative treatment. So if we are skilled enough to restore these things, then definitely non-operative treatment can be a solution, but there are chances of much failure. So definitely the restoration of radial bow, as pointed out by Suresh also, that it has to be restored in a proper way. Okay, so coming to the remodeling potential, another thing that Suresh has highlighted about, that he himself said there is very limited in adolescent age group. So definitely patient's age is not in favor of non-operative treatment in this part. And also the fracture pattern, which is mainly the displaced and complete fractures in this age group. So coming to the decision making, how we decide in this, the major considerations that are two types. One is the patient-specific considerations, and another are the surgeon-specific considerations. So what are those important things which we consider about the patient? Definitely the age group is more important, and fracture pattern and its position. Position I can consider in the diaphysis, but fracture pattern is much more important because the 100% translation and displacement is not a good thing for us to consider the non-operative treatment, and the remodeling potential that is also not in favor in this age group, which is very limited and minimal. Coming to the experience and expertise, definitely if there is a both bone fracture and other sir is doing and some senior pediatric orthopedic surgeon is doing, he can restore those anatomical considerations. But if some young surgeon is doing and even the other people are doing, that they may not be able to restore the anatomy to that level as compared to the senior person. Then definitely the surgeon's experience and his expertise come into view of management of these fractures. Non-operative management, the whole crux depends upon the accuracy of reduction, stability of reduction, as well as the remodeling potential I have already pointed out. And there were the acceptability criteria that were given by the Noonan and Price in their landmark paper. And you can see in this paper also, they have said that more than 2 years of growth should be remaining. So if we are considering the late adolescent, then definitely that much of growth is not remaining. So coming to the obvious reasons for the operative treatment, these are the obvious reasons like unacceptable reductions, loss of reductions, less than 1 or 2 years of growth remaining, open fractures, and pathological fractures, which are relatively new neurovascular injuries, ipsilateral humerus fractures, means along with the forearm and the humerus fractures are associated. In this, we are not having any controversy. So coming to the adolescent, they have less remodeling potential, definitely. Distal is 75%, and complete and displaced fracture patterns I have already pointed out. So definitely this group of population, they are a bit hesitant to board the flight of non-operative treatment. They have the reason for it because of their less remodeling potential and because of their completely displaced fracture patterns. That's why they are not ready to board the flight of non-operative treatment. In the absence of insurance policy of remodeling potential, if you are not having that insurance policy and your accident-prone fracture pattern is there, then definitely you will not be comfortable in boarding that flight of non-operative treatment. So let's, and literature is also in support of that. If we see this paper, there's an 11 experience, then in this, you can see that there is an increasing trend towards the operative treatment. And the observations about this paper that the mean age of the patients treated operatively was 11.2 years. That whatever the amount of patients that they operated or the failed the non-operative treatment, maximum of them were of the adolescent age group. And therefore, they recommended the low threshold for the operative fixation. Coming to the another paper, that what are those factors that predict the instability in pediatric diaphyseal bone forearm fractures? You can see here that age more than 9 years is one of the important factors in predicting the instability. Okay. This paper also that non-operative treatment of both bone forearm shaft fractures, predictors of early radiographic failure of the JPO. In this, you can see the odds ratio for the age more than 10 years is 3, proximal fractures is 6.81. Then definitely age is not in favor of us. Literature is also supporting that. Coming to this paper, predictors of conversion from the conservative to operative treatment of pediatric forearm fractures. In this also you can see the most significant predictor of conversion to operative management is the age at the time of injury. So definitely age is not in our favor. Coming to this paper, this has also suggested that increase in the surgical treatment of forearm fractures was seen most drastically in the 8 to 14 years of age group or 15 to 17 of age group. So, and this was one of the important papers that predictors for operative treatment in pediatric proximal third fourth bone forearm fractures. In this also you can see that the age of the patient, amount of initial fracture displacement are the two important factors that predict the bad outcome in this age group. And similarly suggested by the Walker et al., Moman et al., and Thomas et al., they all predicted the same things, that the initial translation and the age group, which is not in favor. So let's have a balanced approach. Okay. Algorithm for both bone forearm fractures in adolescents. If we are having such adolescents in this age group, and so definitely what I follow, that I give an initial reduction attempt. Okay. And if I find my fracture to be unstable, or I am not finding my comfortable enough that to reduce that fracture, then definitely I opt for the operative treatment in this age group with a very low threshold for the operative treatment. Even if I find the fracture is stable and acceptable, then I depend on two things: proper counseling and the caution to the parents that I will go for the non-operative treatment. I am more in favor of operative in this age group, but if you want to go for the as the fracture is stable and acceptability criteria I am having, then definitely we can go for the non-operative, but with a caution that in coming future it may be converted to the operative if we lost the reduction. Okay. So during follow-up, if I find the stable and acceptable reduction, then definitely I continue with the non-operative treatment. But if during my follow-up there is a loss of acceptable reduction, I go for operative treatment. Okay. So the art of war. There's a famous book by Sun Tzu. You all must have heard that if you know the enemy and know yourself, you need not fear the result of 100 battles. Your enemy here is the fracture pattern, is the age, and yourself, your capability of reducing the fracture, your capability of taking out the acceptability criteria. Okay, so to conclude with, I conclude with my disclaimer first slide, that though I am not a diehard fan of the nailing and plating in pediatric population, and I do respect biology, but it's better not to hesitate to use your weapons when you know your enemy has no or very little respect for your client attitude. Thank you. And in the last, I want to invite you for this basic Ilizarov course that I'm conducting in coming September, on 9th and 10th of September in Delhi. This is a 2-day comprehensive Ilizarov workshop, which consists of Ilizarov frames as well as the rail fixators application on tibia as well as the frame, and Dr. Mangal Payar will be the course director. Thank you.
Now, so I invite both the speakers to on the dais, and now it's open for this debate is open for the discussion.
Dr. Naveen, which implants you use and why? Your preference on it.
Sir, regarding to implant, if the age is less than 10 years, then I prefer TENS. Otherwise, more than that, I go for plate sometimes.
Any other question?
What about artificial damage in male?
Sir, you mean TENS? We are not violating the physis. We are just doing it extra physis. So entry point is extra physis.
Lower third fracture.
In lower third, I use the antegrade part from the proximal part in radius of Allah.
Radius also.
In radius, sir, if it is at that metaphyseal diphyseal junction, then definitely I will use the plate, not the TENS, because TENS is not a good idea. Otherwise, in an attempt to do the entry point, I may break the further cortex.
Any other question?
Sir, in both bone forearm fractures, after reduction, how can we decide whether reduction is stable or is it unstable?
After
Reduction, reduction which we have done is stable or unstable. How can we decide it?
the thing is that if even if after the reduction, you are not having any during the application of the cast, when you are providing the band padding and all those things you are doing, and you are reducing the acceptability criteria or your reduction, then definitely is a unstable fracture, or especially in comminuted fractures or like that. Means you have reduced the fracture, now you need to apply the cast. For that, you need to apply the bandage, what I follow. And even if during the application of my bandage and my cast, fracture is reduction is lost, then definitely it will not be stable for further.
It is not the reduction which is stable or not stable. It is the pattern of the fracture which is stable or not stable. So you have to think about the fracture pattern. If it is from day one, it is the pattern is unstable type of pattern. Then you have to keep a very close watch. Maybe after 7 days, you have to go for second X-ray. So at the time of reduction, every fracture will remain unstable. You can't accept that at that moment it would be stable. It is the pattern you have to see. Two questions from my side. What is your concept? Because we and Dr. Sanjay, we are from the old era where there was a concept of osteoclasis. Do you still believe in the philosophy of osteoclasis or not in both bone forearm fractures?
Yes, sir. Many times when we have late presentation, they are in angulation, we always go for osteoclasis and primarily treated also. If I had a very good reduction in initial thing, but I have lost some reduction in my follow-up, I can always again go for osteoclasis and we can again put a cast. And again, for the if he's using the nail also, he can do osteoclasis and put a nail if he's getting a late presentation.
So my say to my young colleagues that there is a concept of osteoclasis which is very well documented and still hold a position in the management of forearm, especially if you are talking about the adolescent age group. If you are managing by what the X-ray I think Suresh showed that was true for the conservative. And after second week, we have to go for a check X-ray. And majority of time, if the molding and the cast index is not up to the mark, then there are chances of slipping of the fracture. There is a chance under image intensifier you go and straighten that angulation, and you will get a very good result as far as the conservative is concerned. Number two thing which I always ask my my colleagues, you are using, suppose you are using nail. If you are not molding it, so the message should be the proper molding of the TENS in radius is very, very important. Because if you are losing the bowing of the radius by putting a straight nail, that is again going to restrict your supination and pronation. So it is either you go with for the plate or you go with the molding of the tents. So all the students here must understand that there is a concept of molding of the tents before putting into the radius. These two things.
Dr. Ravi, I have one question. First of all, very good presentation. There are few doubts for residents. Many people ask us that, sir, what to fix first? Should we go for radius or should we go for
What I follow that whichever bone looks easy to me, I go for it.
Then
there
about
is
the
no-
entry point of
Sir, in case of tens, it's extrafacial, just proximal, no? On the lateral side. Yes. On the lateral, sorry, lateral, in the medial side. No, no.
So one
Last question.
Yeah, sir has mentioned about the molding of the titanium elastic nail, like we bend it before introducing it. I would like to, because the conservative management is a dying art. We are gradually losing the technique, the plaster molding, which our seniors used to do. We cannot do as good as that because most of it is shifted towards the operative side.
Because we don't want to do the conservative and wants to do surgery. That's why we are losing that art.
Exactly. So technically, if possible, this is a message to the our students. If possible, try to learn the art of interosseous molding in a forearm fracture from someone who is more senior than us. Try to learn that because if you do a proper interosseous molding in these type of fractures, most of the time you need not operate. That's what my senior used to say to me, and I was lucky enough to get a boss whose orthopedic experience was more than my age.
अभिषेक एक और चीज है, चाहे वो सुप्राकंडल फ्रैक्चर हो चाहे वो फोरआर्म फ्रैक्चर, डिटेक्शन तो आपको करना ही पड़ेगा, ठीक है. सर्जरी डज व्हाट ही इज टेकिंग द सर्जरी, ये ओपन सर्जरी वर्सेस percutaneous fixation की बात नहीं कर रहे. It is the percutaneous fixation he is including into the surgery, but what I feel is the extended part of the conservative treatment. After doing the proper conservative treatment, you are not relying only on the plaster, but you are relying on an internal fixation in the form of nail. So for me, that is a extended part of conservative treatment. Then that conservative treatment will be successful only if you will be getting a good reduction by conservative means. So these boys cannot go away without doing the proper reduction.
That's a sort of close reduction and internal fixation.
Yes.
And as sir has asked that, what about the distal fractures? Sometimes we use the K wires only, just to hold that metaphyseal part and putting a cast. But application of a cast is in what sir has pointed out, maintenance of that radial bow, what Dr. Abhishek has pointed out, the interosseous membrane. These are the two important things. You will not notice in the fracture reduction time. Your fracture reduction may be okay, but maintenance of that space is more important when you follow the patient later on, that you may lose the range of motion.
Thank you.
That's
Thank
why
you.
radial bow is important.
Thank you, Ravi. Thank you, Suresh. And now next speaker is Dr. Anand Ajmera, who will speak on the tips and tricks of the elastic nailing. Sorry, मैंने पहले बोल दिया क्योंकि वो tip and trick में आ रहा था molding.
Good afternoon, everyone. Today, Professor Anand was supposed to be here, but unfortunately, because of demise of a colleague, he stayed back for attending the funeral. But he has kindly provided the slides for the betterment of all the residents and delegates who have joined. So let us go towards the tips and tricks of intramedullary nailing for both bone forearm fractures. So if you look the way these are a comparative slide showing the features of a pediatric bone and the effect they have on the management. So in all of these, what you find is that the bone, even though it has got more collagen, it tends to fracture easily, but because of the thick periosteum, it has rapid healing. So there are two counteracting things. And for this purpose, one of the important thing which is which has been devised and used is usage of an elastic nailing principle. And elastic nailing is not only meant for forearm fracture, but also for other long bones. And primarily, the basic principles are these elastic nails can be made of either titanium or steel. They follow the principle of 3-point fixation, 1 point being the entry, 1 point being the distal fixation, and 1 in the middle at the level of fracture. Then you have to use two pre-contoured nails of preferably equal diameter, rather almost always equal diameter, and the diameter of the nail should be 40% of the isthmus diameter. Maximum bend of the nail should be at the fracture side. Now, if we look at the principle of ESIN in both bone forearm fracture, there are somewhat little changes. What are this? The radius and ulna come into a special category because you do not use two nails in these bones. Rather, you consider both the two bones as a single unit and use one nail in each bone. So instead of putting two nails in radius and two nails in ulna, you use one nail in radius and one nail in ulna. Because of the very essential fact that both of them together form a single unit. The pre-contour nails are to be placed such that they have a concavity facing each other, and that concavity has to be directed towards the interosseous membrane. So the convexity is out, concavity is in the nail. Normally the diameter of nail which is used is 2 to 3 millimeter, and instead of 40%, it is preferable that each nail should be 2/3 of the diameter of the radius and ulna of the ulnar medullary cavity at the mid shaft. So this information has been taken up from this book. I don't know whether it is now freely available or not. Otherwise, there was a Telegram channel which was providing you free books. So, important thing is you have to prefer to use both the nails of the same diameter. These are the essential equipment: a plier, the nail, definitely T-handle, impactor, and all for making entry. How do you do it? First and foremost, patient position. Patient should lie supine. You have to have a radiolucent table, image intensifier coming in from a comfortable position, and monitor placed so that you can see without bending your body or neck much more than required. So this was the question: which bone to be fixed first? As Dr. Ravi told, there are one thing is you fix whichever is easy, but the concept which has been given is that even by the AO group is that you try to reduce the radius first. The reason being, ulna is relatively subcutaneous bone, which you can somewhat control the reduction with your fingers and hand. Radius, because of the higher muscle bulk, you cannot actually directly control. And then, if suppose you have trying to reduce, the radius is already reduced, but your ulna is not getting reduced because you have initially passed in some part of the nail in between to engage. So you have to withdraw the nail, not completely take it out, then try to manipulate, because then your both bone forearm will be much more mobile than when you have already passed the nail across the radius. So this was what Professor Ajai Singh sir was telling, that what is important is proper pre-bending of the nail. This pre-bending has to be done so that you have a curvature, the apex of curvature, which should be about 3 to 4 times of the medullary canal at the level of the narrowest part, that is isthmus. And this curves should be smooth, a uniform single curve, and both the nails have to be having a symmetrical curve. It is not as if I'll be providing one curve at one location and a curve at any other different location. What is important is that you have to use only the length of nail which is going to be inside the bone, and you have to bend it accordingly. That means you will be provided a long nail. You need not bend it completely by holding it at the ends. You have to use these nails, use image intensifier, decide what is the length of the nail which is going to be inside the bone, and then bend accordingly. So as Dr. Anand has very beautifully pointed out, so you have taken, you decide this is the amount of nail, you decide these are the two endpoints, then you bend. This is the wrong way because the operator is holding the nail at the end and bending. The correct way is you decide where your nail is going to be in the bone, then bend. The entry point, usually radius, you can, the preferred is a retrograde entry from distal. So this can be done proximal to the radial styloid, taking care that you are not damaging the physis. You make the incision, dissect it out gently, then you place the awl, take the awl, initially directly perpendicular to the bone it should be inserted, then you gradually angulate it and open up the canal. So this is the way you have to gradually open up the canal. Then this is what is provided by the standard manufacturers, the AO set. But in our country, you have to improvise something. So Dr. Anand has very well pointed out the easy way of improvisation, that you tie one gauze piece to one end of the T handle, standard T handle, put in the nail, see that this gauze piece is tied in the same direction where the tip is facing. So this helps you to identify where your tip is directed while you are inserting, even without having these standard equipment. So you insert the nail in such a manner that the curved portion is going to hit the opposite cortex. This curved portion is meant for only that purpose, that it has to slide through the cortex. It should not be piercing, it should be sliding. So once it slides, you have to gradually negotiate. These are the pictures taken from the standard AO textbook. So here, for the radius, the entry has been made. Initially, the awl is directed perpendicular. Then you go to an angle of 45 degree. Insert the nail, standard practice, extend up to the fracture, stop. Make the ulnar entry, insert the nail, extend up to the fracture, stop. Then you advance the nail on the radius so that you have negotiated the fracture. Then you advance the nail on the ulnar side. In case at this stage you are finding difficulty, take back the radial nail a bit, try to reduce the ulna, try to insert it further. Once this engages into the cortex, then you pass the radial nail, then pass the ulnar nail. For the ulna, the preferred incision is in the proximal part, but you should not be directly putting an incision similar to what you do for an adult square needling into the tip of olecranon, because there is a growth plate lying there. You should not be directly injuring the growth plate. Rather, it has to be posterolateral incision on 2 centimeters proximal to the olecranon tip. You dissect it out, same technique, initial perpendicular, then angulate, and then the same way you have to insert the nail also. The curved part goes in, then your hand moves up, so that you have now brought this curved portion against the opposite cortex, and then this slides down into the medullary canal. Finally, the nail has to be cut, and preferred is to cut in such a way that you are able to bury it inside instead of leaving it outside, because it will take around minimum of 3 to 4 months for it to heal properly, and then by the end of 6 months you are ready to take it out. So the nail length cut has to be, as Dr. Suresh told, it should be such that you are able to take it out properly without too much of dissection there. The trick is you insert the nail under CR, then withdraw about an inch, cut it, then use the impactor provided, then you hammer the nail further in, and you just leave a small portion outside for you to remove it comfortably. So successful outcome will be after you have united, the nail has taken off successfully. At times even this becomes tricky, so you have to remove the nail at proper time. So finally, you have to pay attention to choose the diameter of the nail properly, pre-bend only the required length of nail and not the whole length. Follow the principle of ICL sparing insertion technique and leave only minimum required length of nail outside the bone. Thank you.
Thank you very much. Any question from the audience?
Before the flexible nails had come, what nails were used in these patients?
Before, sir, if you are saying about this, then endless nail was definitely there when K-wires have been used.
And what about square nails?
Square nails are there, but sir, the way square nails are designed, they cannot be used in children.
So rush nails can be used, but not the square nails.
Yes.
Yeah. I was also asked a question about removal and keeping it outside. That's a very tricky part of using a titanium elastic nail. Now, I have developed a technique for helping. It's not a foolproof technique, but what you do is when you keep that part outside, try indenting some part of the nail with a plier or something so that you create some wedges over there before you have introduced. That helps in holding it when you are removing it after 6 months or when you are. It's a practical trick. It is something which I learned over time, because removing titanium elastic nail after the bone has remodeled in children is a very difficult task.
Thank you very much for a wonderful lecture. Prateek has done really well. Somebody else lecture reading is difficult always. I request Dr. John Santoshi to present on pediatric wrist and hand injuries, diagnostic and management challenges.
Good afternoon. Thank you, chairpersons and colleagues. I'll be talking about pediatric wrist and hand injuries. So why are we talking about this?
In this population, the assessment can be challenging because the presentations are often innocuous. The injury patterns are often different from the adults because of the differences in the mechanism of injury, the presence of open physis, and also patient compliance may be problems. There are delays in appropriate treatment. There is a risk of long-term morbidity, and we also have a very short period for intervention because of the faster growing rates, healing rates in this population. These are frequent injuries. Commonly, we have door crush injuries, especially hand getting trapped in closed doors at homes or in the car. Fractures, tendon injuries, and even burns are common in children. Pharyngeal fractures are the most common hand fracture in adolescents. Coming to hand fractures, they constitute about 15% of all pediatric fractures and almost 2.3% of emergency visits, pediatric emergency visits. There are challenges in eliciting history and also performing physical examination in this population. So there are peculiarities in children. We have been hearing about it since morning. So bone growth occurs to the physeal plate, which is unmineralized and which is weaker than the surrounding bone. Following fracture, there is differential growth at the physis. There is remodeling, which can happen at the diaphysis, which can correct after for substantial substantial initial fracture displacement, and in the motion of the there is correction in the plane of the motion. So in the flexion extension plane, there will be correction. So as shown in this X-ray, even though the fracture is mal-aligned, still if this patient was treated conservatively over a period of time, the fracture has aligned itself because the fracture was in the plane of the motion of the adjacent joint. The physis itself is vulnerable to shear forces. It can bear compressive forces. It remains strong. So most commonly, fractures happen in the shaft. There are limited attempts at flow reduction should be done because there is a risk of physeal damage when you do repeated flow reduction, and there can be physeal arrest, which can lead to angular deformities or even joint malalignment. So tough fractures are frequently seen when you have a child who's got his finger impacted somewhere in a closed area. So you can have a nail hematoma, and frequently you can have a fracture of the tuft. Now, this is something which is also frequently seen with a similar injury. Can anybody say what is this? What is? Yeah, very simple. Looks like a nail aversion. So what we see here, if you look carefully, you see more of the nail, almost the entire nail is seen there. What is required is to take a proper, true lateral view. And what do you see now? You see that there is a physeal separation. So the name for this condition is a Seymour fracture, which is an open physeal fracture of the distal phalanx. Now, this injury is unique to children. It has to be differentiated from a mallet injury because the mallet is a avulsion fracture at the base of the physis, whereas this is base of the epiphysis, whereas this is to the physis. The treatment for this condition has to be done very carefully. There is the nail bed which itself is also injured. So you have to open up this side, lift the nail plate, repair the nail bed. You have to replace the nail plate again, and then an axial wire would lead to a good result. So as we're talking about this, there are strategies which we have to have when we're dealing with hand injuries in children. So history taking is so important. A lot of times you may not be having the history of what actually happened. So if the child has grown up, then he may be able to give history. Otherwise, it may be an unwitnessed injury. We also have to look for, also have to keep in mind that there may be instances of abuse which we have to be careful about. When you perform a physical examination, ask for the child to move the fingers and ensure that there is proper alignment of the fingers. When you bend the Flex the fingers, all the fingers, they will point to the tubercle of the scaphoid. So obviously you see that the little finger is going out of plane. X-rays are frequently done. So you may have a very long oblique fracture. Ultrasound, the role of ultrasound is growing up in our practice. And if in case you feel that you are not suitable or you're not qualified enough to treat this, then always be prepared to refer the patient to a specialist. So when we talk about phalangeal fractures, these are the parts. So distal phalanx, we have the tuft, and then for the other phalanges, we have the condyles, the neck, the shaft, the base, the metaphysis, physis, and the epiphysis. So phalangeal brace fractures, which are fractures which happen close to the physis. So if they are minimally displaced, they have a high degree of remodeling. If they are displaced or if they are unstable, so you should be going for a surgical fixation. Phalangeal neck fractures are classically seen in children. So they have poor remodeling because they are far from the physis. So in displaced cases, we'll have to do a surgical fixation. So see, then you have condylar fractures in which you have a double density sign in the lateral view, which is important. And for unstable fractures, you'll have to do a surgical fixation. So what are these unstable fractures that we'll see in the subsequent slide? Metacarpal fractures, these are fractures which can happen in the shaft or in the neck. Usually, head fractures are rare in the metacarpals in children. They are common in adults. In the head fractures, if they are seen, there are shorter heads, type 2 fractures. Usually, the metacarpal fractures are undisplaced because of the thick periosteal hinge, which affords for stability of the fracture. The usual displacement is an apex dorsal angulation. So the AIIMS maneuver is commonly used for a metacarpal neck fracture, which you are aware that you flex the MP joint and the PIP joint at 90 degrees and push the proximal phalanx dorsally. That will reduce your fracture at the neck. Well-molded cast should be applied for at least 3 to 4 weeks. So when we say well-molded, the padding should not be too much. A long arm cast may be required. Otherwise, for a small child, the child can just simply shake the hand and the cast may fall off. So you may have to do a supracondylar molding for these children. Again, for displaced and unstable fractures, KY fixations are frequently used. So when you talk about displacement for a neck fracture or for a shaft fracture from metacarpal, it should be not more than 10 degrees for the second metacarpal, 15 degrees for the third metacarpal, and 20 and 30 degrees for the fourth and fifth metacarpals. For the thumb metacarpal, commonly at the base of the proximal phalanx, there is a aversion fracture of the ulnar-collateral ligament, frequently called as the skier's thumb, which is a type 3 shoulder head fracture. A pseudoskier's thumb is a type 1 or a type 2 epiphyseal injury. This is skier's thumb or pseudoskier's? Pseudoskier's. Sorry, skier's thumb. Scaphoid fractures, they are relatively uncommon in children. Fallen outstretched hand is the most common mechanism of injury, and this is also the most common carpal fracture. You have fractures both of the distal pole as well as of the proximal pole and the shaft. So these injuries are seen as they are seen in children. Diagnosis and treatment, you have to understand the ossification and blood supply. So less than 6, you may require an MRI for diagnosis. Treat them as adults, immobilize when you suspect a fracture. Distal radius fractures are the most common pediatric fractures, almost 36% of fractures in children, which are increasing because of increasing participation in sports and also increasing body weight. So these are metaphyseal fractures. So you all know about torus fractures, green stick, and they can also be compression fractures. They are inherently stable, so require a short period of immobilization with a wrist splint or a short arm cast. You have to differentiate between physeal fractures and bicortical fractures when you have, as compared to this incomplete fractures. These fractures can have significant displacement and will require a closed erection, which remodels with growth. Continuous spinning may be required. So this is what is the torus fractures. What is torus? Torus is a mathematical geometrical figure, which is like a donut So it's called torus. It is a green stick fracture. So there are risks of displacement, redisplacement, when there is increasing obliquity, increasing initial displacement, and also subvertebral reduction, and young children, not only for dyslodias, but also for other hand fractures. Also beware of tendon injuries. This is a simple tenodesis effect, which we do. So when we extend the wrist, the fingers fall in flexion. When we flex the wrist, the fingers fall in extension. So this should be done. Also look for the normal cascade of fingers. So if you throw the wrist, all the fingers will be flexing. If the fingers are out of cascade, suspect tendon injuries. Also look for mallet finger, jersey finger, and central slip injuries. So mallet finger can be treated with a closed knees by a splint, or can be treated with K-wires and close erection. Now these are two injuries. This is on the volar aspect, which is a avulsion injury of the volar rim, whereas this is on the dorsal aspect, so this is a central slip avulsion injury. This can be treated with a simple immobilization for a short period, about 1 week, and then mobilize. If you immobilize longer, the finger can become stiff. Whereas the central slip injury has to be immobilized for at least 4 to 6 weeks. Dislocations, as we've been hearing, even in the hand, are also relatively rare because the ligamentous structures are stronger than the immature developing bone. So the joints in the hand are relatively stable, so you can immobilize. You can use body taping for immobilizing an early range of motion. But when they're irreducible, then you have to do surgery. So I thank you for your attention.
Any question?
Thanks, sir. It was a nice presentation. As you are a head surgeon and you must be witnessing a lot of injuries, how often you encounter this, especially in case of metacarpals and phalangeal in pediatric population, post-traumatic facial injuries, deformities? How often you encounter this?
We do encounter. A lot of times the injuries are missed, and you get the neglected patients or patients who have been missed as referrals. We do see them.
Because in hand, we are not that much cautious as compared to the other parts of the body in children in putting K-wires. We put here and there sometimes, and even the normal general pediatric, also general orthopedic surgeons. So that's what. So you want to, what do you prefer? And is there any deformity correction at that part or some? You want to wait?
We have done a few deformity corrections for angular deformities. Yes.
Whenever you first found.
Yes, and usually that also can be fixed with simple K-wires. Simple K-wires are good enough.
And second question regarding the scaphoid. What are your indications of moving into operative in case of scaphoid fractures?
Well, personally, I've never seen I've seen open fractures, open injuries with scaphoid fractures also, but closed injuries in a child with scaphoid fracture are not treated as that. But then what the recommendation is, you treat them as you treat adults.
Yes. Thanks.
Thank you very much. Thank you, Dr. Santoshi. Now we are opening up the case discussion. First is the Dr. Vishal. And you have 5 minutes to present your case, and after that, Dr. Ajai.
Good afternoon. So, an 8-year-old boy presented to us with his cracker burst injury over his left hand, and he was referred to AIIMS Trauma and Emergency Department 1 day later. So on examination, what he had is amputation of his thumb and avulsion of thenar muscles, a lacerated wound over second web space, and there was amputation of third and fourth digit distal segment. These were the clinical images at that time. Now the initial radiograph showed that there was amputation of thumb at the level of base of metacarpal, fracture of second metacarpal at the base level, fracture of neck of metacarpal head of third, fourth, fifth metacarpal. So, vote from audience for reconstructing this. Any ideas? How can you proceed? So the problem here is there is a amputation of the thumb. The amputated part is not available, so you cannot do a revascularization. Second thing is the level of amputation in the thumb is very important. for deciding how you should reconstruct it. So it is at the base or almost at the level of the CMC joint. Another thing is thenar muscles are also lost here. So the options usually for the thumb is either osteoplastic reconstruction, polycization, or a free toe transfer. So something about osteoplastic reconstruction. Usually what is done is a tricortical graft is taken. It is usually done if the amputation is at the level of the MCP joint. You do arthrodesis, then you do a tube in groin flap, you later on division and inset. Now for giving some sensation over the flap, you neurotize it with the island pedicle flap. So this is how it works. Osteoplastic reconstruction of thumb, usually done by orthopedicians. Another option is free toe transfer. Now here also what you can do is the great toe, you can only take up till proximal phalanx because the ball of the first metatarsal is required for weight bearing. So if the amputation is at the level of the metacarpophalangeal joint junction, then great toe can be taken. Otherwise, the entire second ray can be excised and can be used. This requires a microscope and excellent microsurgical experience. That is the limiting factor. So this case was managed, emergency wound debridement was done. Then primary polycization of index finger was done along with K-wire fixation of third and fifth metacarpal neck fracture and a groin flap. At 3 weeks post-op, the flap division and flap inset was done. Then at 2 months, the K-wires were removed, occupational therapy was started, and MCP flexor traction splint was given. 3 months post-op, now because thenar muscles are lost, so extensor indicis opponens plasty was done, and some limitation in flexion was there, so third dorsal MCP capsulotomy was done. So this was the flexor traction, which is applied on the third MCP joint. 6 months follow-up X-rays. The new CMC joint has been formed there. Clinical images, 6 months. So usually polycization is much more discussed in pediatric population in thumb hypoplasia, but for traumatic thumb amputation, it is very reward-giving surgery. And one of the largest case series, they described that their mean age was 43 years of age. So even very good surgery in adults also. Take-home message is the technique of reconstruction depends upon the level of amputation of the thumb and the damage to the adjacent fingers and soft tissue, patient's age, occupation, and the surgical expertise available. The thumb amputation at the CMC joint level is an absolute indication for polycization. Polycization of index finger not only restores the length, it also restores the range of motion, stability, sensibility, and the appearance. In cases where the thenar muscle is lost, then it usually requires a secondary tendon transfer for opponent's plasty. Thank you.
If there is any query.
How was the function of the hand after that?
He had a good function.
Because for a radial club hand in similar situations in children, we usually don't advise polycization after a certain age because they are very well adapted. And,
that's what I'm saying here, sir. It is 43 years of age, mean age they are doing. They're the cortical plasticity, what you are saying, I think so. So it is very well adapted. Actually, in our India only, in Amrita Institute, they have done 2 or 3 hand transplant. Patient who had a hand, almost forearm amputation, 5-6 years, they don't have any limb there. Now they are transplanting a new limb. That cortical plasticity again adapts it. So there's no issue with that.
Vishal, first and foremost, I would want to congratulate you for such a difficult case. It has been managed well.
Sir,
I'm so proud of you coming up as a young hand surgeon, having trained at AIIMS. My question is, for a lot of us who do not do our hand surgery, or for some of us who have the privilege of having somebody like Dr. John or you to take care of those cases, what is the current consensus? In our times, we used to have a mangled hand injury, and the first choice was, isko just laga do emergency, right? And then the patient used to be left alone, right? So is just still there, or have certain modifications happen so that even in a rural setup or in a slightly smaller setup, the hand injuries can be managed better?
Sir, actually, hand injury is little bit different from other orthopedic injury. What you need to understand is you need to give function. The end result you have to think, not only the coverage or how just to fix a fracture. To the patient, end results matter. So, and most of these surgeries are stage surgeries, not a single step surgeries. So you need to make a plan at the just initial stage only itself, how you are going to proceed it till the end. If you are able to do all the stages, then you do it. Otherwise, you refer him. Do a debridement and refer him.
So are we looking at a scenario like a tumor surgery?
Yeah.
Now it is said that if you do not manage a malignant tumor
Definitely,
process till the end, refer it to a hand surgeon.
Definitely, sir. Because doing it, referring it, what sir was saying, that malunion, have you corrected the malunions? That is much more difficult, and the end result is definitely not that great.
Yes, I agree. If you are not able to do it, you should refer it rather than making it difficult for the other person. Thank you very much. And now the second case discussion by Dr. Vijay.
Good afternoon to our honorable director, sir, Ajai, sir, my head of the department, Dr. Rehan, sir, all of the faculties of my department, and all the eminent faculties who have attending this session across the country. I am presenting the case which was operated in our department last year. Now, coming to the history of our case, it was a 10-year-old boy who presented with an alleged history of a road traffic accident, following which he sustained a close injury to his right elbow. On examination findings, the boy was conscious, oriented, with stable vitals. There was a swelling which can be noticed around the right elbow. The range of motion of my patient was painful, and there was no neurovascular deficit. Now, coming to the initial X-rays. So, among the house, especially for the junior residents, if anyone can identify the fracture. Giving some clues, we can see on the anterior posterior and the lateral views, there was some fracture around the radial neck. The second clue, there was some fracture around the coronoid process of the ulna with the subluxation of the elbow. So we diagnosed this case as a case of the terrible triad. So initially we stabilized our patient while applying the above elbow slab. This was the after applying the above elbow slab of the patient. Now, what will be our plan? If anyone want to volunteer about it. So we planned that there was an open reduction and stabilization of the fracture fragments. These were the intraoperative findings. We used a standard posterior approach, and after performing the chevron osteotomy, we can identify there was a radial neck fracture. We can easily see the radial head fragment. Ongoing for that further dissection, we can notice there was the osteochondral fragment of the coronoid process of the ulna. So we primarily stabilized the osteochondral fragment of coronoid process using the K-wires and the ethibond sutures. The further the radial head stabilization was done by applying the another couple of K-wires followed by the tension band wiring for the olecranon osteotomy. So these were the post-operative X-rays. At the 6 weeks follow-up, we noticed that our patient pain improves, and we can on the follow-up X-ray notice there was some sort of a joint congruity obtained. So we make a decision of removing the K-wires. This is the 6 months follow-up of my patient. So after the 6 months, we decided to remove the plant, but because of some issues, we don't have the post-operative after the removal X-rays. So what will be the take-home message from this case? These injuries are uncommon in the pediatric population. A terrible triad injury almost always renders the elbow unstable, so making the surgical fixation necessary for such cases. The posterior approach has several advantages, including it provides a panoramic view in the elbow. Access to the both medial and lateral aspects of the elbow can be easily done, and it precludes the need for a second medial skin incision. Unlike the adults, pediatric patients can tolerate immobilization for longer periods, and bone healing is faster in children rather compared to the adults. Thus, pediatric terrible triad injuries can be treated easily with non-rigid fixation and immobilization for 6 weeks, which allow the healing without major consequences to our ultimate function for the patient. Thank you.
Thank you very much. We are already very late. So I would not invite any further question, and I will ask the organizer to go forward for the quiz, PD quiz.
Okay, sir, meanwhile, sir, quiz setup is getting started. Amendment to the remaining, sir, we will be facilitating that. Sir, kindly. Yes, please, sir, both you come and give the mementos to the speakers. First, I will call to Dr. Anurag Tiwari, please. Thank you, Dr. Anurag. Now, Dr. Suresh Chen, kindly come on the desk, please. Thank you, Dr. Suresh. Dr. Pratik Dera, please. Thank you, Dr. Ravi Chauhan. Thank you, Dr. Ravi. Dr. John Santoshi, sir, please. Thank you, sir. Dr. Vishal Champawat. I will invite Dr. Shukla, sir. Kindly come on the dais, give the mementos to our chairperson. Okay, sir. Sir, Shukla, sir, please, sir. Sir, kindly announce the results of the poster, please.
No, I think there were 10 presentations today, and we have gone through them. We have evaluated them on various points, which is overall visual appeal and quality of the graphics, conciseness, appropriate and relevant content, accuracy and grammar, and affiliation. And after evaluating each poster on these grounds, we have come to the conclusion now. First one, the first prize goes to Mohit Kumar Israni. Presentation on novel approach of dual dome osteotomy with plate osteosynthesis in a 14-year-old adolescent female with failed hemiepithelial disease for bilateral genu varum. Congrats, Dr. Israni. Second prize goes to Dr. Nikhil Ranjan. A case of acute bilateral SCFE. Is he there?
Dr. Nikhil, please.
I think he is from the Allen Medical College. Bilateral SCFE from the Allen. I will request from the Pediatric to receive the from Allen. Yeah. And third prize goes to Swasti Sundar Prasad. Pediatric femur, our experience is okay.
I would also request everybody to please go and observe these, see these posters. It is quite a far away, and it is a distant place. So please go there and see it during your lunch period, lunch time. Thank you very much.
Thank you, Dr. Thank you, Dr. Rahul. Now it's time to session. It will be, Quiz Master will be Dr. Manish Rajput and Dr. Ankit Jain. And it will be moderated by the Dr. Manish Reddy.
Team 1, Dr. Rajesh Ratan, Dr. Hemraj. Team 2, Dr. Mani Bagga, Dr. Siddharth Jain, Siddharth Yadav, sorry. And team 3 is Dr. Arvind and Dr. Swasti Prasad.
Thank you. Now we are starting our most interesting session, that is the easy quiz. There are three teams, three participant team. A, B, C. One is the Ham. Dr. Ham.
Manish, I think better to make them sit on that side. आपको ये बता अच्छा लगेगा डिपेंड ऑन यू
यहाँ बेस्ट
Team A, Dr. Hemraj and Dr. Rajesh Ratan. Team A. Team B will be for Dr. Siddharth Yadav and Dr. Mani Bagga. Team C is of Arvind, Dr. Arvind and Dr. Swati. Now, rules of the quiz. The quiz will be conducted in the 4 rounds. First round will be the question will be of majorly of the historical aspect of the pediatric orthopedics, and the second round include the clinical, OT, and it will be a buzzer round. Third round will be MCQ based, and fourth will be a rapid round, rapid fire round. In first round, there will be 6 questions. Each team will be asked 2 questions. Each right answer, the team will be given 10 marks for each right answer. There will be no negative marking, and question will not be passed and can be passed to the audience. In second round, there is 6 questions. There is a negative marking of 5 marks if answer is incorrect, then there will be a negative marking of 5 marks. The question will be passed to the next team if he is not able to answer that question. Third round of MCQ also include the 6 questions, and in rapid fire round there will be 6 questions for each team. Let's start. Round 1.
Yes, question will ask to the audience.
Yes. Some of the question will be passed to the audience.
And who's the final authority?
Manish sir. Now question to the team A. Identify the person.
Dr. Ignacio Ponseti.
Okay.
Right. What is the main contribution in advancing orthopedics?
Listed the Ponseti technique of casting for
Right.
CT.
Right. Next question will be to the next team. Identify the person. Team B.
Dr. Elisa Road. With Radovic.
Okay, right. Where did he practice? Second question. Russia. In Russia where?
उसका तो बहुत बड़ा है।
सर आप नहीं बता सकते। सर आप नहीं हो सकते बनाने वाले हैं नहीं कर सकते।
सर हमने नहीं बनाया क्वेश्चन।
Practice.
रशिया हो गया। इतने भी टाइम ना दे दीजिए।
Now third question to the third team. Identify the person. Marking.
आप लोग रोज करते हैं उसको क्लास लगाते हो इंडियन बॉन्ड है बाहर प्रैक्टिस करता है नहीं आपने फैकल्टी नहीं
You can say I don't know and then I don't have yes ना आगे जाना है
पास करना
है what time
जल्दी बोल देते नहीं
So then
में हमने सब पूछते हैं क्या हो रहा है
time up. The question will be passed to the audience. Anyone want to answer this question? Any PG? Any PG?
जिन्होंने क्लास लगाया टीवी का वो बताएं
अरे वो देते स्पॉन्टिंग तो कैसे आ रहा है भाई
हाँ उदित
PG नहीं बोल रहा तो ऐसा
Okay, Dr. Sabir Pirani. Second part of this question is, what is the main contribution in advancing orthopedics? बताओ ना. Yeah. He has given the modified Pirani scoring to score. It is the objective score of to assess the clubfoot deformity. Now,
five.
Now question number 4 to the team A again. Team A. Identify the person. Sir, आप तो सब बताइए.
There must be some time.
Yes, sir. 30 seconds.
Time up.
Wrong answer. Anybody from audience? PG? Any PG? Okay, SR? Aisha? Dr. Ashok Johari. The second sub question of this question. The founder of this society. Pediatric Orthopedic Society of India.
No prompting from back.
Next question to the team B. Identify the person.
इसको ऊपर करता हूँ
The question passed to the audience. PG. Any PG?
जिसने परचेज किया है वो उसको बता सकता है.
Now SR. Dr. Benjamin Joseph. Now, second, what is the main contribution in pediatric orthopedics? Sir ने answer दिया.
Move on to the next. Zero.
Next question to the third team, team C. Identify the implant. Sorry, बोलो. Now pass the audience, PG. Now ऐसा
बोलना चाहते नंबर नहीं मिलेंगे
नहीं, इसमें नहीं मिलेगा.
बता दीजिए लेकिन आप बता दीजिए.
More space. Where it is used. More space. No prompting allowed. 0 marks.
पीछे प्रॉम्प्ट मत करो यार, क्वेश्चन चालू है.
Now the first round completed. After that, the total scoring of first round. Team A scored 15 marks, team 10, and team C 5 marks. Now moving to the next round, that is the question will be asked from the ward round, clinics and OT. Question number 1 to the team A.
So, halo structure using management of shaft of femur fracture less than 6 months of age. 6 months of age. 6 months. Shaft of femur fracture.
Okay.
ठीक है, ये गलत बोल रहे बट it was never asked.
एक वो थोड़ा
It was not asked. It was something which was not asked.
उसने ठीक बोल.
ठीक बोलते हैं. We can get the full marks.
Full marks.
Next question.
It is a passable round. No?
Yes.
It is a passable round, so no prompting. Other team will get the
Marks. Identify the AFO and indication. Question 14.
Blue orthosis.
Flow reaction orthosis. Where it is used? What is the indication? Incomplete answer. For what?
In case of fracture of bones or ankle fracture.
No. It is used in partial palsy. Half marks.
Half marks pass नहीं हो सकता.
Sir, आधा फिर. Third question to the team C. Identify the spleen. What is the use of the fluid pulley that is marked with the blue?
Very loud. This bola brown split.
Okay.
Or the pulley mark C is there to prevent the evenness of the boot.
Right answer. Question number 4 to the team A. Which nerve is at the risk in this approach? Which approach?
Be loud.
Okay. Right answer.
I think the mic is not on, right?
Lateral femoral cutaneous nerve, the approach is rotation.
Next question to the team B. For open reduction, internal fixation of displaced humeral lateral lateral condyle fracture, the section around which portion of fracture fragment should be avoided to protect its blood supply.
सुबह डिस्कस हुआ सुबह डिस्कशन हो चुका है इसको तो पता नहीं है Be loud. Switch on the mic. Switch on the mic.
No. Pass to the next team. Posterior. Right answer. Five. Teams. Now, last question for this round for the team C. Identify the disorder. Team C. Last. It is passed to team A. Pass to team B. Now to audience. PG. Any other PG? SR? SR? नहीं कुछ नहीं बोला सर After second round, the total score of team A is 35 marks. Team C 20. And team B is 10. A is B2. The third round. No negative mark. Now third round MCQ based question will be asked. There will be no negative marking and question will not be passed. Question 1 to the team A. When assessing an AP pelvic radiograph for developmental dysplasia of hip, which of the following is a term for a line passing through triradiate cartilage? Correct answer B. Tiger renal line. Second question to the team B. Vascular sign of Narak is noticed in C. Posterior dislocation of it. Correct answer. Last time. Third question to the team C. Shepherd foot deformity is seen in A. By this description. Correct answer. Now, fourth question to the team A. In 13-year-old male present with left hip pain and inability to ambulate. The initial radiograph is shown in the figure A. Which of the following zone of the growth plate is most commonly involved in this condition? First, identify the condition and which zone is involved.
Zone of hypertrophy.
A, B, C, D, D. Correct answer. Fifth question to the team B. Radiological sign of scurvy disease are following except subperiosteal hemorrhage, vertical thickening, marginal sclerosis, dense metaphyseal, fusion band. Four. Which one? Us. Four. Wrong answer.
One.
There is no negative mark. Next. Next question to the team C. Which area of the knee is most likely affected by juvenile osteochondritis dissecans? Lateral aspect of medial femoral condyle, lateral aspect of lateral femoral condyle, medial aspect of medial femoral condyle, medial facet of the Paeds.
Three. Medial aspect of.
Wrong. Is the lateral aspect of medial femoral condyle. Now, this round completed. Scoring after this round is team A 55, team B 30, and team C is 20, and team C is 30. Now, team A is leading. Now, final round, round 4. It will be rapid fire round.
And one of the you choose one of the person who will come here and answer fast. You have 1 minute to answer as many questions as you can.
ये बी वाले के मार्क्स ठीक है
हाँ
30
सर 5 मिनट्स वाले 0 हो गए
ये तो 0 हो गए 10 हो
10 10 20
अच्छा ये ऊपर टोटल निकला
ये टोटल है सर
We will ask 6 questions to each team in 1 minute.
you choose who is coming here okay and who come here answer
The round will be start with the team A. Team A have to answer as many as question as possible. Maximum question you can answer is 6.
The negative mark.
There is no negative mark.
rapid fire as many as
नहीं आता तो पास बोल देना जल्दी से जल्दी 6 क्वेश्चन का आंसर क्वेश्चन वेरी गुड Reverse migration index is used to assess. Yeah.
Dislocation of the femoral head.
In which disease?
That is
Most common classification used in management of Perthes disease now is
having 3 pillar.
no.
Elizabeth classification.
No, पहले गलत नहीं Fourth question. Presence phenomena seen in this pediatric fracture. Pass. Now time. Sir. 1 minute. Time.
दो नंबर मिले
वो सही है तो कितने पर क्वेश्चन 10 नंबर्स है
10.
which is 20 marks
अगर 20 है
So next comes team B.
team B पे आओ
Now question to the team B. Ready. Bilateral knee radiograph of 10-year-old girl. What condition is most likely to be? No. Next. Identify the fracture point. No. Most common approach used in open reduction of DDH in 2-year-old child. Right. In juvenile Tellox ankle fracture, ligament, osteochondritis of the right. Which muscle most commonly causes a dynamic deformity in the swing phase of gait following Ponseti casting. Six. Yes. Use them. Now take team C, ready. Identify technique and zone involved.
What is
Right answer. Cosmic angle is used to assess the severity of. Last time. Identify the pathology in X-ray.
Pass. Be loud.
Pass.
Next. Question knowledge sign seen in which Salter has a single. Right answer. Yes, sign and sagging of sign are seen radiological finding of the childhood condition.
But this.
Right answer. Name the techniques shown in the figure. Matthew. Right answer. Now, yes, sir. Now completed.
Given 5 answers. 5 connected.
The final scoring after the team C is 80. Now winner is team C and team A is runner up.
After this interesting session of quiz, before we break for lunch, I would like to welcome Professor Sanjeev Gosar, from the Senior Minister of Research of Bhopal. And I would like to invite him and Professor Ajai sir to hand over memento and prizes to the winners and the organizers of the quiz. Doctor? Was the winners, Dr. Swasti Prasad and Arvind. So, rapid fire round. We asked a rapid fire round, change their luck, and they won by 5 marks. Runners up are Dr. Hemraj and Dr. Rajesh Goyal. And also, we should give a big hand of applause to the team B. Actually, we had 5 teams, but the 2 other teams that could not come. Otherwise, it was basically 5 teams. Then I would like to request Dr. Manish Rajput to please collect the memento. Interest is what? Certificate. Memento to Dr. Manish Rajput, please. Then Dr. Ankit Jain. Dr. Manish Devedi for wonderfully managing the scoreboard. Then I will request Dr. Vijay Sudha sir, please come over. Dr. Rahul sir. Dr. Rahul sir. Then we have Dr. Pankaj and Dr. V.K. Verma. Dr. Pankaj sir. last two, Dr. Udit and Dr. Shekhar, who were missing. So, Dr. V.K. Verma, sir, please. Dr. Udit, sir. Shekhar, Dr. Udit.
ये रह गया।
Udit. So we want to thank Dr. Gaur sir and Dr. Ajay sir. Now we will break for lunch, and then after half an hour we will gather for the last two sessions, followed by the PG interactive case discussion session. The next session will be on fractures around the femoral neck and femoral shaft. After that, injuries around tibia and knee.
I would call Professor Dr. Sanjay Gaur Sahab and Dr. Jiten Shukla sir, please.
On it.
So after the lunch, we are going to have a interesting session on fracture femur, talk on neck of the femur fracture challenges and management. I call upon my dear friend Shrivastava. Wait, please.
So at the outset, I would like to thank Dr. Rehan and Dr. Prateek for giving me this opportunity to present my talk. And I would like to thank Dr. Gaur sir and Dr. Shukla sir also, and all my dear friends and colleagues. So the topic given to me is challenges in femoral neck fracture management. This is a difficult topic, so let's delve into it. So this fractures is less than 1% of all pediatric injuries, fractures. They are because of high energy injuries, road traffic accident or fall. And this fracture is known more for its complications than for its occurrence. Size matters. There's a wide spectrum of fractures, right from the smaller kids to the adolescent groups, and the management totally differs. So when the child comes to you, there has to be some treatment decision to be taken for managing these cases. So what is the age of the child? Whether it is a kid, a juvenile or adolescent. What is the location of the fracture from the physis? That will be covered in the classification also. Whether you want to do close or open reduction of the fracture. If the child is coming in the late evening hours or the midnight, should we do an emergency surgery or do a planned surgery? And what should be the implant according to the age and location of the fracture? And lastly, how to immobilize the child, because only fixation is not sufficient in these fractures. So now complication or the challenges to prevent are first and foremost AVM, then second is malunion, most of the time it is coxa, non-union improper fixations, and premature facial arrest if it is crossed. Then the loss of fixation if the biological principles are not followed. So to overcome these challenges, we have to consider timing of surgery. For me, it is always a planned surgery, even if it is coming in the late in the evening or night. I would like to do it with the proper staff, proper OP timing, and with the proper implants. I would like to decompress the capsule so the hematoma is evacuated, and that will lead to good perfusion of the head. Accurate anatomical reduction is must. Implant selection for small children's KYs, 4 mm CC screw or 6.5 CC screws, or DHS, or sometimes etc. also. Spica, I would like to give to smaller kids. Now coming to classification, Delbert classification is time tested. It is 100-year-old and now popularized after 1929 by Dr. Colonna. So it has got 4 types. Type 1 is transfacial fracture, A and B, with the B with dislocation. Second is most common fracture, that is transcervical. Third is cervical trochanteric. Third in occurrence, and intertrochanteric fractures around 11%. Coming to case, this child came with a history of dislocation. So it is fixed with the KY, reduction, close reduction done, fixed with KY. Now with all epiphyseal injuries, it is important to follow up the child, even if the reduction seems good. This child was followed, and eventually
The 5-year follow-up is blended with the avian coxavera trochanteric overgrowth. Now, the same epiphyseal injury, the literature is reporting nearly 100% of complications. But this is reported 2 cases, none other than Dr. Gans, where they have done, where the cases, fracture dislocation came to them, and they did a safe surgical dislocation, and the follow-up of 4 months, 7 months, 1 year, and 2 years, they did not report avian. But the safe surgical dislocation is not like that you can see on YouTube and do it. You have to learn and then execute. It's called learning curve. This is another fracture, roadside accident. This is like type 1. This is it, close reduced, fixation with 2 cc screw, and eventually the results are good. So in type 1 treatment, for undisplaced fracture, spica was advised. For undisplaced or displaced fracture, previously the spica was advised. Now, following 1992, for displaced fracture, they have said closed open reduction plus interfixation by smooth or threaded wires or by CC screw. If a dislocation is present, you can take a CT scan. Coming to transcervical fracture, this is most common. Fractures and occurrence most common in complications. So this is an 8-year-old fracture, 8-year-old transcervical fracture. It is closed reduction done and fixed with a 2 cc screw. And this is supplemented with a spica. This is another fracture. This is 2-week-old fracture. Closed reduction was tried, did not came. So open reduction was done by Watson-Jones approach, and the head, a wire was introduced into the head, joystick was done, and reduction achieved and fixed with 3K wires. Eventually, the child had good functions. So type 2 fracture needs proper attention, proper implant size and placement, like this fracture, which is fixed with 2 cc screws, but the screw length were inadequate. So as anticipated, the screws moved away. Implant failure was there, but luckily fracture healed. But this cannot be a norm. In this case, this 11-year child fixation done with 6.5 cc screws, and fracture gap is still present, threads into fracture line. This case was known that it will give away, and it happens. The screw gave away, resulted in non-union. So all these fractures needs spica, supplementation with the spica after fixation. But normally, in older kids, spica is very troublesome. So for this, to overcome this, AO has come with a AO pediatric hip plate. Whether they say that you don't need spica, the only disadvantage of this plate is cost. It's around 45,000 in the market. So as we are Atmanirbhar, some of our doctors have developed this plate, side plate construct, where they put a 1 screw through the plate and 2 in the shaft, 1 or 2 in the shaft, and 1 without going into the plate. And this gives good stability, and you don't need a spica supplementation. So in this fracture, even if transcervical fracture, because of known complication, they should be fixed even if they are undisplaced. Capsular decompression can prevent avian, though there is controversy in literature for and against, but there is no harm if you do it. Because one study in SCFE, they have put a probe into the head through a screw, and then they measure when they operated the child and decompression was done, the flow was increased. So there is no harm in doing it. Adequate reduction and compression should be achieved. Now, a little tip that when you put a screw, tightening of superior screw, get the reduction in valgus, and this prevent varus. So it is not like that if an adolescent kid come to you and you just put a 6.5 mm screw and you think that it will be okay. You need to supplement it with a spica or a side plate. And always cross phases if you think that the stability is jeopardizing. Don't hesitate in crossing the phases. Type 3 and 4 fracture, they are cervical trochanteric and intertrochanteric. A good paper has come for these type of fractures by PGI Chandigarh, where they recommend the fracture to be treated with pediatric DHS and a derotation screw. And you need not cross the physis in these fractures because they're very much away from the physis. These fractures less in incidence and less incidence complications. So if close reduction is not acceptable, don't hesitate to open reduce it. DHS recommended in type 4 with derotation screw. So what are the acceptable criteria when you see that fracture is reduced? So there's a Lowell method where the femoral head with the neck from S or inverted as shaped curve in any projection in AP and both lateral. If fracture is not reduced, it will produce broken C curve leading to varus and extension. So the various series have come into complication. Various series have reported various complications. Recent one, canal, is reported AVN 43%, Coxavara 21%, Pfizer closer to 60%, and non-union around 7%. So how to treat AVN? So this is the AVN after a year of trauma, good fixation. So the frequency of AVN decreases as we move, bearing type 1 frequency decreases as we move away from the physis. So in type 1 it is 100% with dislocation, type 2 50%, type 3 25%, type 4 10%, overall 40 to 45%. So there's no treatment available for AVN once it is identified. So all effort should be made in preventing its occurrence. This has been proved in a paper. Coxavara is another complication because of malunion or epiphyseal injury. You can treat it with a valgus osteotomy. Now, delayed union and non-union, they are 6.5 to 23%. These have been reported in hip flexion in children, long-term follow-up study by Davidson, Winster, and other by Dr. Ratliff. For non-union, there is a good paper by Sancheti Institute where they've given guidelines to treat non-unions. Now, basically, they have divided patients into two types: failure of fixation and delayed presentation. If there is failure of fixation, evaluate whether it is improper fixation, improper implant choice, implant failure, or failure to test biometric and rule out infections. So plan, they say that remove implant, institute stabilization of fracture site, valgus osteotomy and refixation of stable implant. Secondly, they say delayed presentation, evaluate if there is neck resorption, intervening fibrous tissue, and rule out pathological fractures. Plan is to institute stabilization across fracture, avoid open reduction unless absolutely necessary. Neck reconstruction using fibrillar stud grafting, valgus osteotomy, and fixation with stable implant. To summarize, non-displaced fracture do better and less complication regardless of fixation. Fixation is indicated in displaced type 1, all type 2, displaced type 3 and 4, and in older children. Anatomical reduction is must. Stable fixation with proper implant. Younger kid needs spica. Adolescent kid needs side plate construct. Cross physis for stability. So physis grow 4 mm per year, or there is contribute 13% for overall limb length. So don't hesitate if you need to cross physis. If LLD occurs, you can do timely epididymosis and overcome it. Plan for surgery as early as possible, routine hours with proper implant. No, nothing doing in the emergency hours. MRIs of little use in fresh cases. Thank you so much.
No, for most of your cases, you have put across the episodes.
There's selection of cases, just giving messages.
Yeah, but what is now rule is? What is? Can you have to cross above the episodes?
Yeah. Stability, you have to see the stability. If you think the fracture is not getting stable, cross the physis.
Because it's always better, stability will be achieved if you put it.
But then in the younger kids, you have to do with the KOS, and older kid by the CCS screw, and still older, then you put a side plate type 3 or type 4. Even type 2, you can put a side plate.
Vivek.
Yes.
Dr. Vivek.
Yes, sir.
Two questions. One is that those pins which were initially introduced, one was shown here also, Moore spin and novel spin. And you have shown one fixation with KY also. Why, with the spica augmentation, you cannot use those pins.
Yes.
The Moore spin and novel spin. For
Moore spin,
fixation.
I don't have any experience. I have told you that time also. But even Dr. Rehan and we were done PGs in the same time. We never used nose spin or nose spin or nose spin. And we used to put a spica.
And your choice of this thing, can you look at screws 4 mm or 6.5 mm?
So recommendation is below ATS 4 mm, above ATS 6.5 mm. But then you have to see the size of the neck also.
And how many number of screws suffice?
Two depends on the age, fracture, and neck width. I think 2 are sufficient.
Just a small query. I think, and also to the other panelists who are here. Inevitably, you will get some patients who land up with AVN, right? They're 10 years old, 12 years old. Then what do you do with them?
I put a slide there. There is no treatment of AVN. It is better to take every precaution to prevent them.
No, but now you have treated a patient and the patient has finally landed up with AVN. You have taken all preventive methods. This child is skeletally immature, right? So there must be something. चाहे हम treat ना करें, लेकिन manage तो करेंगे उसको. So what is your protocol? How do you counsel the patient? What do you do? Do you
See,
keep them
then,
on weight bearing?
then it depends on the symptoms, just not the X-ray. If the range of movement is good, you can wait for some time. Then AVN has got 3 types, whether it is whole head is involved or patchy sclerosis there. Now, some people have said that in a pre-AVN stage, you can give a trial of zoledronate acid intra-articular in the head only. So that you can try.
Ravi and other panelists and sir, do you have anything to add to that?
So actually it depends on whether it's partial or total collapse and how much area of the head is involved and which part of the head is involved. So for partial, there are different types of osteotomies mentioned like valgus and derotational osteotomy so that you bring the normal part of the head under the weight bearing zone. If it is total collapse and patient is really symptomatic, then either you can go for pelvic support osteotomies or you can wait and do a THR later on.
Do the Paediatric procedure. There is no direct treatment of AVN. You have to put a good cartilage head into under the weight bearing area.
I'd like to add something over here. I have I've seen 2 or 3 cases of pediatric AVN recently. So I'm doing a bit of hipscopy also. So one, we had a bilateral AVN which was evolving in the adolescent age group around the male child, age around 11 or 12. They'd gone all over India to get it treated, but it was neither a CP or a Paeds. It was a pure AVN as mentioned, not related with neck of femur. So what we did was we did a hip arthroscopy, a bit of PRP or the stem cell which is available in city and that, and we did a proper capsulotomy with a bit of differentiation. So somehow, like we don't have any
through scopy.
Yeah, through scopy. Yeah. But somehow the entire thing improved, the pain improved on the other side. Maybe the AVN was related with some other metabolic disorder, something. The other side, the AVN gradually disappeared, and the right side, which was the most affected side, we ended up having a functional hip for the time. He might need a DHR at a later date, but this is what I have been.
There is no published reports of treating
no.
AVN. Personal experience may be different for certain children.
Usually, basically, there are a few cases that I have seen in my practice, and those are basically I mainly consider them as the late presenters or early presenters. Late presenters, I am sure that I may go for the pelvic support as Ajai has pointed out. Pelvic support, if the attendants, parents are ready for the pelvic support. Otherwise, I counsel them just to wait for the THR and early THR and all those things. And if problem arises when they are early, basically, in that there are some osteotomies that have described. I have not that much of experience of those osteotomies because they are the complex osteotomies. I have tried few things like zoledronate acid, as Sir said, and in some of the cases I have also tried the synovectomies and the capsulotomy, and there are 4 or 5 cases, and I tried the distraction by using the fixator and the distraction at the hip side. So I have received like that pain relief is there, but that's not the permanent solution.
You mean to say arthrodiastasis?
Yeah, arthrodiastasis. Distraction at the joint side.
I've seen few of these pediatric AVN. They are not very symptomatic. So they can pull on. There's no method which we are practicing. The rotation osteotomy is only in the books.
They don't take
Only-
a call only, so they go for THR, wait for THR to get in.
Yeah, but if you get at age 6 years, AVN, that's a big question. You will only do a THR when he's 18 or 20 years old. So how to pass, that's the question of Rehan. So in my experience, they are not very symptomatic. They have some deformities, but they can pull on, walk around, sit around, and you wait. The osteotomy which only works is valgus osteotomy, where the normal cartilage can come. The rotation osteotomy, I have not done. Not many people are
Very
doing
correct that
it.
initially they don't have that much of pain. But in two of my patients, one of them from the Nepal, and what I have noticed that through the time, basically that child developed the AVN at the age of around 9. And that child during the course of the time, though he was not having pain initially, but later on developed a severe stiffness around the hip. And that, later on realized that stiffness, why that was. Maybe because of the local inflammation or because of the pain, he was not moving like that. So there was some pathology. He had developed that stiffness. The stiffness is a big problem during the follow-up.
Okay, thank you, Dr. Vivek,
Thank you, sir.
for such a nice presentation. Now I will call upon Dr. Spanshu Bari. How do I manage femoral shaft fractures in a spider?
Good afternoon, everyone. I want to thank Dr. Sir and Pratik Bhai for inviting me here. So, pediatric orthopedics cannot be complete without speaking about spica, be it in trauma or be it in cold orthopedics. So, I'll be telling about what is the role of spica in femoral shaft fractures. So, by the end of this lecture, we'll be having clear view about when to use spica in femoral shaft fractures, how do we apply it, and when to consider initial traction, when to give delayed spica, early spica, and what are the possible complications we should keep in mind while using this method. A brief introduction, it comprises around 1.6% of the pediatric fractures and common in males. So our aim of treatment in a femoral shaft fracture, or for that matter any fracture, is to maintain the length, alignment, and rotation. If you follow these three things, our outcome is going to be good. Initial management, patient presents to the casualty, follow the ATLS protocols, airway, cervical spine, breathing, ventilation, circulation, and hemorrhage control is necessary. And after this patient is stable, go for the secondary survey and do a complete musculoskeletal examination, rule out other fractures, other injuries of other joints. With thorough neurovascular examination, don't miss out on any distal neuromuscular deficit. Splint test is essential to give pain relief as well as to reduce anxiety of the child and the parents. Younger child, you can give a high Gowen slab or a T slab. Little bit older child, you can use a Thomas splint. And radiographs, as I've been mentioned since morning, always one joint above and one joint below. Don't forget. General principles, primary management should be such that we do not need a secondary procedure. That should be aimed. We do a single procedure and that's it. If you're aiming for two procedures, that means there is something lacking in your management. And the perfect anatomic reduction is not essential in pediatric femoral shaft fractures. And with younger age, there is more chance of remodeling, and the alignment of the fracture fragments is more important than actual position of the fragment. So patient presents to you, when do you think of spica? Patient is less than 5 years, patient is less than 50 kgs. How do you know that? Because patient is in the stretcher, so you eyeball. You have been seeing children from childhood. So we know, we can make out what's the weight of the child. Less than 48 kgs, go for spica. Shortening up to 2 centimeters, you can check the telescopy, but it's a painful procedure if you can do it. Otherwise, by looking on the radiographs, you can make out whether the shortening is more than 2 centimeters or not. And isolated injury. So then comes the fact, what spica tip will be used? That is a question. When I became a consultant, I started asking everybody what spica tip will be used. So there are various variations. I got some pictures from Chacha Nehru, Delhi, KGMC, Lucknow, and the costlier one is there, which is 6 to 8 lakhs rupees, which I don't think anybody in India will be having. So basically, you need a bar. That's the basic funda. You have to have the bar to support the trunk and a trunk table, and you can have variations. You can make of stainless steel, you can make of cardboard, supply anything, and make a desi jugaad for all this. So now the patient is in the OR. So what to do? Now I do not prefer putting a definite spica in the casualty or the ED. Always take the patient to OT, because in casualty you have a lot of other factors just on which you do not have control. In OT you are in charge. you are in complete charge in there. In the casualty, there are a lot of things in which you do not have control. Heavier child, go for GA, top of the anesthetist, either mass, short GA or IV GA. But in Indian scenario, sometimes the OT slots are not available, the anesthetist is not ready. So go for conscious sedation, either with promethazine or pedicloryl, 5 to 10 ml, and there's no issue in that. And how to decide whether I have to give sedation or anesthesia? Approximately. Lighter the child, more use of sedation. Heavier the child, go for anesthesia. Application. The technique is universal. Place the child on the spica table. The hips should be abducted. As we all know, the pull of the forces, there is an effective varus thing at the fracture site. So, and there is a controversy regarding whether foot should be included in the spica or not. AOA recommends not including the foot, but what I've learned is include the foot in the spica, and I follow that. And always give a valgus molding to the shaft so that to prevent future varus collapse. So, and then you put the bar to prevent any. So, how do I position the limb? Flexion at the hip of 30 to 60 degrees, knee 50 to 60 degrees, abduction at 30 degrees at the hip, external rotation of the 20 degrees, depending on the best look on the CM view. The more proximal the fracture, you have to give more hip flexion because the iliopsoas will be pulling the fracture fragment. So more proximal fracture, more hip flexion, and less knee flexion. It leads to loss reduction because your quadriceps, all the vasti, they act as internal splint. The more you flex, the more stable is the fracture reduction. So this is the position of the child. I include the foot in the spica. The acceptable reduction is shortening up to 2 centimeters is acceptable. After 30 degrees of valgus after 2 years. 15 degrees after 2 years, after 30 degrees of AP angulation after 2 years, 20 degrees up to 5 years. And when you take the check X-ray, the AP of the hip and AP of the knee should match. That shows you that the rotation is intact. So you cannot know on the CM, you cannot make out the tips and tricks. Just see the hip X-ray, knee X-ray, they should match. After care, always admit the child for 24 hours because your trunk is involved in the spica. Check the neurovascular status, check the radiograph. Explain to the parents how to take care of the child in the spica because that is important. They do not want the parents to come back with a broken spica, which is very common in India. Explain to the child how to make the patient supine, how to make the patient grow without undue pressure at the joint of the hip, where the trunk and the hip. And always tell the patient to report whenever there is a crack or weakening at the hip joint. This was a hip spica stroller which has been devised by the Ahmedabad group, in which it's easier for the children, for the parents to mobilize the child during the treatment. The protocol, after you finish the spica, check X-ray ho gaya. Uske baad you always take a repeat X-ray at 1 week. You see if there is any deviation, if the criteria is being met. If it is not met, always be ready for a wedging, either on a varus valgus or for an AP angulation. Subsequent X-rays at 3rd week and then at 6th week. Spica removal, simple formula, the age of the child plus 3 weeks. You don't have to worry about 6 hafta, 8 hafta, age of the child plus 3 weeks. So when do you be ready for wedging? You have sent the patient after the initial treatment, but you have to be prepared if the patient would need wedging at the 1st week X-ray. So increased age of the child, a low energy fracture or oblique fracture. These fractures may need wedging, so be prepared. So how much remodeling to expect? There is no rotational correction. Up to 2 centimeters of overgrowth has been reported in literature, and significant angular deformities correction is there if there is enough growth potential, because usually we use spica for less than 5 years. So there is a lot of chances for the deformity correction. And because the plane of the motion is there in the AP plane, if correction is more than the varus valgus correction. So when do you expect more than 2 centimeter LLD? Increase age of the child, increase weight of the child, in the longer period of immobilization. This has been seen in the studies. Now, delayed spica. When do you consider initial traction before applying the spica? So if there is shortening of more than 2 centimeters, unstable fracture patterns like spiral fracture, lung, oblique, and cumulative fractures, polytrauma and open fracture. Polytrauma and open fracture is again debatable because you can again go for external fixator, which makes the rehabilitation of the child beneficial. But if you're talking only about spica, they should either go for a delayed spica application. There have been studies which have compared the early and late spica application for femoral shaft fractures. So early, it has been shown that it has reduced hospital stay, better patient and parent satisfaction. But in early, there's always increased chances of revising the cast either in the form of wedging. So be prepared for that. Complications, overgrowth and shortening both can occur. Overgrowth up to 2 centimeters has been reported in patients who are less than 10 years of age. Shortening up to 2 centimeters is acceptable. Skin complications, as we all know, is common and should be looked after. Yeah. And lastly, parents. In pediatric orthopedics, we have two patients. One is a patient themselves, second is a parent. So parents' view also has to be taken and explained to them. They have difficulty in hygiene of the child because there is a cast, the child is increased in weight, so carrying them is difficult. And there is always a loss of pay for one patient parent because one parent has to stay home. So these are things has to factor when you speak to the parents and the order. So summary, use spica when the child is less than 5 years or less than 45 kgs. Initial traction when the shortening is more than 2 centimeters or if it's unstable pattern. Technique of spica application, read each time and always include team members because spica application is not a one-man job. And wedging is always handy in loss of reduction. And up to 2 centimeter shortening, you should not be worrying. Thank you.
Thank you, Dr. Siddhantu. This is open for discussion. Before others ask, I will ask you one question. There is a technique in which they apply initial traction and then in the Thomas spray and convert the same Thomas into spica or top of plaster. And I've seen this successfully done in England where I was sometime in already hospital. So what is your opinion?
Sir, I have read about it, but I have personally, I have never used it. Maybe senior people can say. I have never used it personally.
It is a good method because the initial 2 weeks, if you give a traction, in a younger child, they are in hospital and plaster incidence will go down.
Including Thomas plane, you know, sir.
And the other advantage of that is that child can sit up. Okay. The other question is, if you get a patient from labor room with fracture shaft femur, how do you treat?
So if it is a no, just neonate, just take a cardboard piece or something and then you immobilize with it. If you get a Pavlik harness, that's also fine. No need for any extensive immobilization in a younger child, in a neonate. A cardboard piece also is enough for the immobilizing the femur.
Why cardboard? Why can't
it can be Pavlik? No, sir, slab because first of all, the skin of the neonate is much more sensitive. So I would not like to go to sleep at night thinking what will happen to the child. So I would be happy with just applying this minimal splintage than to spoil my sleep at night.
So the method described, they strap it to the abdomen. Have you heard about it? You practice it?
So yes, sir. But usually, if you just give a Pavlik hand, which effectively flexes the femur to around 90 to 90 degrees, so that effectively means you are flexing and touching the abdomen.
Basically, TOGAT was used for transportation of the patient. That is the reason why TOGAT was devised. So that is one I think I would like to tell Dr. Singh. But definitely treatment, I don't know, in TOGAT. Secondly, I think immobilizing the foot. If we are giving flexion at the hip and flexion at the knee, now the thing is not acting as a single unit. So you can very well leave the foot aside. You can leave the foot there. But if you are giving more extension, then there is a likelihood of rotational thing transferring to the joint of the femur. Then you can perhaps go for it, using the foot as including the foot movement. That is my opinion.
For foot is that, sir, I have learned that way and I don't want to change what I've learned because learning new thing is difficult. So I'm continuing doing that.
You mean to say, sir, the shaft femur, you need to include the knee as well as the foot in a class?
Yes. So AO recommends the foot, we don't include the foot. But what I
better to include the
yeah, better to include the foot. I do that. No, I do that. I said
it is better to include the foot.
yes.
And I'm telling that if you are giving flexion at two stages for the two joints, at the hip and at the knee, now the limb is not acting as a single unit. So that is why you can leave the foot aside. In that scenario.
In that case, we can say, but sometimes we don't give 90.
Yeah.
Yeah, not 90, not 90.
60 years. 60 and 60.
Also you can leave the foot. That is my opinion.
Thank you, sir.
Less than 6 years age, what is your indication of operation?
So depend on the patient size and the weight. If it is 6 years, patient is heavy, I'll go for operative intervention.
What?
If it's a low, it's a stable fracture pattern, I'll go for elastic nailing.
Because I have seen surgeons operating at 2 years. So that's what I'm asking you.
It's 6
Every
years.
chef femur fracture, they'll put something. So there has to be an age.
See, age,
Below which, like 6 years.
age cutoff is 5 years, sir.
So
Yeah.
cutoff age
5 to
is
6.
child 5 years, 5 or 6, some literature says 6, but AO says 5 years. It's okay.
And 5 to 6 is a gray area. You see the size of the child. If it is heavier child, taller child, go for elastic.
Yeah, even in 4-year child is heavy child.
It's heavy child.
Then
So
we can
age,
go for tennis.
more than the age is the weight. So if you see it's a heavier child, go for elastic.
Any other question? You want to make comment? Yeah.
We should be a little bit, from my own experience, we should be a little bit more careful in that borderline age group. When we are operating, say, like normally 4 years or 5 years, I think it's a borderline, this thing, 4 years, a bulky child we will be operating. I recently had a case in which the child was around 4.5. So again, the borderline, this thing, it took almost 3 months for the fracture to join. And I felt that if you'd have done a titanium elastic nail in the first place, he could have been mobilized a little bit early. So that is the message from the.
I have seen a lot of complications of young patients, pediatric age group being fixed. I've seen a lot of complications, infection, other problems. So previously, it was said that don't operate less than 8 years. Now they have come to 6 years. And you are saying 4 years because weight is more. So in expert, listen, in expert hand, the treatment is different. Here we are general population. So you cannot advocate a treatment to general orthopedic surgeon. You have to keep separately for the specialist. In your hand, 4 years is fine. But if you get infected and get osteomyelitis, you can treat in spica, it may have some deformity, some shortening, it becomes all right. So I think I have an objection to younger age group, and I don't operate less than 8 years. This is my personal view. You may have a
When we were
different view.
students, so that was the dictum. When we were students, that was the dictum. That's how we.
So with time, the indications for the surgery is.
Age is reducing.
I think whatever you do it safely. That is, and you need to know how to do it. I think. Otherwise, yeah.
We will have Dr. Ritesh Pandey and Dr. Pratik Bera. I think it is a discussion between titanium nail and steel nail. So we are topic is elastic nails for the femoral shaft fracture, whether you will use titanium or steel. So first, Dr. Ritesh Pandey.
Thank you, sir. Good afternoon, everyone. And for this debate, I will be speaking in the favor of a titanium elastic nail. So let me explain the controversy first. We all have been using a stainless steel nail in the form of rush pins and enders nails since long time. However, titanium elastic nails are widely used now for pediatric femoral shaft fractures. And there is another group which favors stainless steel elastic nails as they are claimed to be stiffer, cheaper, and easily available. So this debate will end if we are talking about a remote area where titanium nails are usually not available, or if there are financial constraints in the family. So I assume that both the nails are available and affordable, and then why I use a titanium nail instead of a SS nail. Also, if we are talking about this stainless steel elastic nail, I doubt about its easy availability. I am working in a tertiary care center and still it's not easy for me to get this nail so easily. So the only point which stands in favor of a SS elastic nail is that it is stiffer and it makes stronger construct than titanium. So let's compare these two implants in different aspects. First, serving the purpose. Now here I have simulated a titanium nail with bends only because it is more expensive as compared to a SS nail. And both these cars serve the purpose of transportation. So do the nails. Both are effective in managing pediatric femur fractures successfully. and it is supported by literature. Well, this randomized control trial reported similar clinical, functional, and radiological outcomes and a similar rate of complications for both the implants. This is another RCT, again similar outcomes. However, the incidence of rupturing the opposite cortex while inserting a SS nail was significantly higher, and this could be because of the fact that SS nails are stiffer. This is another systematic review, again mentioning similar outcomes. So we can say that both titanium and SS elastic nails have similar treatment outcomes. Okay. Now coming to the comparison of features. We know that titanium is a metal and SS is a metal alloy. So how does it matter? Well, it makes the titanium less dense and hence it is lighter in weight. Titanium is more elastic and hence we can bend it without undergoing permanent deformation. Yield strength is more and so it is more durable. However, tensile strength is less, but we can see the difference is not very high. Now, this study has reported less tolerance for titanium nails to the torsional stress, but there is more tolerance to the axial load. This is another study which has now mentioned equal tolerance to the rotational stress here. The bending stiffness for titanium nail is less, but it can be improved by using a CS configuration as shown in this figure. So both the nails enter through a common lateral entry point. One is going in C, other is making a shape of S. So that is how to increase the bending stiffness. So now we can say that there is a biomechanical advantage for titanium nail. Torsional and bending stiffness may be less, but it can be improved by a CS configuration. Now coming to the safety in terms of biocompatibility and tissue tolerance. So what does this mean? Biological tolerance depends on the amount of soluble implant material which is released in circulation and toxicity of this released material. And we all know that nickel and chromium, which are components of stainless steel, they are more allergenic and are less tolerable to the soft tissues than a titanium. And the same study has mentioned these positive points for titanium. They have better adherence to surrounding tissues, better adherence of surrounding tissue to the implant, which makes them resistant to infection. They are more resistant to corrosion and hence less corrosion products are released and hence less toxicity. Then the corrosion products which are released are well tolerated and hence less chances of allergy. Then titanium are MRI compatible and there is better osseointegration and so implant loosening and migration is less. Now let's compare the complications. Actually, this was the first study which has compared complication of a titanium and stainless steel elastic nail. And this study has mentioned significantly high number of malunions with a titanium construct. But then similar successive studies have, they didn't report any difference in the rate of malunion. In fact, as discussed, this study has reported more chances of violating the opposite cortex with a SS nail. And this study published in Injury Journal, they have not found any case of malunion by using a titanium nail. Few minor complications were reported, which were more associated with the surgical technique and surgeon's learning curve, and it has nothing to do with the type of implant material. Moreover, the complications are more related to the mechanism of injury, the weight of the child, and his age. And as we can see, they are not in the control of the treating surgeon and has nothing to do with the type of implant. Also, if I am worried about a road traffic accident, which in our case is a malunion, what will I choose? I will choose some other mode of transportation rather than choosing any other car. And so for obese children and elder children, where I expect more risk of malunion, I will go for some plate or fixator or any other mode of fixation. So I favor the titanium elastic nails because they are effective, safe, and has acceptable rate of complications. The strength of the construct can be improved by following standard technique. And I will go for other mode of transport, other mode of fixation, especially for obese and elder children. And I will say that if one has some disadvantage, that does not make the other one perfect. There is always scope for improving and making it better. Thank you very much.
So good afternoon. So my dear friend Ritesh has made a valid point, and actually he has quoted many papers, which I am also going to quote. And while quoting that, you will come to know that the way you have to interpret a paper depends on the way you have gone into thinking about it. So the same papers which he has interpreted in a different way, I am going to interpret in some other way. And then you will know that not all papers are perfect. And for while you are reading and analyzing a paper, you have to keep an open mind and think objectively. So first of all, I must acknowledge that this idea of debate was not mine. Basically, it was Dr. Rahul's. And he suggested this debate in the month of January. We are planning for the pediatric femoral session in the meeting of BOSS. At that time, because of time constraints, we did not proceed. But I must thank him for bringing out this important topic. So these are the common type of nails which are used for fixation in femur fractures in children. Of these, our point of primary discussion are on the left-hand side, right-hand side of the screen. Both of them are the straight ones. And one more nail is the old ender nail, which has been there since past 40, 50 years. Though not classically an elastic, still it has elastic properties, and many people consider it to be an equivalent of an elastic nail. So basically, we have to understand what does an implant do for any sort of fracture. So its only purpose is to retain the reduction till the fracture is united. And one more preferable option will be to allow for early mobilization for better functional outcome. So the debate about a perfect implant or ideal implant material has never been settled. And while these are the properties which are expected, and if you go through the textbook, which almost everyone must have read during their residency, there are multiple expected things, but the end result is that such a material which can be considered as an ideal material for implant is not available. What we are using are stainless steel alloy and also titanium alloy, not pure titanium. Still, we are using the titanium alloy. They both have some advantages, some disadvantages. Dr. Ritesh went into it very great detail. And if you look, titanium is preferred, as he also told, because the mechanical properties are much closer to that of bone than steel. And the corrosion resistance and potential of toxicity and soft tissue damage is much lesser with titanium than steel. However, that being said, if I may quote, in the year 2021, there was a systematic review as to what implant material is better. Before we delve into the details of titanium nails and steel nails, what implant material is better? They found that the results are inconclusive. Two areas which they have noted where titanium can be favored over steel, that are use of a distal femoral locking plate in distal femur fracture, because you get early and more callus and less stress shielding, and in tibia nailing because you have less breakage of the interlocking bolt. But overall, the stainless steel is equally good as titanium for any other location. But this paper did not discuss the point which we are going to discuss. So in my quest to get an answer, I refer to this age-old textbook, that what they are recommending. Does AO recognize stainless steel? Yes, AO recognizes that when you use a nail, whether titanium alloy or stainless steel, they have adequate strength to maintain the reduction till the fracture is healed. So our purpose is getting solved. We are going to obtain reduction. We are going to retain that reduction, and that can be done till fracture is getting united. So there is no clear statement that steel is worse than titanium. Now I am discussing the other way around. The steel is not worse. than titanium. So this paper Dr. Ritesh quoted, and this paper was one which actually suggested that titanium had some better properties than steel. But after that, so this is the same paper. Just 2 years after that, one more paper came, and they studied biomechanical comparison of stainless steel using and titanium flexible nail and external fixator. What they used was ender nail, not classically the SSEL, but they found that the ender nail was superior to titanium in control of sagittal plane angulation, but it was not statistically significant, and that a smaller diameter ender nail was better than a larger diameter titanium, or 3.5 ender was better than 3.5 titanium for bending stress. So again, there is no clear statement that stainless steel are worse than titanium. So this is the same paper which Dr. Ritesh has quoted. And this paper actually came out with 56 children. They treated with titanium elastic, 48 with steel elastic. They noted the major complications to be almost twice with titanium than stainless steel. Malunion rate was almost 4 times in titanium than stainless steel. And minor complications were similar, but the cost was 1/4 for stainless steel than titanium. So then I went and read few more papers. And what they found was, this is a stainless steel nail, flexible nail, made locally in a poor country, Colombia. And they found that for a period of 24 months after they followed up the children, the results were almost similar, like that for titanium. All major and minor complications were similar. They concluded that the results with stainless steel nails are as good as titanium nail with a shorter follow-up as reported in the literature. Then the same paper from UCMS GTB hospital, both similar, no complication, no major issues, but stainless steel was cheaper. Finally, this paper with Dr. Ritesh is also quoted. Cost of stainless steel was 1/3. There is no clinico-radiological difference between the two groups at 1 year follow-up. These are for ender nail. This is from US. This is from India, SMS Medical College. No difference, nothing, same results. So with all these things, finally this result, which was, this was also again quoted by Dr. Ritesh, that they used a systematic review, and what they found that there were 5 studies. They reviewed, out of those, the nail removal time was less for titanium nail in only 1 paper. 2 studies had higher rate of malunion with titanium elastic nail, and there was no difference in the rate of delayed union or infection in the 2 groups. They concluded there is no consistent evidence to suggest that one type of nail is better than the other. So still now we are, cannot say that yes, you have to use titanium only. Steel can also be used. So then I did a market survey. So in Bhopal, of all vendors, only 3 were able to provide stainless steel nail. New Delhi only 1, 0 in Chandigarh, Indore only 1. So almost everyone has titanium nail. Some have ender nail, but almost very limited people have stainless steel nail. So the reason is why? My understanding, I don't know why this has happened. While there is a possibility that the awareness is relatively lacking, that both are similarly effective. We are preferring titanium, but probably we can get the thing done in relatively cheaper rates. Unavailability, as just discussed by me. Misconception, probably marketing ploy by the manufacturers, that titanium is always better than stainless steel, and a lack of hard-hitting evidence at present about one being better than the other. So we have come to the situation where we are in clinical equipoise, and Dr. Rehan is smiling because it is one of his favorite terms. So we are in a stage of clinical equipoise. So what do you do next? Till we get an answer to resolving this clinical equipoise, I searched the literature and I found the guidelines, the steps for performing the nail from Synth's website, and they have found out that titanium alloy implants merge high mechanical stability with elastic properties, but they recommend stainless steel implants have higher mechanical requirements. So those situations where the mechanical requirements are high, they are recommending stainless steel. This is the Synth's group, not me. Then when you read the discussion by Dr. Thakkar, it is a surgeon's choice at present because there is clinical equipoise, you don't know what has to be done. Stainless steel is stronger with a higher tensile strength. Stainless steel, but this has not been assessed for ender. Stainless steel has the strength of TEN, one size larger than itself. That means if you are using a 2 mm stainless steel nail, it will have an equivalent strength that of titanium millimeter 3 millimeter diameter. TE and elasticity and handling characteristics are very suitable for a child's diaphysis. This is the statement from this book. But what they find that stainless steel can be preferred if medullary canal is disproportionately small. That means you have to use a nail if you are using a titanium, a thinner nail. So in that scenario, you use a thinner steel nail rather than a thinner titanium nail. And if you are considering it for a heavier adolescent. So in conclusion, nothing can be written in black and white. And as Dr. Ritesh told that you have to choose between Mercedes-Benz and Suzuki car and you look for Vande Bharat. I think we have to go somewhere in between because being a resource constrained country, if we have availability of similar mechanical properties and we can get similarly functioning implants at a relatively fraction of a cost, then we can actually prefer stainless steel. And I would like all my colleagues to plan out in collaboration with us, in collaboration with other orthopedic surgeons, a relatively larger study where we can compare the stainless steel elastic nail and titanium elastic nail and try to break that clinical equipoise. Thank you.
Now, I think the session is open for questions, and we would also like to have comments of other faculties who have come to comment on it, please. So, if any question.
So not a question, but just a comment because the randomized control trial which was published from UCMS, I was a part of that group when we were doing that thing. The genesis of that study was they had initially done a study on titanium elastic nails and they found that the malunion rates were increasing. So Sarkari hospital hai kya karna hai yaar, malunion ho raha hai. Then we started putting in casts to a tense nail and some sort of an immobilization just to reduce the malunion rate. But then also problems were happening and therefore Dr. Aditya, who was the lead author in that paper, he said, yeah, let us do a review of literature, let us see what is it that we can do differently. And then he found some studies where it was saying that stainless steel is actually doing better than the tense nail. And then he designed this randomized control trial to do the stainless steel and the tense. And honestly, after they started doing stainless steel, the rates of the malunion actually reduced. Maybe it were heavier childs which they were choosing, or maybe the age was more. I really don't know. But we have to look at that paper and say that, yes, there is definitely a role of stainless steel. That is what I would want to say, especially in the heavier children and the older age.
Stainless steel is elastic nails are malleable, more malleable. So I think I have never used, rarely I have used one of the cases elastic nails. Stainless steel has been much better.
I also have similar opinion as Dr. Sanjay Gupta. It is technically intraoperatively easier to put titanium nail than the stainless steel nail because more rigid and perforates the opposite cortex so doesn't go fly. And on the other hand, I think I'll agree with Rehan's observation that titanium nail patients have more bending or malunion than the stainless steel.
There is one observation actually what you were saying, malunion regarding what the answer said. In literature also malunions are basically specified with tense nail. But if we go through that, then we have to see three things. One is age of the patient, that Rehan sir has pointed out. Another is the weight of the patient. And third and most important is the technique, whosoever is doing. Because tense nailing is, tense or even elastic nailing is dependent on some principles, biomechanical principles. If whosoever is doing it, if they are doing it in a proper way, with keeping the apex at the flexor site and all those things, then definitely the malunion rates can be decreased. So age, weight, and the technique, these three are important things, I think. Otherwise, no doubt, steel nails have more strength, and even AO, what Pratik has referred, they have clearly mentioned that if the weight of the child is more, and even the configuration is fracture pattern is bad, then better to use the steel nail. Even in that though they produce tension only.
I say it is technique dependent. We have to encourage incorporate a longer contact area in the pencil. If you're using a smaller contact area, then it may fail. And if you are seeing a longer heavyweight child, older age child, you can supplement it with the X-rays also. Hence, gives a wonderful result, and I didn't have any problems over more than 100 cases now.
I also use pens. I don't use steels, but it depends on technique, I think, and what we are choosing the patient pattern.
Actually,
because sometimes if I find my fracture unstable, regularly I supplement with fixator.
Dr. Ravi, that is what I'm trying to say, that you, me, Dr. Abhishek and everyone should put together and do a proper randomized trial all over the country. Because if you look at the availability, Delhi only one vendor I could find.
It's not easy.
Bhopal, it is 3. No vendor in AIIMS is supplying for you.
Actually, the point is that because the demand is not that much.
Yes.
That's why.
So it was my colleagues from GMC who actually called up different vendors. Whoever vendors I knew, they all said, no, we don't have. They called up Dr. Vishal, Dr. Manish, and when they called up, they found there's 3 people at away.
So those who are, whatever we are using, we should keep on using that. And let's see what comes up with the later studies which Dr. Behra is suggesting. Now I call upon Dr. Ravi Chauhan. Tips and tricks of elastic nailing for lower limb fracture.
Good afternoon, everyone. I'm really thankful to Rihan sir, Prateek and Ajai sir and all the organizing team for the invitation. So regarding the tips and tricks of elastic nailing, actually Prateek has already explained in morning some of the important tips. Now I'm moving further, and as just now we have discussed that indication, age, weight, technique and the fracture pattern, these are the important things in elastic nailing. Other things are of no use. So before beginning, we should consider that this pediatric population, we should consider them that they are not small adults. They have different anatomy, different physiology, different surgical principles govern them, and even the implant requirements, they do have different requirements. So coming to elastic nailing, it's a minimally invasive, elastic and stable osteosynthesis, as we all know. Definitely the debate was going on that about the titanium and the steel, you all know. Coming to the biomechanical principle of elastic nailing, that is much more important, and we should follow it while we are putting a nail. Okay, so there are 3 important things. Double secant construct, because what it is actually, we need to construct the elastic frame intramedullary. So if that frame is stable, then that fracture will be stable. That frame should be that much stable that it should provide the stability to that bone. Okay, it provides us the symmetrical bracing action of the 2 elastic nails that are inserted into the metaphysis proximally and the distally. And there is a 3-point fixation. It should be better achieved. The 3 points are at the entry site, at the apex site, and at the distal or the proximal, depending on the entry point, metaphyseal site, wherever we are impacting the nails. So maintaining this symmetrical bracing and keeping the 3-point fixation in mind, our technique will be okay. So we should follow these biomechanical principles while the application of the elastic nailing. And because of this 3-point relationship, you can find out, you can see that in the picture that it provides the flexor, axial, translational, as well as the rotational stability. So almost in all planes, our fracture will be stable if we provide this 3-point fixation to our inside frame, what we are putting in. Coming to indications, which is much more important, selecting our patient. So patient and limb specific considerations, as I've already pointed out, age, weight, and soft tissue envelope sometimes, because depending on soft tissue envelope, we need to consider retrograde or antegrade and or medially or laterally sometimes. So most important is age and the weight of the child. Another is the fracture specific consideration, means fracture location and the pattern. it is also much more important as along with the age and the weight. So ideally, it is suited for the transverse fractures. In advanced cases, like in the comminuted fractures or more distal or more flexible fractures, no doubt these elastic nails can be done, but it require a bit of experience for that. So better to begin with transverse fractures only. If you are with your experience as you gain, then start putting it for distal and proximal or sometimes comminuted fractures. Because in case of comminuted fractures or other bad fracture patterns, you need to augment it sometimes with the external fixators as well. Okay, so I'm not moving it into it. So for the femur, length stable fracture in middle 60% of the diaphysis in a child of 5 to 11 years whose weight is less than 49 is the ideal candidate for the tense nail. Okay. Similarly, for the tibia, 5 to 14-year-age old child with unstable fracture, compound fractures, or polytrauma patient, secondary loss of reduction. These are the indicated which are referred in the literature for tibia. These are the various configurations for femur as well as the tibia nailing, depending on their retrograde entry, depending on the antegrade entry, and similarly in tibia, we usually prefer the antegrade from the proximal to distal. We usually don't go for distal to proximal. Sometimes an experienced person can do that, but usually it should be avoided. Okay. So coming to the technique, patient should be positioned, as you can see in the femur, supine, and in the tibia also supine with a bolster under the knee joint. Fracture reduction part is very important while doing the elastic nailing. There are four points where we need to do the fracture reductions. Initially, just before the surgery, in order to have an idea of reduction maneuver and the check for reducibility by the closed means while during the surgery. So initially, just try to reduce it and have an idea how you can reduce this or how you need to reduce it at the time of tense nailing. Another is the intraoperatively to facilitate the nails to cross the fracture. Another one is at the end of the procedure, that is also very important, that to facilitate complete reduction by the precise rotation and orientation of the nails. And another is, but not the least, just before the nail trimming, final impaction is done at the fracture site. Under the, sometimes even in the proximal femur, if I'm impacting the nails, I use the C-arm just to see the AP and the lateral views so that I'm impacting at the right angle, right orientation, right rotation. Okay, so at these 4 points, you need to reduce this fracture value. There are different modalities of fracture reduction. This is the common F tool. It comes with the tense set. This is the way how it should be used for the reduction. Another is you can use the tense itself as an indirect mode of reduction the fracture site during its application. You can use a sand spin, or sometimes in rare cases, you need to open it for the reduction. Implant selection, which is also very important. That's why I said the technique is important. Both the nails should be of the same diameter. Your entry points should be at the same levels. Coming to it. And nail size, inner canal diameter, you should measure it into 0.4. Means your whole, you should measure the diameter of the canal, and 80% of that diameter should be occupied by the tense nails. What I do, because there you can also find the difficulty of the resolutions of X-rays, what we do. Okay, there are different resolutions. So in order to get the accurate idea, what I do, because I usually cover my C-arm with a style drape, style transparent drape. So I just take a C-arm shot and put my tense nail over it and just have an idea that 3 mm, 4 mm or 2.5 mm, depending on the width of the size. So that is the actual basis of how I do. Okay, coming to the usual size, femur is usually 3 to 4 mm, tibia 2.5 to 3.5 mm, what we usually require. Entry points, which is also very important in femur, when we are doing the retrograde nailing, both the entry points, they should be away from the physis, almost around 2 to 3 centimeters. They should be symmetrically at the same location. And while doing the incision, just start at the entry point and move distally, not proximally, because your nail will go distally. Otherwise, the skin macerations and all those things, infections, bursa formation, these complications will occur. Okay. In case of the antegrade nailing, you should avoid the greater trochanter physis plate. Okay, keep it 0.5 to 2 centimeters away, 0.5 to 1 centimeter the proximal hole, and the distal should be at least 2 centimeter apart in both AP and the lateral views, so that the intervening cortex should not be broken. Okay. In the tibia, similarly, it should be away at least 2 to 3 centimeter away from the proximal tibial physis, And in this, while you are giving the incision, your incision should go from the entry point distally, because nails now will go upper side. That's why they should not impact the skin. This is the how we should proceed with the awl. First, it should be perpendicular to the entry point, and then with the screwing movement, just move 45 degree, almost 45 degree, incline it, so that our whole entry point will be made in that direction. This is the pre-bending of the nail. It is very important because this will provide us the secant arc formation or the symmetrical bracing. Okay, and as Prateek has pointed out in the morning, that our bending should be done in the length of the nail, and the length should be selected depending on the length of the femur or the tibia in which we are putting the nail. If the size of the femur and the tibia is short and we are just bending the nail of full size, then the apex will be at different side as compared to the fracture side. So we should take that much part of the nail, which is the size equivalent to the size of the tibia or the femur, whosoever we are doing. Okay, and this bending should be 3 times the diameter of the nail. Okay, coming to the insertion point, while doing, just put it on the nail inserter, or you can use your chunk, and after just insertion, it should be perpendicular to the shaft until it reaches the far cortex. And once it reaches the far cortex, that turn it 180 degree just to have the curved end over the distal cortex, so that it should not penetrate it, and then advise it further without further movements. Don't rotate it beyond 180 degree. Okay. And after, once it reaches first nail, once it reaches the fracture side, then take the another nail and get it up to the fracture side, that also, and then simultaneously move further. Now, after this, once you pass the fracture side, then move both the nails together, and after passing out, once you achieve the reduction and everything, then the final point of fixation is the impaction into the metaphysis, distal or proximal, depending on the entry point. That fixation into the metaphysis should be checked, and after the rotation conformation as well as the length. So at that point of time also, before that impaction, your fracture reduction should be accurate. This is the corkscrew effect. Why this occurs, as I have already pointed out, that don't rotate your tense nail or elastic nail beyond 180 degree. If you continue rotating it like that, then these nails will rotate around each other, and this will further impede this will affect your biomechanics, totally absurd biomechanics then, and it will not also move further. It will also impact your further advancement of the nail also. Okay, so avoid this corkscrew effect. Another is avoid penetration into the femoral neck. I have faced this in one of my patients, and since then I started taking the frog leg view while impaction into the neck area. I have penetrated the anterior cortex once. Okay. Assessment of the rotation, this is very important, clinically as well as the radiologically. Clinically, by having the normal range of motions, and radiologically, what we can do, lesser trochanteric profile. Okay, just have a C-arm view. In our picture, you can see there is the internal rotation, and in this the external rotation, depending on how much the size of lesser trochanter. This is how we can compare the 2 lesser trochanters. And this is the another method of the rotation assessment, vertical congruency assessment across the fracture side, vertical thickness, and the shaft diameter. They should match to each other. Okay. Coming to nail cutting is also very important because it will avoid the further infections, further skin macerations, and further complications. Okay, so nail should be cut in a particular manner that it should not be large enough that it will affect your skin, and it should not be small enough that it will affect your further removal of the nail. Okay, so and how you can do the trimmer, there is a nail cutter in the set, or you can do with the wire cutter as well. Avoid too much bending of nails. Just a bit of bending, not too much, because it will macerate your skin. Okay. End caps, usually I don't use it, but in literature also, and in 1 or 2 cases I have used it, that it provides the axial stability and also protect the soft tissues, and also aid in further removal as well. Okay. So axial stability means if you are having a fracture pattern of the comminuted pattern, and if you use these end caps, then it will protect further collapse of the fracture site. Okay. Compartment syndrome, especially in the tibia fractures, have a high index of suspicion. Increasing pain is the first sign, and compartment syndromes can develop because of your complete again and again manipulations and all those things. Implant removal, It is very important after 6 months at least and before 1.5 years. Don't keep the nails for too long. Otherwise, it will not be possible for you to remove them. Okay, so implant removal is also an important part. So better to make the proper decisions. That is more important, depending on your age, weight, size of the patient, and depending on your entry points, and all those decisions are more important, much more than your incisions. Okay, and develop your skills. And in the last, I would invite you for the basic Elizarov course. I have already pointed out in the morning. It's on 9th and 10th of September this year. Okay, thank you.
Now we will, I think we will skip the questions and in this instance, we'll go for case presentation. Dr. Manish Rajput to present his case.
Thank you, everyone. Now I am presenting a case of fracture sort of humor in a 11-year-old female. This was the X-ray. Here's the history of fall. The injury was closed and no other associated problems. What will you do? Any PG? Do you want any other X-ray? One joint above and one joint below. In this, unfortunately, I don't have X-ray of the knee, but it is normal. Now, what will you do? Yes, weight of the child is 35 kg.
Size of the child is small for it.
It's appropriate. 11-year girl.
What's the resident?
PG,
Just
any resident?
identify the fracture pattern. What implant you want to use in this?
It is stable fracture or unstable fracture? Length unstable or length stable? Yeah, it is a spiral type of the fracture. That's why it is unstable fracture. What will you do now? For stable fracture, we can very easily go with the TALS, intramedullary fixation.
Ideal indication actually. In
Yes.
this also, but that's why I said depending on your expertise and experience.
Yes.
Stainless steel.
Yes. We can also go through the stainless steel implant.
Any worry about nailing it? Any complication which is evident there? Can occur.
Yes, sir.
Any nail.
You have to be careful when you approach the possible fracture.
Yeah.
Very-
What is there?
If there is there, can split.
There is a fracture line which is going up.
Yes.
You have to be very careful, otherwise it will separate as a
This is-
butterfly. Yes.
This was the fracture line. Very long spiral fracture. Now what? According to the AAOS guideline, in the age of the 6 to 11-year child, we can divide the patient into category. One is the length stable and length unstable. It is length unstable implant, and the weight is less than 49. Then we can also do stainless steel implant as well as the TALS nail we can choose, but we can also do a some muscular plating, or we can also do intramedullary fixation along with the external fixation stainless. Now what we have, it was done somewhere else, not in our center. The surgeon choose the open method. What he used in this, what implant he has used? Any resident? He has used small DCP very small. It is not crossing the fracture also. Ideally, it should be 3 times the fracture configuration. And the fixation is not appropriate. And there is a not good reduction. Now, these are the problem. The fracture configuration is not fixed properly and there is a non-union. Yes, sir. Yes, sir. Now, there is a non-union and implant failure. Now, what will you do?
ये प्रिवेंट हो सकता था अगर इसको बूटन बार लगा के 6 हफ्ता लड़की को बैठा दें.
Yes, yes, yes. We can prevent the non-union after the fixation by providing butane bar.
You can unite. We can give a spiker to the
Yes, yes. We can augment.
spiker to the patient. It can unite this child.
It can unite. Now, what will you do? Now, three months down the line, what will you do?
Duration from a text certificate. Yes. Duration from a text certificate. You also have to rule out.
3 months.
Is it infection?
No infection now. It will heal.
Maybe. No, it will not.
Okay.
We need to intervene.
We need to intervene.
We need to remove this extraordinary implant.
Okay. We have to remove this implant. We have advised the removal and resurgery.
Now the age is.
But the patient went to the same surgeon.
Right. So problem क्या है इसमें? Again and again. Yes. Again and again. You are violating the principles.
Yes.
And you are putting everything on the implant. Then it's wrong.
Yes, yes.
Why not just immobilize? Even initially in 11 years, plate can be done.
Yeah,
Some
plate
of
can
the
be
plating
done.
can be
Yes,
done.
yes.
But the plate length should be okay. It should be done in a proper way.
Or
Then
it can be augmented
then
with
the
the
results
other
would have
method.
been much better.
Yes.
Even if you are not comfortable with the TANs, go and use the plate. No issue. But use it properly.
Yes, sir.
Point is-
Principle matters. Decision making is matter. Not the skill, but is the decision. According to the research.
At 11 years, especially in a female, even an interlocking nail can be done.
Yes,
But that will
Can be done. But not piriformis entry, but it can be trochanteric entry nail can be used. Rigid nail can be used.
We can last infection. Why not just put a spiker and wait? Give it a try.
The Rajput had beautifully enumerated all the defects in the last thing. I was going to ask the juniors and them to just to know what all principles have been violated here. You can put the other X-ray also. There is some things over there as well.
Now, this
Anyone
is the
can
second
point out.
surgery.
Anyone can point out what all principles have been violated here. Anyone from the juniors.
I have one more comment. If you look at the distal femur, you find that there is some irregularity there. Like somebody has tried to make such a nail.
Sir, he must have tried the TANs.
And then it has.
Yes. Sir, you have noticed.
You have rightly pointed out.
Yeah.
There are entry points. There are entry points.
There are entry points, then it must have split the segment. And then he has.
I haven't noticed.
Each of it was a resting.
He was not ready with the plate of that size or whatever.
And,
He was
yes.
not with that length of.
And in this also, he has.
That's the experience.
On grade the
Now, what wrong in this configuration?
I think मुझे लगता है
डॉक्टर साहब छुट्टी पे होंगे उनके टेक्निकल लेके होगा
नहीं पर वो गई वापस डॉक्टर के पास ही गई होगी.
दोबारा से सेकंड सर्जरी.
डॉक्टर साहब has placed the screw at the fracture site especially.
Yeah, will it unite? No.
There are a lot of issues.
What is wrong? The implant selection is not.
Question should be what is right.
Yeah, nothing is right in this. Number of screws are too much. And there is the infection. And knee is stiff. Refer to Ravi sir.
ये pediatric orthopedics का केस बन गया. Actually, that's why what Ortho was saying. If you are not comfortable with the technique with the implant, it's better to leave in a traction.
Yes, sir. Then go.
You can avoid this bad complication. That's why those things come.
Now there is the infection. Yes. Now implant is exposed. Now we have to tackle three things. One is the infection, second is non-union, and knee stiffness. What will you do? Naveen sir. Yes, sir. No. Then we have operated in Amelia hospital. Yes, sir. We have thoroughly debrided the bone and remove all the dead portion of the bone, and we are fixed with LRS, and distal corticotomy was done to the bone transport. This much portion was removed and corticotomy. The bone is transported. This was the follow-up X-ray. Now there is a union. This is the last X-ray after the LRS removal.
Good job, Manish. Manish, you did a good job, but why have you not used 3 pins in proximally? Was there any reason? Don't. Hand is good and everything.
One is small, that's why
But if you have used 2 pins, you can use 1 pin in between because that provides the more stability. I think
Yes.
that should be the principle.
Yes.
Otherwise, the job is excellent.
चल रही है सर. Yes, last call of the
Now we will have Dr. Vivek Tiwari for his case of presentation. Dr. Vivek Tiwari, Dr. Vivek Tiwari has to.
Good afternoon, everyone. Good afternoon to the esteemed chairpersons and the esteemed faculties and all my colleagues. First of all, at the outset, I would like to thank the organizers, Dr. Rehan sir and Dr. Prateek, for giving me this opportunity to present the case. So, I'm working at Apollo Sage Hospital. So, regarding the case, a 12-year-old boy came to the OPD with history of road traffic accident. He had complained of pain in his right hip as well as in the right ankle, and he was obviously he wasn't able to walk. On examination, there was tenderness in the right hip region as well as in the ankle. Active SLR was not possible. The right hip and ankle movements were painful, and there was no distal neurovascular deficit. So these were the X-rays which we got. So as we can see on the left-hand side, he had got a Delbert type 2 fracture of the neck of femur, and on the ankle he had a triplane fracture, a supination inversion injury, and that's the type 3 Salter-Harris injury in the distal tibia. So this is what was done, the post-op X-rays. Close reduction and internal fixation was done for the fractured neck or femur. Before progressing further, I would like to comment that this was operated after a week, around 7 to 8 days after the injury due to some financial constraints and some other factors. So the golden time was somewhat delayed. So close reduction and internal fixation was done for the neck of femur, 2 cc screws, and ORIF was done. Open reduction had to be done for the ankle, and fixation was done with screws and K wires. And then unfortunately the patient was lost to follow. He didn't comply with physiotherapy. He came straight after 1 year of the index surgery. And now his complaints were he had limping on the right side. He wasn't able to squat. There were no complaints in the ankle at that time. And when we examined, his right hip was totally stiff. It was fixed in 30 degrees of flexion and 30 degrees of adduction. So these were the X-rays after 1 year of follow-up when the patient came again. So as we can see, there is a non-union of the neck of femur. There is AVN as well. It has set in. The implants have protruded out. On the right-hand side, the ankle fracture has, however, united. So now the confusion, what to do? What should we do in this? What should be the further plan? So when we refer to the literature,
this paper was published in Hip International regarding the non-union pediatric femoral neck fracture treatment without open reduction. So they concluded that the non-union could be successfully treated by a valgus intertrochanteric osteotomy. So that is one of the best options for this. Another paper which Vivek Shrivastava sir also discussed, which was published, a very beautiful paper in JBJS. So they concluded that in patients with a delayed presentation, the intervening fibrous tissue and resorption of the neck, it does pose challenges. In these patients, in addition to performing a valgus osteotomy, also in situ stabilization with fibula, it adds to the bone stock and is recommended. And so these are the two literatures which we referred to and that make us help in the further plan. However, you can also refer to such papers if you want, where they treat them with extracorporeal shockwave therapy under navigation published from China. So unless you want to resort to this, obviously what we did was valgus osteotomy of the right proximal femur. Fibular grafting was done. At the same time, implant removal was done from the ankle, and a hip spica was added this time for added stability, because we didn't want to do it that way. So these are the post-op X-rays. The implant was used, angle blade plate, pediatric angle blade plate was used. The fibula was also grafting was done on the superior aspect. And these are the 1 year follow-up X-rays now. The neck union, the neck femur has united. The head has become of a mushroom shape. However, on the ankle side, now there is something else which we can notice. There is growth arrest of the medial distal tibia, and it's going into varus. Also, there is shortening of around 2 centimeters on that side, around 16 degrees of ankle varus is there. And this is the final functional outcome. He can now squat, and his hip is doing satisfactorily. However, we can see clinically there is a varus at the ankle, varus deformity at the right ankle. So now retrospectively, when we think why he developed varus on the ankle, so this paper is their recent injury paper about growth arrest and its risk factors after physeal fracture of the distal tibia in children and adolescents. They say that the degree of initial displacement, this was the only significant risk factor for growth arrest after physeal fractures of the distal tibia in children. So we can notice that there was significant displacement in our case in the distal tibia. It was reduced in a satisfactory manner. However, this was the outcome. Similarly, this was the another paper which was published very recently about incidence of growth disturbance after distal tibia physeal fracture in children, and they also concluded that the Salter-Harris types 3 and 4 fractures, they are very prone for developing physeal arrest, growth disturbances after distal tibia physeal fractures. So was the distal tibia Salter-Harris type 3 injury, and probably this increased the risk for the growth arrest. So now we are planning for doing a supramalleolar osteotomy with an external fixator with an Elisa rope to correct the lengthening, to correct the shortening as well as the varus deformity. Thank you for your attention.
Other questions?
Dr. Vivek, nice case. Actually, I'm not concerned about the hip. I'm just asking Uncle, after how much time you have removed that medial wire?
Actually, unfortunately, as I told, patient was lost to follow-up. So we removed it after 1 year when he came back.
Actually, problem was just it may not be the reason of the fracture. Just because of that wire, it could have developed the varus deformity. Because that wire was acting as a permanent anti-fascitis.
Right. Agree. Point well taken. That is one of the factors.
If it retained for 1 year, then definitely that varus deformity, because that varus deformity is typical. That's only in the coronal plane.
Right.
That was not in the sagittal plane. So if it is in the coronal plane, then it's a very one plane deformity, and one plane deformity maximum chances are just because of the medial growth arrest.
Right. Yes, sir. Agree with you. It could be one of the factors.
It could have been because of the fracture, then it could have been different things.
2 planes at least.
Right.
Point well.
Regarding the first initial management of the neck femur itself, you used only 2 screws. So that itself, there is a sufficient space for a third screw. Yeah.
There was
it is a unstable construct to begin with, but even it was a very good reduction. So even if you're leaving it 2 screws, then probably you could have gone for a spica at the first stage. So all this might have been prevented. You could say that.
Yes, I agree with you. That could have been one factor as well. Yes.
Nice question. I agree with you. The spike has to be given at the first place, and we use angle plate a lot. So because the advantage is we don't remove any core. If you use DHS, we will remove core bone from the neck. But in angle plate we don't use that. There is no need for spica after applying angle plate because it is a very strong implant. That is the first one point. And you used a double angle plate. Right. So if you want to give valgus, there is no need to double angle because you have to lateralize the cell. If you go on to give varus, then you use the double angle plate to medialize the cell. That is the 2 points. Thank you.
Second, anyhow, this patient will mostly land up in this THR at later date. But right now we have something called a neck lengthening surgeries. So that could have been attempted during that. It's definitely a specialty. This we are also like learning the trade now how to do it properly. But
in expert hand is probably
it can work. It can work. Like it prevents the need for an early THR, or we can give him far more years of disease-free life.
What's the age of the patient right now?
He was 12 years old when he first came. So after 2 years,
Right now he's
14 years. At the last follow-up, he's 14.
I think growth, not much growth
Not
that
much
is remaining.
growth.
Because you can use the medial screw just for that. Whereas that varus is not that significant.
16 degrees varus. So
Very shortening as well.
2 centimeter shortening is good. I think Lizaro is the best for.
I think we should now wrap up this session.
Thank you.
Thank you all the speakers.
Thank you.
Over to Dr. Pankaj.
Now it's time to show our gratitude to our speakers. I will call upon the Dr. Gaur sir and Dr. Sugla sir to give the mementos to the speakers. Dr. Vivek sir, please.
कैमरे वाला कहाँ गया? फोटो हो गया complete.
Thank you, sir. Dr. Vivek sir. Now it's called to Dr. Shikanshu Barik. Thank you, Dr. Barik. I will call to Dr. Vivek Tiwari. Thank you, sir. I will call to Dr. Rehanullah, sir. Please give the memento to Dr. Gaur, sir. Thank you, sir. Now we will move to the next sessions. It will be judged by the Dr. Ravi, the PBPS chairperson, and Dr. Vijay.
So I think the last session, I would like to invite Professor Dr. Rehan. Sir will be speaking on ACL injuries in children, a different ballgame than adult ACL injuries. So please.
So a very good afternoon to all of you. I think the last session of the scientific deliberations, the attendance is already becoming thin, and I would not want to keep you waiting from going home, right? So I have been feeling like a fish out of water for the last 2 days. There is a group of pediatric orthopedic surgeons who हमको hammer करते जा रहे हैं pediatric orthopedics ये pediatric orthopedics me. For a young, for an adult hip and knee surgeon like me, it was like a harrowing experience, and I was thinking, why am I sitting in this hall? But then Ravi said, the chairman said, sir, इस वाला avian हो गया neck femur में अब हम कुछ नहीं कर सकते. You need an arthroplasty. So that emboldened me. Yes, I have a role here, and probably this talk is also needed over here. So what I'm going to talk is to talk of pediatric ACL injuries, and just before we actually have to talk. May I have a show of hands of how many of the seniors, like all of you who are pediatric orthopedic surgeons, would see and do an ACL injury? You will do open, right? And for the younger crowd, how many of you have actually seen a pediatric ACL injury and have thought about managing it, right? Just a show of hands. Let us be true about it, because that makes my job very easy. It helps me to moderate my lecture to the level where it is actually needed by the crowd, right? So I think a very rare injury, and my job is easy. जो भी मैं बोलूँगा वो आप लोगों को शायद सही लगेगा, right? So the objectives will be, why are pediatric ACL injuries important? Why am I talking about it when even the senior people who are sitting on the front benches have seen very few of them in their academic careers? Why are they different from the adults? Ravi has already said a very important statement. There was a time when I used to do a bit of pediatrics work, and I had a slide where I used to say that children are not miniature adults. And I had a very good skeleton also, which just used to grow in size, right? And people used to see that slide and think, "Yeah, yaar, answer ko bhi kuch aata hai." But yes, the statement is still true. Children are not pediatric patients are not miniature adults. They need to be dealt very differently. I'm going to talk of the treatment options, a bit complex topic, but I'm trying to do justice to that. I'm going to talk of some technical tips and tricks, because I do a bit of arthroscopy work, and some of these cases need to be tackled arthroscopically. And last but not the least, we are going to talk of the preventive pediatric ACL injuries. I think a very new and a very interesting topic, because we as orthopedic surgeons are always thinking of ourselves as people with a knife, and we're going to treat everything with a knife. But remember, prevention is always there, and like we were talking during AVN, prevention probably is the best cure for a lot of things. So why are pediatric ACL injuries important? Because the incidence is increasing. And why do you think the incidence is increasing? Anyone? जब गौर सर ने पीजी किया होगा तो उस टाइम में मेरे को लगता नहीं कि भोपाल में एमआरआई होगा सर, या कहीं पे भी एमआरआई होगा, right? Now if you see in the city, there may be 20 MRI centers. So every knee who will come to an orthopedic surgeon, he will not be carrying an X-ray, he will be carrying an MRI, right? So if you have a higher sort of an investigation, naturally you are looking at the patient more diligently, and therefore you will get more ACL injuries. The next reason, when we were kids, we used to go out and we used to play, right? Abhi kya hota hai? My wife will say, yaar, mere ko beti ko na badminton mein enroll karwana. I tell her, yaar, badminton mein kya enroll karwana? Let her play. So people are becoming more competitive. They are not playing just for fun. They are playing because they want to get into some position. And so when you are into competitive sports, the injuries are more, right? The second thing is why I am talking about it. I already covered. Management is completely different from adults. Why I am talking about it is because decision making is more complex. And last but not the least, like we have been seeing since the morning, unlike in the adults, in the pediatric population, whatever you may do, the complications are always higher. And these patients tend to live with those complications for a longer duration of life. So number one, how are they different? What do you see on this X-ray? I think my PGs will be able to answer this. If they don't answer it, I think I have somehow failed in my duties as a teacher. So what do you think? Aisha is one of my most intelligent senior residents. Aisha, what do you think on this X-ray? I have given you a clue, right? Yeah, and what do you see here? Do you see a normal this thing? Yeah, and this is a disrupted one. And in your 6 years or 7 years as an orthopedic surgeon, have you seen this one or have you seen this one? Right. So what she's trying to suggest is that bony avulsions are always more as compared to mid-substance tears, or what we call as the peel-offs. So in a pediatric patient, because the bone is much more softer and the ligament is almost of the same strength as an adult, it will come out as a tibial spine avulsion fracture, and that is what you will see 80% of the times. Only 20% of the times you're going to get an ACL injury, which is mid-substance or which has come out from the femur. So treatment options, tibial spine avulsion fractures, I think a very wonderful classification already given by Mayers and McNevers. Type 1, almost undisplaced, kuch nahi karna hai, you can put the patient in a cast. Where will you put the cast? Either in complete extension, which is 0 degree, or maybe go down even to 20 degree based on what is the size of your fragment.
Just to keep the time, I'm not going to talk of when to put it in 0 and when to put it in 20. When it is type 2, the posterior hinge is intact. So you can try to do a close reduction. The technique of close reduction, I think the only indication in my practice where I'm going to aspirate a hemarthrosis today would be a type 2 mares and neck nevers. I'm going to aspirate the knee joint because I want to decompress it. I'm going to take the knee into complete extension so that this hinge sits down and then maybe apply a cast, right? For type 3 and type 4, the treatment will definitely be to do either an open reduction like you said, or maybe do a closed reduction arthroscopically and then fix it. So this is, as arthroscopy surgeons, we have n number of techniques, but this is something, a schematic diagram of what you're trying to do. So this is the crater that you have, the footprint of the tibial spine is there. You have put in 2 wires on either sides. This is a normal needle through which you can pass in a PDS sort of a suture. This is a nylon suture on both sides. Get your ACL footprint in its place, pass in a needle over here, and then just pull it down. So this is the sort of reduction. I think if it was, we had more time, we would have had a video also. But the idea is you have to do a reduction, whether you do an open reduction or whether you do a closed reduction. After you have done an open or a closed reduction, you have to fix it. Either you can fix it with the threads because you don't want to get too much through the physis, or you can put in a small screw which stays only in the epiphyseal part. The treatment algorithm for mid-substance tears, I think more complex, but I will run you through this. So the first thing is to do an MRI, right? I said the MRI is the gold standard today. A child comes to you who has got knee pain. He has got a tense effusion. You have got an X-ray done. You find that the X-rays are normal. The next step is don't worry. Kindly get an MRI. And in this group of patients, probably waiting for 3 weeks or 4 weeks as of today is not recommended. What is recommended is try to do an early MRI. You may over this thing, but then you will be able to treat the child better. Once you've got an MRI, if it is a partial ACL tear, especially of the enteromedial bundle, there is definitely a role of conservative treatment. So try non-operative conservative treatment. If it is a complete tear, then you have to go back to your pediatrics. Anybody knowing what is Tanner's staging? अरे यार मनीष तुम तो फैकल्टी हो गए, तुम नहीं बताओगे. Postgraduates, any idea about Tanner's staging? So Tanner's staging, you would have read in your pediatrics 1, 2, 3, 4, and 5. 1 and 2 are pre-pubescent, 3 is pubescent, and 4 and 5 are post-pubescent, right? So if it is 1 or 2, you have to spare your physis. So do any surgery which does not disrupt the physis. So these are physial sparing surgeries. I'm just going to talk of 2 surgeries which are commonly done. However, if it is Tanner's 4 or 5, you can go through the physis and treat the patient like an adult, like a normal ACL reconstruction that is done. The 3 is a gray area. For me, I will do something like 1 or 2, but 3 is a gray area. You can treat it either ways. So conservative treatment, I'm not going to talk of it, but bracing, activity modification, and rehab. The reason why conservative is not very popular or why it fails in children is because of non-compliance, right? So you have a child, he is a sportsman, he has injured his knee, you want to brace it, you want to tell him you don't have to play, he's not going to listen to you. And then he's going to have recurrent instability, he will have recurrent chondral injuries, he will have recurrent meniscal injuries, and then you have lost the knee, right? So probably one reason why people have started moving more and more towards operative management of these difficult injuries. So what is the treatment? This is, I think the people from the senior generation would know, you used to have an ACL injury, but we used to treat it by an extra-articular procedure. This is still valid for pediatric ACL patients where you are using an iliotibial band and you are creating the anterolateral ligament like this and then bringing the ligament into the knee from the over-the-top position, bringing it through the intermeniscal ligament, right? And then coming down, removing a little bit of periosteum over here and then stitching it. So what you are actually trying to do is you have actually protected the physis completely. You have not breathed the physis. The second thing is you have not taken any grafts. So your hamstring is intact, your quadratus femoris graft, your quadriceps graft is intact. all other grafts are intact, right? So even if you, like I say, there is a very high failure rate of ACL reconstruction in the pediatric age group. Even if this procedure fail, the knee is almost a virgin knee, you have all the ligaments, you can go back and do a reconstruction. These are the steps of the surgery. I think I'll just skip it. When you come to the next group, right? So you don't want to do a non-anatomic procedure when you have an anatomic choice, right? So you're going to do an all epiphyseal ACL reconstruction. That means I'm going to put my fixation, I'm going to make my tunnel through the epiphyses only, not crossing neither the femoral physes or the tibial physes, right? So the tunnel is much higher and here it is much down, right? So this way you can protect your physes. The fixation device, you can use suspensory on one side and you can use interference on both sides, or you can use suspensory on both sides. So fixation does not matter. The key principle is that you are not violating the physes, you are keeping your implants only in the epiphyses. This is the more easiest of the one that is to be managed. So you have a patient, you find this is a pediatric patient, 14 saal ka ladka hai, 13 saal ki ladki hai, you will do a Tanner's grading, and mind you, this is the only group of patients where I actually have done a Tanner's grading 5 or 6 times. It's not a very huge experience, but you will have to see these patients. So 4 or 5, you can actually treat them as an adult. So you can see that the tunnel is going through the tibial physes and it is also going through the femoral physes. The only trick is try to keep your tunnel a little bit more vertical, right? So if you keep the tunnel more vertical, naturally the physeal damage that you're causing is less. And then you can use the fixation either like the one which has been used here, or you can use a metaphyseal fixation. Last but not the least, I think a very interesting area of research which is coming up is prevention of ACL injuries. It is increasingly being recognized that young female athletes have almost 8 times more chances of having an ACL injured while they are into an activity like sports, especially football and other contact games, right? Why it is happening? People have started researching it. They have started identifying number of factors. There are hormonal factors, there are anatomic factors, and then there are mechanical factors because of which the neuromuscular control has been identified to be different in female athletes as compared to male athletes. And therefore, the current concept is that you should go for year-round training. You need to do a proper warm-up. You need to learn landing skills. You need to improve the agility. And last but not the least, work on muscle strength and neuromuscular coordination, especially if somebody is going to a level 1 or a level 2 sports activity. So what are my key take-home messages? I think this is I've directly picked up from a paper, and this is the level of evidence, the grade of evidence that is there. Number one, the MRI should be done in all patients when you're suspecting an ACL injury. It has to be done early. A trial of non-operative treatment can be done, especially if the ACL is injured less than 50% or only the anteromedial bundle is injured, and the patient's age is less than 14 years for the males, young 13 to 12 in the females. If it is a complete ACL tear in 2023, you have to do a reconstruction. However, you need to know how to do that reconstruction. One thing I missed out, there is no, in India, honestly, we don't have allografts, right? So we are always dependent on autografts, so not very important for us, but in the Western literature, there's a wide use of allograft, and therefore in the pediatric age group, don't use an allograft because allograft has much more higher failure rates. You're going to use an autograft. Physeal sparing ACL reconstruction when the Tanner stage is 1 or 2. Transphyseal ACL reconstruction for stages 4 and 5. I would say 4 and 5 for me, because for 3 I will do physeal sparing. And last but not the least, ACL injury prevention and neuromuscular training protocols must be used to prevent ACL injuries. Thank you.
Presentation, sir. So informative. Any question?
Just one or two points.
Yeah. Yeah, please.
Because I already told I have zero experience on arthroscopy. Most of the time, the intermeniscal ligament will come in between the fragment and the crater. So you have to clear that before fixing. And also in the late presenting or neglected avulsion cases, you have to deepen the crater to put the fragment into place. If the fragment is not put exactly into the place without deepening the crater,
it may cause impingement during the extension. So you should take care of that. Next, there is another reconstruction called hybrid reconstruction. So sir told in panel 3, I will do in between like that. So hybrid means you will do transfacial in the tibia and all epiphyseal in the femur. So like I sir told, you will have to go more vertical tunnel and more centrally placed. So the third point is there is a 3 or 4-fold increase in graft re-rupture rates in pediatric age group and also contralateral ACL. So in these cases, the graft choice also matters. So the recent papers are coming up with quadriceps autograft.
Right.
Because in children, the quadriceps is having a high collagen content and the diameter of the graft is around more than 8 centimeters. So it is not, there is no grade A recommendation, but it is a moderate level recommendation. The quadriceps autograft may be better than hamstring autograft. And return to sports should be not less than 9 months. Just a point there. Thank you.
Yeah, thank you.
Thank you, Dr. Karthik.
I think just adding on to that intermeniscal ligament thing, when we were initially doing arthroscopy, we always thought that it is the intermeniscal ligament which is always there. But now, if you look at the more recent papers, it says it can, most of the times it will be the intermeniscal ligament, but it can also be the medial meniscus and also the lateral meniscus, which can be the anterior horn of the lateral meniscus or the medial meniscus. And there is one paper which says that the medial meniscus is more common. So yes, when you are trying to do it, you will have to take it out and only then you have to reduce it. Thank you.
I do arthroscopy and I have an experience of almost 7 cases, right? First of all, I was very happy to see the pull-through technique, right, which you did. And the message, I have been giving surgical tidbits more than this thing, theoretical knowledge. The screw thing which, sir, you have mentioned. So have you any experience of the screw backing out and after that you shifted over to the pull-through?
No, I think I was initially trained in this technique only, although these are not my own photographs. I do it a bit differently. I put in these needles and then I pull the suture from the intermedial portal and then take it. But I was never trained in doing the screw technique. I've always been using the cross fiber wire sort of thing.
Should not be attempted.
Right.
My boss used to do that. The screw, first of all, it looks very easy to put a screw through the suprapatellar area, but it is one of the most difficult tasks to do. And second thing is it invariably backs out. The fragment breaks, it will back out and you will have some issues.
Your comment should not be done at all. This is what you are saying is true. I'm a great fan of his screw. I've done more than 70 cases. I've done 26 cases of PCO fixation. I have developed a different system. It's a more cancellous threads than the cortical fluid. Okay. So don't say it is not to be done. Preferably not to be done, you can say. That's what I'm saying. You may not have a good experience with it, but I hardly have done pull-through since I've developed that system. It's a 5 millimeter system with guide wire of 6.5 screw. And it is all threaded screw. So it doesn't break back out. And it has a washer.
Yeah.
So the technique is modified. I think pull-through has its own role where there is a combination. If there is a combination, you cannot use a screw. If there is a combination, you have to use the pull-through system. Okay? If it is a one big chunk of fragment, then you can use the screw with good hold.
So I think we are moving from the domain of pediatric orthopedics to adult orthopedics and arthroscopy. So we bring this discussion to an end and then
I have done few in pediatric age group. I have done in older. I was not knowing how old fracture you can avulsion you can fix. But up till 8 weeks, I fixed this pediatric old age group with the screws with good results.
Thank you, sir. Thank you.
Thank you, sir. Our next speaker, there will be debate. Both bone leg fractures in children. Either we should conserve them or operate them. And the speakers will be Dr. Saurabh Sinha and Dr. Sitanshu Bari. So first of all, Dr. Saurabh Sinha is coming and he is advocating the conserve.
Very good afternoon to everyone. And I would like to thank all the organizers, Anurag sir and Pratik Vaira sir, for having me here. So I will be speaking for conservative management in pediatric diaphyseal fractures in children. So I'll begin with the basic knowledge from the textbooks, and then we'll build up on the discussion. So it is one of the common long bone fractures in children, and with an annual incidence in 1 in 1,000 children, with a male predominance, and most common fracture pattern being the spiral type of a fracture. So almost 70% of these fractures are isolated tibial fractures, and only 30% being associated with the associated fibular fracture. And the most preferred treatment is close reduction and casting. So coming to the biomechanics, the muscles which originate from the fibula and they insert on the medial longitudinal arch like the tibialis posterior or the EHL, these muscles are the deforming forces. And when the fibula is intact, as we can see in the first X-ray here, they tend to pull the displace the fracture into a varus. But when the fibula is also fractured, the same muscle forces pull the fracture into a valgus alignment. Then in the pediatric age group, we have to be wary about the plastic deformation and the green stick fractures. So we have to look for the plastic deformation and green stick injuries in the fibula, because that will determine the molding which we need to do to reduce these fractures and to prevent re-displacements. So the basics of the casting method would be to have a uniform thin cast padding. A 3-point molding is very important so that the fracture alignment is well maintained. So when you have a varus fracture, then you have to have a valgus mold and vice versa. Secondly, to control the rotational alignment, you have to have a 30 to 45 degrees of flexion at the knee, and it also helps to keep the child non-weight bearing. Thirdly, an apex posterior angulation is absolutely not accepted. So to control that, 10 to 20 degrees of flexion at the ankle is also accepted. Lastly, loss of alignment is very common in the first 2 to 3 weeks, and the use of recasting or cast wedging techniques is very important to have successful outcomes. As exemplified here, we have a valgus redisplacement, and with an open cast wedging technique, we are able to get back the alignment. So the acceptability criteria for the younger children, less than 8 years, it's more relaxed. So up to 10 degrees of varus alignment is accepted, 10 degrees of apex anterior angulation is accepted, and a shortening of up to 10 millimeters is accepted. But more older children, just 5 degrees of angulations are accepted, and apex posterior angulation is absolutely not accepted. Only up to 5 millimeters of shortening is acceptable. So what are the indications for this treatment? So all non-complicated tibial injuries should be given a casting treatment. The contraindications would be if you are unable to achieve the alignment in our primary reduction, then obviously it's a straightforward contraindication. Other contraindications are the open fractures, presence of swelling, or the risk of compartment syndrome, and polytrauma children and children with floating knees. These are relative and contraindications to the use of casting. Lastly, children with higher body weight, usually more than 50 kilograms, or obesity, or to some extent adolescents, they are now being taken as relative contraindication, but this is where I would like to build my discussion. So what is the world doing when it comes to tibial fractures? So I would like to summarize it with the help of this meta-analysis, which was published in the European Journal of Pediatric Surgery in 2020. So they took 1,108 fractures, out of which 75% of these were treated with casting. 24% of loss of fracture reduction was seen. So that's a very high number. But with remanipulation and use of wedging of the cast, a large number of patients were able to achieve a satisfactory alignment. And at the end, just 5% of the patients had a treatment failure with respect to casting, and they were managed with operative methods. When analyzed further, when they looked at the displaced fracture group, the patients who had a displaced fracture to begin with, there we saw that the percentage of casting reduced. So the people were more tended to go for operative treatment. Secondly, again, when we looked at the age, comparing between the flexible nails and the casting groups, we saw that the nailing group had a higher age, mainly adolescents, and the casting group had a lower mean age, that is the smaller children. So again, there was a bias towards operating older children. Thirdly, when we looked at the presence of a fibular fracture, that is a fracture was present or it was an intact fibula, we found that when there was an associated fibular fracture, again people avoided casting, 50% only. Whereas when the fibula was intact, 80% of the patients were managed with a cast. Again, loss of alignment in the presence of fibular fracture, 38% versus just 21%. So taking these three factors, we'll just see what further evidence we have. So I explored the literature. I wanted to see what is the effect of weight and age with respect to the treatment of tibial fractures. And I found this paper by Rivera et al. Luckily, we still have contemporary literature on casting. This paper came out in JPO in 2023 itself to help me. So in this paper, they compared ESIN versus the casting group, both in adolescents. So both the age groups were adolescents. They were comparable. Both the groups had weight more than 50 kgs. So again, they were comparable. So out of the 141 cases, here what I would like to point out is that there is no difference with respect to malunion in between the two groups. Secondly, when we look at the radiological healing, the healing in the casting group is at a faster rate compared to the tibial nailing group. We see that by 6 months, 95% of the fractures have a three-cortex radiological union, whereas only 77% in the nailing group had a three-cortex union. Also, when we look at the time lag, they have reported that there was a 7 weeks longer time duration in the nailing group for radiological healing. And finally, when we looked at the time to full weight bearing, the difference was only 1 week. So the casting group took 1 week longer to have full weight bearing compared to the nailing group. Then I proceeded to look at the effect of fracture displacement and fibular fracture, how this impacted the treatment. So I found this paper by Kinney et al. And this was also a retrospective review. And in this, there were 57 patients who underwent close reduction and casting. Again, this was in the adolescent age group. And in the adolescent age group, we found that there was a very high failure rate with respect to loss of alignment. So it's up to 40%. So they did a multivariate analysis to look at the risk factors that were associated with redisplacement of fractures. And they found out 2 factors. The first one was fracture displacement as seen on a lateral X-ray. And they noted that if the displacement was more than 20%, the odds ratio of having a redisplacement was 6.9. Secondly, if the fibula was also fractured, then again having a loss of reduction was with an odds of 5.1. Then coming to another paper, here we looked at 137 cases with a mean of 10.2 years. Here again we had a similar loss of alignment of 21%. Here again we see, as in the meta-analysis, that when cast wedging and remanipulation was used, a lot of these reductions could be salvaged. And at the end, yet again, only 5% of failure rate is present. And only 2 patients had a malunion which needed further treatment. Again, in the same paper, in the patients who had a weight of more than 50 kilograms, the loss of reduction was no more than the mean itself. That was 21%, and it's only 20%. So there's no increased loss of fracture alignment. So with this, I have a very short message to give. That is, most of the uncomplicated tibial fractures should be and could be managed with reduction and casting. But we have to have a very good evaluation of the risk factors. We have to be careful when we are using this treatment in adolescents, in the presence of a fibular fracture, and when the initial displacement is larger. There is a high chance of loss of alignment, 24 to 40%, as already evidenced. But with close weekly follow-up, these can be picked up on time and can be managed with open wedge casting, or if there is a higher loss of alignment, we can remanipulate these fractures into a better alignment casts. Lastly, with careful treatment, we can have as much as 95% success rates with this treatment. And therefore, I would like to conclude by saying that casting, even in adolescents and in children who are heavier, can be taken care of by this method. Thank you.
Thank you, Dr. Saurabh. So now I call Dr. Sikanshu. He will be speaking regarding operative treatment of both bone leg fractures.
Actually, Saurabh has made my work easier now. He has told what are the indications for conservative management, what are the contraindications. What are the contraindications and the indications for operative treatment. There is nothing, no controversy in that. And he told 4 factors: age, weight, initial displacement, fibular fracture. These 4 factors, same factors, will decide whether you go for conservative treatment or operative treatment. So we'll be seeing what are the indications and what are the options for surgery. Pulse of examination, high index of suspicion to rule out child abuse, multiple fractures, metaphyseal corner fractures should be seen. Other syndromic and metabolic causes should be ruled out because tibia is one of the common sites for bowing and fracture. And open fracture, innocuously looking open fracture might have severe internal degloving and severe internal injury. So that should be kept in mind. And friction burns, fall from bike are common. Therefore, should be managed appropriately. Growth perspective, briefly, the tibia grows around 6 mm per year approximately with 5 mm per year distally. And the typical pattern of eye-shaped closure is that for the tibial epiphysis, and posterior to anterior for the tibial epiphysis, for the tuberosity, it is proximal to distal. Remodeling guidelines, as the age is less, more remodeling is possible, as we all know, in the plane of joint motion. Metaphyseal fractures, they commonly remodel better because they're closer to the physis. Rotation, less correction. Overgrowth, not as predictable as femur. Reduction, he has already mentioned, 8 years is the cutoff. More than 8 years, your coronal angulation, the accessibility reduces. When to operate, absolute indications, when there is inability to maintain the acceptable reduction, open injuries, suspected impending compartment syndrome, and polytrauma. Relative indications, multiple long-bone fractures, floating knee, that is lateral femur fracture, associated with spasticity like a CP child or a hereditary child, and any patient with bleeding disorders. These are the patient in which you have a floating knee. So ideal for management with a operative management for better care and as well as better rehabilitation. Operative options, they can be pinning and casting, external fixation, flexible nailing, a plate or a rigid nail. Pinning and casting, more commonly for distal metaphyseal fractures. Proximal metaphyseal fractures usually they heal even if there is a valgus because of Cole's family. They recover with the growth and it is rarely needed in the proximal fractures. External fixation, it is you can use for both open and closed. For a length unstable fractures, you can use it, and with polytrauma and open injury cases, and they can be converted to cast once the wounds are healed and once you are sure callus is forming, they can be converted at 4 to 6 weeks. Flexible lanes for open and closed, same indications as in femur, length stable fractures. Age less than 10 years, lesser weight child. Weight bearing may be allowed at 3 weeks depending on how much callus formation is there. Initial protection with a cast can be given, and removal around 9 to 12 months can be planned. Plate osteosynthesis is also for a length unstable fractures, and you can either go for anteromedial minimal invasive technique, anterolateral you can use open technique, but they have their own complications, own complication chances, and increased OR duration for the child. Rigid nailing for closed physis and early weight bearing can be done. So summary is, as Saurabh said, the indications for operative and non-operative both are clear. Age of the child, weight of the child, fibular fracture, displacement. These 4 factors will help you guiding. So if you have 4 factors positive, it will go more in terms of your operative treatment. If you have 2 factors, so basically then it comes to a surgeon decision making, surgeon's choice. But all suppose it has a fracture displacement more than 50%, you have a fibular fracture, age of the child is more than 10 years, weight of the child is on 50 kgs. Go for X-fix or go for a submuscular plating, depending on your choice. So operative intervention rarely needed. Hardly, as Saurabh said, 98% do well with conservative management, hardly 5% needed. There are clear indications, so there is no room for confusion and debate. And the external fixation and flexible and common options for surgical management, and rare cases, plate and rigid nail can be used.
Thank you. Anybody having any question regarding the both bone leg fractures treatment? Whether to go for conservative or operative?
I think both of you teamed up initially only, right? Both of you are from the same institute.
Absolutely zero, sir. It's an absolute zero.
Both of you decided कि boss तुम ये बोलना मैं ये बोलूँगा, right? So I think wonderful this thing harmony between the two speakers. The only thing which I think very interesting is wedging of the cast, right? So can you just tell us a bit of the tips and tricks, because it's quite difficult to do, right?
Yes.
Based on the X-ray and where you want to make the cut, whether it is going to be open wedge or closed wedge. And I would also want the senior people to give some opinion about cast wedging.
So when we think of doing a wedging, the level of the cut that we make in the cast is at the level of the fracture site. Now, how much of the wedge we need to open up? It is determined with the post-reduction X-ray. And we look at the angulation at the fracture site. And in the orthogonal plane, we have to make the cut and do a correction based on the measurement from the X-ray. Thirdly, a closing wedge in the cast is absolutely not recommended these days, and only an open wedge wedging of the cast is recommended, because we don't want to impinge on the soft tissues and cause further problems for the patient. And when we do an open wedge correction of the cast, we also gain length of the bone. So any collapse of the fracture also is improved. So these are the things. And also, even though AO promotes all types of fixations in so many types of fractures, when you go to the AO's website and the guidelines, they have a section where they have shown how you have to do a cast wedge.
You have a two-plane deformity, right? Some degree of coronal plane deformity and some degree of sagittal plane deformity. So how do you plan your open wedge?
So it's absolutely similar to how we do a surgical planning. We have to get the oblique plane, trace out in which oblique plane the deformity is occurring, and the wedge has to be opened in that plane.
One more additional comment regarding this. So right now there are available blocks similar to what you do for your HTO. There are blocks available for performing your open wedge wedging. So you can initially make out the plan, but ideally it will be good if you take the patient to the OR under a CR image intensifier, no anesthesia, CR image intensifier. You make the cut. You can then wedge, fit in the wedge. Have a look at the alignment. If you have gained the alignment what you are looking for, you just wrap around another cast. The wedges are now available, ready-made.
Wedges also provide extra stability.
Yes, exactly.
Sitting in between the blocks.
So that are keeping the cast distracted, and then you wrap around it further bandage over that cast.
I think your wedge, you have to calculate the effect.
Yes.
Wherever is the effect, that should be the open wedge.
Yes.
From whichever area. And the degree you want to correct. Suppose you want to correct 10 degrees, you take 10 millimeters. And we don't have the value, but we used to use the wooden sticks.
Yes.
And we used to cut them in different lengths and diameter. Wood is taken because it will prevent it from collapsing the plaster. You have to cut it half circle, otherwise it will not break. So to do a half circle, cut it, open it. If you are taking, generally you don't have the image facility in the OP, but if you have image facility, then you can check out the image facility, put a wedge and complete it. And it's a very good technique actually when you're treating.
We are getting lazy. That is why you have ready-made block preparations. You can very well prepare it with a transfer BOP bandage also of same width, and you can make it to your liking. You don't have to wait that somebody is going to bring that block, isn't it? And you can correct the wedges you can make on interlateral, post-lateral, whatever. Make an open wedge as Dr. Rehan was asking to blend deformities. You have all the flexibilities of doing it angle-lateral, or making it acromedial and then opening it that way. You are opening anterior more, medial less. So that comes with the experience. Actually, close wedge, as he has said, is not in.
If you consider, I always consider it wedging is like putting a hinge in Illusorum. Yes. So in Illusorum, when we do, those who are doing like the base and those who are doing Illusorum, they must be knowing how to correct the oblique line deformities, finding out the angle in between, and then putting a hinge at that point. So similarly, the wedging is also that much important, and it's a very good technique.
I would like to one more point. One more point I would like to add that close reduction and casting, you have shown in some studies that later on revision is required, 40% or somehow redo is required, or surgery is required. Redisplacement is there in 40%. So the principle of casting is that when you primarily cast it, you have to keep the patient under observation. See for displacement. And if you find there is a displacement, you correct either by wedge correction or by redoing the cast. That is why I am saying we are getting lazy.
When you want to put it onto a PTB cast, right? So because the normal protocol is initially give a long leg cast, then at 6 weeks or something. So what are the things that you're looking at when you convert it into a PTB?
When we there are two things we look for. One is the duration itself. It has to be at least 4 weeks. So 4 to 6 weeks is the duration. Secondly, we look for signs of initial radiological union. So if there's a bridging callus that has started to form, then we can definitely go for a PTB. And secondly, the location of the fracture. So if it's a proximal third fracture, then PTB is not a very suitable method. But mid diaphyseal and distal third fractures, which are more common, definitely PTB has a very good role beyond 4 to 6 weeks because it helps in compression and it is helps in ambulation for the patient.
Okay, thank you, Dr. Saurabh, Dr. Sitanshu. So next, I would like to call Dr. Karthik for his speech on pediatric foot and ankle fractures.
So after a good discussion on tibial shaft fracture management, we are coming on to the last lecture of the day. That is pediatric ankle and foot injuries, how they are different from adults. So the learning objectives of the talk are ankle fascial injury classification and how we evaluate these cases. What are the imaging modalities that is required to diagnose and plan for treatment? So what are the general treatment principles when you will do conservative management and when you will go for surgical management? So what are transitional fractures? Tillock's fracture and triplan fractures I will touch upon. And finally, I will touch upon pediatric talus and calcaneal injury. So what is a pediatric ankle? So it ranges from distal end of the tibia and fibula from metaphysis to the epiphyseal region. It covers the pediatric ankle region. So it is the most common fascial injury in the lower limb. Overall, distal and radius is the most common fascial injury in our body, but in the lower limb, ankle fracture is the most common fascial injury. So the peak incidence is between 8 to 15 years of age. Boys are more involved than the girls because of more sports participation. In children, the collateral ligaments attached below the level of physis are stronger compared to the physis. So the weak physis link causes the physis injury rather than the strong collateral ligaments. So it may lead on to premature physical closure in 30 to 40% of the cases. The parents should be counseled for that. So one should also know what are the fracture mimics. So there can be all subtibiale or subfibulare, or it is like a Poland's hump or Kump's bump, that is the starting of the asymmetric physical closure that present on the anteromedial aspect. So whenever you are having a doubt, you take X-ray of the opposite side to compare whether it is a fracture or it is a fracture mimics. So Salter-Harris classification is a wonderful guide to help in plan the management. So yeah, we all know type 1 is transfacial separation, type 2 is metaphyseal fragment, is fascial injury, that is the cluster column fragment. Type 3 and type 4 are intra-articular fractures because the fracture line extending into the epiphysis.
and type 5 is a crush injury. So Mercer rank described the type 6 injury, that is a perichondral injury, and type 7, that is described by Ogden et al. So that is an avulsion fracture of the intraphaseal region. So this is more is specifically seen in the ankle injuries, whether it's an avulsion of medial malleus or lateral malleus. It is very specifically seen in the ankle injuries. So another classification that is similar to large Hansen classification in adults, that is Diaz and Taxon classification. Here the most common type is supination inversion. In adults, the supination and external rotation is the most common injury, but in children it is a supination inversion injury. Whether you have Salter-Harris type 1 in the fibula phaseal level or Salter-Harris type 2, type 3 or something like that in the vertical, more of a vertical fracture pattern in the medial malleus. So in the pronation and external rotation injury, you will have a type 2 Salter-Harris with a lateral fragment in the coronal plane, in the distal tibia. In the supination plantar flexion, you will have again type 2 Salter-Harris with the metaphaseal fragment in the posterior metaphaseal region. In supination external rotation, it is a spiral fracture that's run along the distal tibia metaphases. So how will you do clinical evaluation? As a routine, you will look for the skin swelling. You have to take the history, because what is the position of the foot at the time? If the parents are able to tell what is the position of foot at the time of injury, what is the direction of force, it will help in the mechanism of injury. So you should look for swelling, ecchymosis or open fractures. And as I told, compartment syndrome, although it is rare compared to adults, so you should look for 3 A's. Sometimes the displaced fragment may compress the deep peroneal nerve, may cause extensor retinaculum syndrome, causing weakness in the toe extensors or numbness in the first web space. So the ankle sprains or diagnosis of explosion in children less than 10 years should be differentiated from the subtle physeal injury, because physis is the weaker link. So imaging modalities, you have to get an ankle trauma series. AP, mortis is very, very important, and lateral use. So one should know what is Ottawa ankle rules. The child is not able to put bare weight and not able to walk 4 steps. Otherwise, the patient is having any tenderness in the medial or lateral malleus tips. Then it mandates the need for taking an X-ray. So in the radiographic appearance, you have to look for tibial incisura, tibial clear space, medial clear space, because the medial clear space may be up to 6 to 8 mm in children. So always you compare with the opposite side, because more than 4 mm is abnormal in adults, but in children it can be up to 6 to 8 mm. So the CT scan. So in pediatric ankle fractures, especially in the adolescent age group, transitional fractures or triplant fractures, you should have a low threshold for getting CT. MRI has only limited role. You have to look at if there is a doubtful physeal injury, or if you want to look at any ligaments if you want to see, or any osteochondral fragments. Only in those cases you can have a role for MRI. So what are the general treatment principles? The main goal is the alignment, physeal reduction and alignment, and the articular congruity. So the undisplaced fractures or displaced fractures after close reduction can be managed very well with conservative treatment. Intra-articular fractures, articular step or displacement less than 2 mm is acceptable. If it is more than 2 mm, you have to reduce and fix it. So we are fond of using arthrogram pediatric orthopedic surgeons. So sometimes you can do close reduction and can confirm the articular congruity by using arthrogram itself. If you are not used to arthrogram, you can go for mini open incision, and so you have to look up the joint congruity. That is very, very important. The joint should be reduced. So coming on to Salter-Harris type 1 injuries, it forms 15% of all distal tibial physeal injuries. Once you reduce, if it is stable, you can apply directly cast. If it is unstable, you can fix with smooth K-wires. So Salter-Harris type 2 injuries, this is a very common injuries, forms 32 for 50% of 58% of injuries. If the post-reduction gap is more than 3 mm, there is a high rates of premature physeal closure. So this is very important. And in follow-up, about 40% might have premature physeal closure. So the parents should be counseled for the same. So type 3 and type 4, as I already told, it is an intra-articular fractures because the fracture line passing through the epiphysis into the joint. So either using arthrogram assisted or mini open technique, you have to reduce and fix it. So this slide is very, very important because you should know the sequence of distal tibial physeal closure. So the physeal closure starts from the anteromedial aspect. It goes to the medial, then it goes to the posterior aspect. Last is the anterolateral aspect, is the last one to close. So that's why you will get the Tilloch's fracture, because anterolateral aspect of the tibia is the last one to close. So what are transitional fractures? Because the injury occurring to the transition from a child to adolescent age group due to the asymmetrical closure of the distal tibial phases. So Tilloch's fracture is an intra-articular fracture. It is actually an avulsion of the antero-inferior tibiofibular ligament. Triplant fractures, it can be either extra-articular or intra-articular. The mechanism here is the supination and external rotation. So juvenile Tilloch's fracture, actually, this is Paul Tilloch from France. he described his fracture. But in the initial, he didn't describe whether he was describing the adult or pediatrics because there is no mention on the original paper. So that's why some people used to call it as a juvenile Tellox fracture. So as I already told, it is an avulsion fracture of the anterolateral tibial epiphysis due to the avulsion of anteroinferior tibiofibular ligament. It is a biplane injury. This Salter Harris type 3 injury. So sometimes you may miss this injury in the standard AP view. So Mortis view is very, very useful. Otherwise, CT scan if required. Sometimes if you are doubt, suspect, you should have a low threshold to take for CT scan. So if the articular step is less than 2 mm, you can manage conservatively with Benoni cast. If it is a displaced fracture, you have to fix it. The reduction can be joystick assisted or mini open again or orthogram assisted. So the most important thing is the direction of the screw, because you have to put screw in the lateral to medial direction and also in the sagittal plane from the anterior to posterior direction. So the CT scan will help very much helpful in identifying the plane of the fracture line. That can very much help in planning the direction of the screw also. If you put screw perpendicular to the fracture line, you will get a good compression. Outcomes are usually very good. So what are triplane fractures? Because the fracture line passing through the 3 different planes. That is why it is called triplane fractures. So you can see the CT scan here. In the epiphyseal fracture is in the coronal section, that is in the A figure. The metaphyseal fracture is in the sagittal plane, that is C and D, and transverse plane through the physis. So the fracture line passing through the 3 planes. That's why it's called triplane fracture. It can be 2-part triplane, 3-part triplane, or 4-part triplane. So most of these fractures are intraarticular fractures. So you have to take CT scan and you have to plan surgery accordingly. You have to look at the fracture pattern, and most of the time it needs open reduction or orthogram assisted reduction, because all intraarticular fractures you need to achieve the articular congruity or gap less than 2 mm. This is a 2-part triplane fractures. It can be lateral or medial. Lateral is the most common, and coronal fragment in the posterolateral aspect is the most common type. This is a 3-part, and another one is a 4-part fractures. In all these fractures, CT scan is mandatory, and you should have a less threshold to take a CT scan for planning. So the primary aim is again restore the articular congruity with no step or gap that is less than 2 mm. The factors that need to be evaluated in assessments are whether the fracture is intraarticular or extraarticular. Tellox fracture is always intraarticular, but in triplane it can be intraarticular or extraarticular. So what is the article? If it is intraarticular, what is the articular step off? So this is a 13-year-old boy having triplane fractures. We did a CT and the fracture gap is more than 3 mm. So you go for open reduction by using screws. That is one is the intra-epiphyseal screw and another is the metaphyseal screw without crossing or damaging the physis. So this is a treatment algorithm proposed by Dr. Venkat et al. From Ganga Hospital. So you have to take X-ray or trauma series of X-ray. If you are having any fracture seen, then you have to classify according to the Salter Harris. So Salter Harris type 1 and type 2, if it is undisplaced or stable after close reduction, you can manage conservatively with the Benoni cast. If it is unstable after close reduction, you can put smooth K-waves. If it is a type 3 and type 4, it is again intraarticular fractures. So again, the articular congruity is important. So if the gap is less than 2 mm, you can manage conservatively. If it is more than 2 mm, you have to fix it. So the transitional fractures, you have to go for CT scan. Again, the articular fracture, articular displacement less than 2 mm, you go for conservative management. If it is more than 2 mm, you have to go for fixation, surgical fixation. So next, I am coming on to the pediatric talus fracture. Pediatric talus and calcaneal fractures are very rare compared to adults. The incidence is 0.08 to 0.1, something like that. The mechanism is axial load on dorsiflex foot. Pediatric neck fracture is the most common. So AV as similar to adults, AVN is the most common complication following a pediatric neck fractures. Undisplaced fractures, you can apply cast immobilization from 6 to 8 weeks. Displaced fractures needs fixation. This is a case of a 12-year-old boy having talus and middle malleus fracture. So this is actually a fracture of talar neck along with the body fracture. So this is a soft tissue condition, because in foot and ankle injuries, the soft tissue condition is very, very important to plan for surgical intervention. So we go for dual approach, anteromedial and anterolateral approach. So this is a CT scan. You can see some fracture seen on the anterolateral and anterior aspect of the anterior lip of the distal tibia also. So we fixed using tension band wiring for medial malleus and Herbert screw for talus fracture through anterolateral and anteromedial fractures. And since the medial malleus is already fractured, it makes our job very easier. So this is a follow after 1.5 years. Can anyone tell what is Hawkins sign? Any resident from the group? Any junior resident can tell what is a Hawkins sign? No knows? Huh? So what it signifies? Is avian? It shows avian? No. So again, you are right. It is a radiolucency on the subchondral bone. If the sign is present, it is a good sign. It shows that the vascular is established. It is not avian. If there is a radio dense, then it is a avian. Okay. Hawkins sign shows that the blood flow is intact. Radiolucency on the subchondral region, it shows that the blood flow is intact. It's not avian. So coming on to the pediatric calcaneal fractures, it is also rare compared to the others. It is 0.05%. So the most of the time it is a fall from height. So you have to rule out the spine injury also. Most of the time it can be bilateral calcaneal fracture with spine injury. So you must rule out spine injuries. So why it is very less? Because of the large cartilaginous component, it may be resilient to trauma. If it is a more osseous, it may get fractured. If it is more cartilaginous, it may get less injury. Say again, clinical evaluation, you have to look at the soft tissue condition, what is the complaint, and you have to rule out spine injuries, open fractures, blisters, swelling, something like that. And this is a case example of 13-year-old boy having a depressed calcaneal fractures, intra-articular depressed calcaneal fractures. You have to draw the angle of Gizen and Bowler's angle. Okay, so this is altered here. So you have to elevate the posterior facet to bring back the angle of Gizen and Bowler's angle because it is an intra-articular displaced calcaneal fracture. So most of the time you can achieve using percutaneous methods. There is no need to do extensive lateral approach. So you had done percutaneous approach, sinus toss approach, you can use that. And if you fix with KOS. This is a follow-up showing excellent outcome. And you can look at the axial view. There is no heel, valgus or varus. But some cases may go into subtalar orthosis later on. That is not in our hand. This is another case of you can fix the sustentacolum tali fracture, the sustentacolum tali fragment, and maintain the Bowler's angle by elevating the posterior facet. So most of the time you can achieve using minimally invasive surgical approach. There is no need for extensive approach in pediatric cases. So most of the calcaneal fractures can be managed non-operative by 4 to 6 weeks of Biloni cast. Only the displaced intra-articular calcaneal fractures in the adolescent age group needs some fixation. So take-home message is pediatric ankle fractures are common and Salter-Harris classification is a very good system to guide the management. Transitional fractures form separate groups in the adolescent group because due to the asymmetrical closure of the physis. So you should have a less threshold to get the CT scan. Articular congruity and radius and the displacement should be less than 2 mm is the goal. Premature physical closure can occur up to 40% and parents should be counseled for the same. Pediatric talus and calcaneal fractures are rare compared to adults and most can be managed conservatively using the cast and non-weight bearing protocol. Thank you. Any questions?
All injuries around the ankle joint. Excellent presentation, Dr. Karthik. Any question from the audience? Dr. Karthik, I have one query that regarding the ankle injuries. If suppose there is no as such quick fracture obvious on the ankle X-ray. So what you suggest is X-ray okay with you, or depending on the clinical scenario, you go for higher imaging in one instant, like just after X-ray, go for CT or.
No, I always correlated radiology with clinical findings.
Okay.
So if there's any tenderness, swelling, and in X-ray, if I'm not able to find anything abnormal, I will go for CT scan. Okay. Look and suppose where is the tenderness.
And what are the possible indications of MRI in ankle injury?
That's what I'm telling you, sir. Sometimes you will have undisplaced physial injuries. That can be picked up with the MRI, and sometimes osteochondral fragments.
So, in case of the undisplaced physial injuries, what are those patients? How you suspect actually, just for the residents and all those?
So I had seen one patient.
When they suspect if there is a physial injury.
I had seen one patient of Salter-Harris type 1 in distal fibula fracture. It was undisplaced. So it has tenderness directly over, just above 1 centimeter above the tip of lateral malleus. There was a tenderness. Clinically, it was a very suspicious fracture, but X-ray is normal. So I suspect Salter-Harris type 1 fracture injury. So I went for
because if Dice and Tarzan classification, if we go by that, then physial injuries, no doubt that occur in distal fibula. So for every case, you go for MRI, or just X-ray is more than enough in that case?
So not for every case, it's
Just
not
for fibula,
recommended. Not for every case.
Yeah.
if required clinically, if required, you can go for it. Otherwise, you can just immobilize with the. So you should clinically correlate. Where is the tenderness? If I'm telling you, if it's a distal fibula, so it may be saltarized type 1, you can manage conservative.
Yeah,
but if it is the anterior joint line tenderness or it is the anterior aspect of the distal tibia, then you have to go for further intervention. It can be osteochondral fragment or it can be again avulsion like Pillows fracture or something like that.
But in that case, you go for CT first.
CT first.
And then if required, then go for MRI.
Yes. MRI has limited role.
Exactly. And do you have any experience about the ligament injuries in pediatric population around the ankle joint? Because literature says no doubt it's.
So in adolescents, yeah, not less than 10 years of age, but sometimes in around 13 years or 14 years,
Because
I do
as
have.
as we speak about the transition fractures in
Yeah,
that age group.
yeah, yeah. So at that age group I had, but I don't go for MRI. Just I immobilize with the cast. It heals.
For how much duration? Means if you are
3
suspecting
weeks.
ligament injury.
3 weeks.
3 weeks and then mobilize. Weight bearing or just.
So 3 weeks. If I applied a lightweight cast, I will start weight bearing after 5 days.
So in one or two patients of mine, basically, when the parents are much poor, and I have noticed that even after the removal of the cast, then the patient do have some pain during walking. So now what I started doing, maybe because of corporate practice or what you can say, that now after 3 weeks of class, I move into the air boot.
Yeah.
And then continue with 2 to 3 weeks with the air boot, and when the child is comfortable, then continue with that.
I think MRI has a role in isolated fibula fractures, distal ones, where you are suspecting a deltoid ligament injury, because the bone on the medial side has not given way, so there are more chances of ligament injury on the medial side in isolated fibula fractures. So what I do is to do a stress test and see. You can get an X-ray also. People put in under the influence of gravity and take a X-ray and see how much opening is there on the medial side. And if that is indicative of a ligament injury, then
Yeah, in that case, you will have a medial tenderness also.
Yeah.
So clinically, if there is, then I will correlate it. So always clinical correlation. If you doubt X-ray is normal, then you go for further.
Any other question?
Are there any other questions? So I think we should wrap up this session.
Thank you, Dr. Tasne. Now, thank you, Chairperson, sir. Now I call Dr. Sanjay Gupta, sir. Please felicitate our speaker of this last session. So I will call to Dr. Rehanul Lagbos to take a memento. Thank you, sir. Now there is call for Dr. Saurabh Sinha. Thank you, sir. Thank you, sir. Now the last part of this session, I call to Dr. Anurag to give the nitty-gritty of the MS and EMT examinations to show. All the faculties, all the delegates will moderate this session. All the faculty will be moderation.
I want to request the postgraduate students, because this is meant primarily for you, please come to the front and be active in discussion. Dr. Anurag has prepared very painstakingly the common scenarios which you are going to get in your exam.